I can see more and more people.
You may speak up.
Okay. Shall I wait all people to join so we start?
It is 92.
Yeah, but the number is increasing. It's 96.
Yes, yeah, let's wait a few seconds or a few minutes, okay?
Yeah, let's wait 2-3 minutes more, huh?
Yeah, okay.
Yeah. Anyway, I don't think the introduction will take more than 10 minutes, so we can start at 9.
Yes. Yes, 100. Okay.
Okay, I think we can start with the introduction, huh?
Yeah.
Okay.
Okay. So once again, welcome to the 5th Bosnian Turkish Cytopathology School. For the first time virtual, unfortunately. This is the one that was scheduled actually for last year, but it was canceled for obvious reasons last year. But this year we decided to run it online, and we are very happy to announce the 5th traditional School of Cytopathology with our Turkish colleagues. And this year the topics are thyroid and lung cytopathology, with some pathology inputs as well. And this is the second time actually we run this topic. We got it for the second one that was held in 2017, and we are also happy to have new faculties joining to this traditional school. Some old ones are also with us. We are very happy for that. This year we have 8 distinguished speakers, mainly from Turkey, but 2 also from Bosnia, clinicians, 1 radiologist and 1 nuclear medicine specialist. And a full day of thyroid and lung cytopathology today. I hope you will enjoy the sessions during this long course. I wish to acknowledge a great efforts of our Turkish colleagues to make this school possible. Special thanks goes to the president of the Turkish Cytopathology Society, Dr. Sevgin. Of course, special thanks goes also to the previous president, Dr. Deniz. And of course, our efforts, all the efforts and all the encouragement and the power that comes from our great friend and founder and our honorary president, Professor Sitki Tuzlali, who actually was the founder and the establisher of this important event for the Bosnian pathology and Bosnian cytopathology. And of course, our thanks goes to all the speakers that will give you the all the updates and the news in the lung and thyroid cytopathology. Once again, on behalf of local organizers from Bosnia, I wish to acknowledge all the efforts from our Turkish colleagues and certainly from our local Bosnian speakers. And I hope that this impressive number of attendees today will enjoy this great event. Once again, I wish to thank you everybody for participating and making this important event possible. So now I will give words to my Turkish colleagues, my Turkish friends, first with our honorary president and our founder, Professor Sitki Tuzlali. Thank you.
Thank you very much, dear friend Semir. And I am very much honored to be with you again. And dear online guests, we began a series of cytology meetings with our Bosnian colleagues a couple of years ago. And in the first meeting, we hold a general approach to cytology with all the topics. And then in the second one, thyroid, lung, pancreas, and lymph node. And in the third one, we dealt with only uterine cervix and screening programs with clinicians. And then in the fourth meeting, we hold cytopathology of the GI tract and abdomen. And now, with very distinguished speakers, we will deal with only lung and thyroid cytology with histopathological correlation. And I would like to express my gratefulness to all our friends in Bosnia, namely to Semir Renic and Faruk Skenderi and Nuria Bilalovic, and the past presidents of the Turkish Society of Cytology, Pinar Ferhat and Deniz Nart, and the new president, Dr. Sevgen Önder. And we can see that this year our meeting is transformed into a cytopathology congress with many participants. And this means that it proved its success. I hope that from now on it will be traditionalized. And now we all feel the responsibility that we must deserve this interest, this affinity. And we are all open to your feedbacks and suggestions and of this larger group. Please write any one of the organizers. We need your feedback. So I hope it will be a successful meeting, and thank to all the speakers also for their effort to be in this meeting. Thank you very much again. And now Professor Sevgen Önder will take place to say a couple of words in the name of Turkish Society of Cytopathology. Thank you.
Thank you, Dr. Tuzlalı. Good morning, everyone. On behalf of the Turkish Society of Pathology, I am delighted to welcome you to the 5th Bosnian and Turkish Cytology School. Actually, we are very happy of having been conducting this collaborative annual tutorial between two countries for the last 5 years under the auspices of Turkish division of the International Academy of Pathology, Turkish Society of Cytopathology, and Association of Basic Medical Sciences of Federation of Bosnia and Herzegovina. Actually, this year, it's a bit pity not to be able to meet face-to-face as in the previous 4 years because of this COVID pandemic. However, thanks to communication technology, it allowed us to reach more people this year. And our traditional and humble workshop, fortunately, seems to become an international event with contributions from multiple countries. As far as I saw, we have more than 400 participants from 25 countries, which is really exciting and also encouraging us to think about to conduct future events with expanded scientific coverage during maybe longer dates. This year, we reserved our scientific program to recent advances in thyroid and lung cytopathology, which are two hot topics in our daily cytopathology practice. And with this, I'd like to thank the organizers of this meeting from both countries, Dr. Bilalovic, Vranic, and Skenderi from Bosnia, and Dr. Tuzlalı and Dr. Nat from Turkey. I'd like to thank also to our Turkish and Bosnian speakers for accepting to be a part of this tutorial and for sharing their valuable experiences with us. And finally, I'd like to thank you, all participants, for sparing your time and being with us this morning. I wish you enjoy and get the most benefit from our course. So, presenting you my most sincere regards, I'm now turning again the microphone over Dr. Semir Vranic. Thank you.
Thank you, Dr. Sevgin and Dr. Sitki for brief introductions to this meeting. We have a couple of minutes back before we start the first session, and I can see that the number of participants is slightly increasing, and I hope more and more people will join in the coming minutes. So if you agree, let's wait 2-3 minutes more before we start the very first session at 9 a.m. I also acknowledge the participants that come from different parts of the world, so the time may be really different. So it's probably not only good morning, but also good afternoon, depending on where you are joining us to this this wonderful meeting. So I wish once again welcome to everybody to this traditional cytopathology school. Thank you. So let's wait 2-3 minutes more before we start the first session with
Yes.
Lang.
We may inform the participants that there are participations from all over the world, I think.
Yeah, that's why it's not only good morning, so it's good afternoon.
Norway to United States, so but mostly the Balkanian region and neighboring countries, but from many parts of the world, including Pakistan also. There are many attendees from.
So time difference in Pakistan is probably 5-6 hours from here.
I think we should say that after every session there will be a vote for the session.
Yes, they will. Yeah, the participants will be able to assess each of the sessions, and of course, it's as Dr. Sitki already said, it's very important to us to improve this course. So your feedback is really appreciated. Also, you can, for the participants, you can type your questions, your comments in the chat box, and they will be taken by the chairmen and also by speakers who can follow the questions and comments that come in the chat box while the sessions go. So all the questions, inquiries, comments can be briefly discussed after each session. This is just for general information to the participants. So your comments and your questions are definitely very welcome. So please type your questions in the chat box. Thank you. Okay, I think it's now 9 a.m. Central European time, and I wish once again welcome to everybody to the 5th Bosnian Turkish Cytopathology School, and I'm very happy and pleased to introduce the first speaker. The first speaker is Dr. Serpil Dizbey Sak. She's coming from she actually graduated from the Ankara University School of Medicine in '85, completed her training in pathology in '91. She served as a president of Federation of Turkish Pathology Societies from 2016 through 2018, and now is the member of its executive board of the Federation of Turkish Pathology Societies. She has interest in different fields within pathology, including the thyroid, breast, lung, thoracic, and molecular pathology. So Dr. Serpil will talk about updates on histopathology of lung cancer, including WHO classification of lung tumor. So I'm very pleased to introduce the very first session now. Thank you.
Thank you very much. Thank you for the invitation.
I'm Dr. Serpil Sak from Ankara, and I'm here for the first lecture. Let me share my presentation first. Okay. No. Today I'm going to talk about histopathology of lung cancer. Originally, this would be my topic, histopathology of lung cancer classification 2015 and beyond. But then I saw that the beyond is here now, which is the latest classification, and I'm going to talk about that one. I have no relevant conflict of interest to declare for this talk or the next one. And here is my email address if you're interested. I'll show some photographs in my presentations, and all photographs used in this presentation labeled by the cover photo of the WHO Blue Book are the content of the new beta version of the Blue Book and downloaded from the website. And I will also show you some pictures from some literature, and the literature will be shown. And all the rest are my photographs. The tumors of the lung, the epithelial part of the tumors of the lung, I mean, has some benign tumors. I'm not going to go into details in this one. I will just talk on this one and slightly on this one too. And my presentation will be largely on precursor glandular lesions, adenocarcinomas, squamous cell carcinomas and precursors, and large cell carcinoma, adenosquamous carcinoma, and sarcomatoid carcinomas. And of course, I will not go without mentioning the lung neuroendocrine neoplasms. And I will only shortly talk on hyalinizing clear cell carcinoma of the lung and SMARCA4 deficient undifferentiated tumor. So lung cancer is the most common cause of cancer death worldwide, we know, but its incidence and mortality began to decline progressively, particularly in younger males and females. It's a major cause of cancer incidence and death. I'm going to talk shortly on adenocarcinoma. Adenocarcinoma is a carcinoma with glandular differentiation and or mucin production and or positivity of adenocarcinoma immunohistochemical markers. In lung context, these are TTF1 and napsin A. We name the pulmonary adenocarcinomas according to the predominant pattern, that is lipidic, acinar, papillary, micropapillary, or solid patterns. But most adenocarcinomas have more than one pattern actually, and in resection specimens, each pattern should be estimated and recording in 5 to 10% increments, totaling 100%. This is a lipidic pattern. Look at the tumor cells. Tumor cells are lining the alveoli, but they are not obstructing the normal pulmonary architecture. This pattern is accepted as an in situ component in lung adenocarcinomas. Acinar pattern is just the organization of tumor cells around a central lumen. But cribriform pattern, which is back-to-back fused glands without intervening stroma, this is also accepted as a pattern of acinar adenocarcinoma, but this one is associated with a poorer prognosis. This is a picture from the Blue Book. And there is papillary pattern. Papillary pattern is basically the cells are around the branching fibrovascular cores, like here in this photograph. In micropapillary pattern, cells grow in papillary tufts without fibrovascular cores, or cells form lace-like narrow cell stacks. If an acinar structure is filled with micropapillary structures, then we shouldn't call it micropapillary acinar, but we have to call it micropapillary. This is very important in recognizing the patterns. So here's the papillary pattern with fibrovascular stalk, and micropapillary pattern, on the other hand, either makes cells growing in papillary tufts without fibrovascular cores or lace-like narrow stacks. Here is the schematization, and maybe it's easier to understand this way. Solid pattern, on the other hand, shows tumor cells arranged in sheets, lacking any recognizable pattern. In this kind of carcinoma, expression of a pneumocyte marker, namely TTF1 and or napsin A, is necessary with negative P40. Or histochemical demonstration of intracellular mucin is also enough to call this carcinoma as an adenocarcinoma. Here is another example. Here are cells doing nothing but cell nests, but they are showing mucin expression, so they are adenocarcinomas. We have another invasive adenocarcinoma, which is the mucinous adenocarcinoma. This is a lung adenocarcinoma with tumor cells showing goblet cell or columnar cell morphology with abundant intracytoplasmic mucin. And smoking is very much in accordance with this adenocarcinoma type, and KRAS mutations are common. These tumors are poorly circumscribed lesions with soft and gelatinous mucoid appearance. It may be difficult to appreciate them like other adenocarcinomas. Goblet and or columnar cell morphology with abundant intracytoplasmic mucin and small basally oriented nuclei are typical. This type of adenocarcinoma shows cytokeratin 7 expression, but also may show co-expression of the markers that we know as the colonic markers, and they're usually negative for TTF1. So sometimes the differentiation of a colonic adenocarcinoma is different, may be difficult in some cases of invasive mucinous adenocarcinoma. Before finishing adenocarcinomas, I have to tell about spread through air spaces, which is STAS. That means that tumor cells are there within the air spaces beyond the edge of the main tumor. This is the original definition. In original proposal, at least one air space beyond the tumor edge was recommended, but we have to exclude artifacts. But this is very important because it's prognostic in all major histologic types, especially in limited resection. We should not forget that it's just a manifestation of tumor spread like lymphatic invasion or perineural invasion, so it's not used for percentage of patterns or tumor size for staging purposes. This is a photograph from the original paper. It can be micropapillary structures that are going in the airways, like here, or it may be solid nests of tumor going beyond the edge of the tumor, or there may be just single cells which are going through the air spaces. We have to differentiate it from artificial spread, but I'm not going into details. We have a concept of adenocarcinoma in situ. It should be a small tumor. It should be pure lipidic. No stromal, vascular, or pleural invasion is accepted in this category, and we shouldn't see any pattern of invasive adenocarcinomas. That means that the patterns other than the lipidic adenocarcinoma pattern should not be seen in this kind of tumor. And no STAS also. In this examples, we are seeing one non-mucinous, and we are seeing a mucinous adenocarcinoma in situ from the new WHO Blue Book. It's very important that the tumor should be completely sampled and correlated with the architecture, because if solid component is present on CT or gross examination, the lesions should be evaluated with with care, because these areas often correlates with an invasive component. And then we have minimally invasive adenocarcinoma, MIA. It's also a small tumor. It's a solitary adenocarcinoma, predominantly lipidic. It can have an invasive component, but this invasive component has to be small, smaller than 5 millimeter. What is invasive component? Invasive component is any histological subtype other than the lipidic pattern or tumor cells infiltrating myofibroblastic stroma. And also, minimally invasive adenocarcinoma diagnosis is excluded if the tumor invades lymphatic, blood vessels, pleura, or contains tumor necrosis or makes STAS. Here is an example from the blue book. Here we are seeing that the tumor is going in a lipidic fashion, just lining the alveoli. But in here, we are seeing that we have a different area. And in this different area, we are seeing acini or small nests we could call a solid pattern. And this makes this tumor a minimally invasive adenocarcinoma. Of course, this area should be less than 5 millimeters. And a new concept in adenocarcinoma is the grading of adenocarcinomas. In this new classification, a grading is proposed, and we should use it. Grade 1, which is well differentiated, is a lipidic predominant adenocarcinoma with no or less than 20% of high-grade patterns. The grade 2, which is the moderately differentiated, is an acinar or papillary predominant adenocarcinoma with no or less than 20% of high-grade patterns. And the grade 3, which is the poorly differentiated, is any tumor with 20% or more of high-grade patterns. Then, what is a high-grade pattern? A high-grade pattern is a solid pattern, or micropapillary pattern, or cribriform pattern, or the complex glandular patterns, that means fused glands or single cells infiltrating a desmoplastic stroma. These are the complex glandular patterns. In adenocarcinoma, we have TDIAP positivity, but not in all tumors. It's more prominent in lipidic papillary patterns, but it's less prominent in solid areas. And we must not forget, other tumors can also be TDIAP positive. For example, small cell carcinoma and even non-pulmonary tumors. Napsin is another pulmonary marker, adenocarcinoma marker, and in an adenocarcinoma, squamous markers are negative. But we can see some focal staining of P63 in some adenocarcinomas. The macroscopic findings in an adenocarcinoma are very much dependent on the pattern of adenocarcinoma. Non-lipidic patterns reflect as a solid tumor, like here. But in lipidic patterns, we have different macroscopic views. For example, here is the bisected tumor surface of 3 tumoral areas. One is an invasive adenocarcinoma, which is easy to appreciate. But here we have another adenocarcinoma, which is lipidic and more difficult to see. And here also we have another one, which is not a carcinoma, but it's atypical adenomatous hyperplasia. So the invasive patterns are easier to appreciate, but the non-invasive patterns are more difficult to see macroscopically. We have a lot of mutations in adenocarcinoma that derives the tumor, that makes it the tumor. And KRAS mutations and EGFR mutations are the most prominent ones in the driver mutations, but we also have ALK mutations and BRAF mutations and all the other mutations. And it's very interesting that the mutation in East Asia and US and Europe are quite different in proportions. For example, EGFR mutations are the most prominent mutations in East Asia. On the other hand, KRAS mutations are the most prominent mutations in USA and Europe. What about Turkey, for example? This is a study, an old study when we did Sanger sequencing. In this study, we examined and we saw that in the adenocarcinomas, the Turkish adenocarcinomas had 17% EGFR mutations. And this is in recent series, and in this recent series by MGS and immunohistochemistry and FISH, we saw that EGFR mutations are about 13%, BRAF mutations are about 4%, and KRAS mutations are 23%. And also we have ALK and ROS rearrangements. The numbers here are in between Europe and East Asia, more like European numbers, but KRAS and EGFR numbers are somewhere in between. So maybe we are lying in between of these two geographical locations, and maybe our genetic pool also lies somewhere in between. But we don't know. This is a special kind of adenocarcinoma, which is colloid adenocarcinoma, which presents itself by extensive pools of extracellular mucin, which distends alveolar spaces and destroy alveolar walls. And this also shows some colonic markers, and metastatic tumors should be ruled out in this type of adenocarcinoma of the lung. Before going to squamous cell carcinoma, I want to go to a special tumor, a benign tumor actually, which can present some problems to you in real life, because I saw it more than once that to the unexperienced pathologist, this tumor can present itself as a lung carcinoma, especially on frozen sections, and create problems. So I will just go on this just for 1 minute. This is a tumor. It's a very well circumscribed tumor, I may say, and it's making some papillae. This papillae may make you think that this is an adenocarcinoma, but this is not. This have more features that that gives you hint. For example, this sclerosing areas here is very important to recognize. These papillary structures, if you look at them carefully, the cores of the papillae are not fibrovascular cores. There is another type of cell in the cores, which is going also in this solid areas. This is not also a solid pattern of adenocarcinoma. This is a second type of cell, and this is sclerosing pneumocytoma, and this could the clinician can think that this is an adenocarcinoma, and in a small biopsy you can think that this is an adenocarcinoma. Please don't forget this. This diagnosis, it can sometimes create problems to the unexperienced pathologist. This is a rare tumor, but this is the most frequent of the rare tumors of the lung. I think that. Now we're going on squamous cell carcinoma. Okay. Let's go to the squamous cell carcinoma. It's usually a central tumor obstructing the lumen of the bronchus, like here. Sometimes it's invading parenchyma and lymph nodes, and it invades through the bronchus to the parenchyma. But in some cases, rarely, it's a superficial tumor spreading without invasion to the bronchi. In other cases, it has peripheric location. In larger tumors, you also see cystic degeneration. In some cases, tumor is actually smaller than the radiologic mass because it creates pneumonia around the tumor cells, the actual tumor related to the obstruction of the bronchus. Squamous cell carcinoma can be keratinizing or non-keratinizing. The keratinizing one is a tumor that is easily identified as squamous, but the non-keratinizing type needs immunohistochemical examination, immunohistochemical demonstration of squamous markers, which are P40, P63, and cytokeratin 5-6. And adenocarcinoma markers should be negative. We have a variant of this tumor, which is the basaloid carcinoma. But before, I must say that in situ component or squamous dysplasia may be seen in many cases in primary squamous cell carcinoma of the lung, like here. We have to see keratinization. We can have prominent or single cell keratinization, and we can see that the intracellular junctions we can see here very nicely. But in some cases, we cannot see the clues to the squamous cell carcinoma, like this case or this case. We don't see any keratinization anywhere. This tumor can be anything. Its Mu-Karman is negative, but P53, P63 is positive, and TTF1 is negative. Also, cytokeratin 5-6 is positive in this case. And this is a squamous cell carcinoma, non-keratinizing type. In the differential diagnosis of squamous cell carcinoma, sometimes real tumoral glands and versus captured alveoli lined by type 2 pneumocytes are confused, and adenosquamous carcinoma can come in the differential diagnosis, and metastasis from urothelial carcinoma, thymic carcinoma, and metastatic squamous cell carcinoma from other locations can have a difficulty in diagnosing primary squamous cell carcinoma, but most of them can be we can reach the diagnosis by immunohistochemistry or by the clinical findings. Now I'm going to tell you that there are some entities that we can confuse, which is the squamous cell carcinoma non-keratinizing type, which is TTF1 negative and squamous markers positive. Solid type adenocarcinoma, which is TTF1 positive and squamous markers negative. Large cell carcinoma, null type, which does not show any of these two types of markers. And large cell neuroendocrine carcinoma, we have to have neuroendocrine morphology and neuroendocrine marker positivity. In the basaloid squamous cell carcinoma, which is a poorly differentiated tumor, and there is no typical squamous morphology, but it has still the typical squamous cell carcinoma profile, and the neuroendocrine markers are generally negative. Here is a carcinoma. Here you are seeing a peripheral palisating of the cells, some necrosis. Here, some more palisating, no squamous differentiation here. And or here, it just looks something more primitive. Maybe you can even think of small cell carcinoma here. This is a biopsy of a different case. Here, the same. But this is P63, which is a squamous cell marker, and this is a basaloid variant of squamous cell carcinoma, and the neuroendocrine markers were negative in this case. In the differential diagnosis of squamous cell carcinoma basaloid variant, neuroendocrine carcinomas can come into the differential diagnosis, adenoid cystic carcinoma, not carcinoma, and also in some cases even adenocarcinoma would be in the differential diagnosis. In squamous cell carcinoma, the mutational burden is high, and we can see copy number variations and mutations in many genes. And for targeted therapy, squamous cell carcinoma usually is not a tumor to be treated with targeted therapy because these EGFR mutations, ALK rearrangements are rare, but they can occur, we must know that. And we should consider their presence in young and never smoking patients, especially in patients with a history of lung adenocarcinoma with one of these genetic alterations. And there are some special types of squamous cell carcinoma. Lymphoepithelial carcinoma, for example, is in this category. It's a poorly differentiated squamous cell carcinoma, mixed with variable amounts of lymphoplasmacytic infiltrate, and it's in many cases Epstein-Barr virus associated. Like here in our tumor, this is the P63, and this is the chromogenic in situ hybridization for Epstein-Barr virus EBER. There's also NUT carcinoma. NUT carcinoma is a poorly differentiated carcinoma genetically defined by the presence of nuclear protein in testis gene rearrangement. It's mainly a mediastinal tumor. It has abrupt foci of keratinization in some cases, and it may come into differential diagnosis with a squamous cell lung carcinoma, but the typical NUT protein positivity will solve the issue in many cases. Now, adenosquamous carcinoma. Adenosquamous carcinoma is a carcinoma showing components of both squamous cell carcinoma and adenocarcinoma, with each accounting for more than 10% of the tumor. This does not have a definitive diagnostic molecular finding, may harbor gene alterations that can be seen in adenocarcinomas or squamous cell carcinomas. For example, here is a case of ours. Here you're seeing in this yellow areas adenocarcinoma, acinar adenocarcinoma, but here in these areas you are seeing a keratinizing squamous cell carcinoma. In these tumors, immunohistochemistry and morphology must be correlated. For example, here we are seeing squamoid areas, and they are P40 negative, and we are seeing some adenoid areas which are TTF1 positive. So they must be correlated. In the previous example that I have shown you just a few seconds ago, in that particular adenocarcinoma, in the molecular analysis showed a very well-known EGFR mutation, and in the Sanger sequencing, and this mutation made the patient a candidate for EGFR tyrosine kinase inhibitor therapy. Now we are going to large cell carcinoma. Large cell carcinoma is a diagnosis of exclusion. It's an undifferentiated carcinoma. It used to be about 10% of lung carcinomas in the 90s, but it's quite low now because those large cell carcinomas are now solid adenocarcinomas because they are TTF1 positive, or non-keratinizing squamous cell carcinomas because that tumors are P40 positive. So it's a diagnosis of exclusion and should be used on resection specimens only. Here's a table from the new classification on how to diagnose on resection specimens or diagnosis on biopsies. As you see, there is no large cell carcinoma category in diagnosis in biopsies. We should not forget. And these are the immunohistochemical findings in different types of lung carcinomas. Now, three examples from the last version of the previous version of the WHO Blue Book. Here, look at three tumors we have. They are more or less looks the same, but one is a TTF1 positive that makes it a solid adenocarcinoma. The other is P40 positive that makes it a non-keratinizing squamous cell carcinoma. And the last one is negative for two of the markers, and this is a real large cell carcinoma now. Now, sarcomadoid carcinomas. In this category, we have three entities, but I'm just going to talk on pleomorphic sarcoma, which is a poorly differentiated non-small cell lung carcinoma, including adenocarcinoma, squamous cell carcinoma, and or large cell carcinoma, with a component containing at least 10% of spindle and or giant cells, or a carcinoma that consists entirely of spindle and or neoplastic giant cells. You can use this category only in surgical specimens again, and in surgical series, it's about 2 to 3%. This is a spindle cell carcinoma. This is a large cell carcinoma. And immunohistochemistry is helpful to highlight the different cell components in these types of tumors. In the non-small cell carcinoma components are usually pancytokeratin positive. Spindle and giant cell components are variably reactive or negative for pancytokeratins, and in some cases, multiple keratins may be needed to confirm epithelial differentiation. And other lineage markers, napsin or P40, are variably expressed depending on the direction of differentiation. In pleomorphic carcinoma, we can see all kinds of genetic events, but skipping mutations are quite special to pleomorphic carcinomas, and PD-L1 expression is very common in pleomorphic carcinomas. Here's a carcinoma of ours. Here, in this tumor, in this area, we are seeing spindle cells, whereas in this area, we are seeing adenocarcinoma, and the adenocarcinoma component is TTF1 positive, whereas the spindle cells are TTF1 negative. Let's talk about therapy targets in non-small cell carcinoma before finishing this subject. As you know, about 70% of these tumors are not operable in the diagnosis. And they are diagnosed by small biopsies or cytologies. And we cannot operate on them, so we are giving chemotherapies. But these tumors have different driver mutations, and if we can target those driver mutations, we can treat these patients. We can elongate their lifespan. The driver mutations of adenocarcinoma and squamous cell carcinoma are very different from each other. So which genes to test? Obviously, the tests we are going to do will be targeted to the mutations that have drugs to treat them. And the minimum panel of mutations should include EGFR, ALK and ROS1 genes, and the extended panel should include these genes. And it's very important, the immune checkpoint inhibitors are very important in non-small cell lung carcinoma, because there are a lot of studies of immune checkpoint inhibitors, and in the first line setting, immunotherapy is superior to cytotoxic chemotherapy in a subset of these patients, and there are combined immunotherapies and chemotherapies, and immunotherapy can now be considered to be the fifth pillar of cancer therapy. So PD-L1 expression is commonly used to predict therapy benefit, and so we have to make PD-L1 investigation in our tumors, like this tumor, which was about 100% positive for PD-L1. This will be an important therapy target. Now, passing the neuroendocrine tumors, in this category, we have small cell carcinoma, large cell neuroendocrine carcinoma, carcinoid tumor, typical and atypical, and we have a pre-invasive lesion, which is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. And we must not forget neuroendocrine proliferations less than 5 millimeters, morphologically similar to carcinoid tumors, are called tumorlets. And we have combined tumors, combined small cell carcinoma and large cell carcinoma, which is large cell or small cell carcinoma, and in addition, a combined non-small cell carcinoma component. Beginning with small cell carcinoma, which is about 15% of lung carcinomas, the patients are basically very heavy smokers. The tumor cells have scant cytoplasm, finely granular nuclear chromatin. They are small cells, nucleoli are inconspicuous, and nuclear molding is common. And in immunohistochemistry, there are keratin positive, but high molecular weight cytokeratins are negative, and neuroendocrine markers are positive. There are some emerging markers in small cell carcinoma, but they are not widely used in all institutions yet. TTF1 is positive in most of these tumors. Loss of retinoblastoma protein and P53 overexpression or null expression is also seen in small cell carcinomas. And Ki67 may be useful in small crushed biopsies because it's very, very high in small cell lung carcinoma. This is a male smoker, an old patient. These are the tumor cells, small cells with scant cytoplasm, and we can see molding here and there. And this is positive with neuroendocrine markers and TTF1. And as you see, Ki67 is quite high. This is a small cell carcinoma. This is another example, I guess, with similar immunohistochemical staining, and this is a small cell carcinoma. This is an operation specimen, which we had two different components, and in one area we had a small cell component, and in the other area we had a squamous cell carcinoma, which makes this tumor combined small cell carcinoma. And we have large cell neuroendocrine carcinoma. This is a high grade but non-small cell carcinoma with neuroendocrine morphology and high mitotic counts, and with one or more neuroendocrine markers. It's approximately 3% of resected lung carcinomas. Here is the tumor that we are seeing, a large areas of necrosis, and these are the tumor cells, and the tumor cells are showing a considerable mitotic activity, and we are seeing neuroendocrine markers, and this is a large cell neuroendocrine carcinoma. Coming to the carcinoid tumors, these are neuroendocrine malignancies with a well-differentiated organoid architecture. We have typical carcinoid, which is a carcinoid tumor with less than 2 mitosis in 2 millimeters square and do not have necrosis, whereas atypical carcinoids have either mitosis or foci of necrosis, or sometimes both. Carcinoid tumors are less than 2% of all lung malignancies, and there are no risk factors recognized for carcinoid tumor. Some cases include multiple endocrine neoplasia 1 gene mutations. Carcinoid tumors, most of them are central tumors, intrabronchial even, but some of them are peripheral tumors, like here. And diffuse idiopathic pulmonary neuroendocrine cell hyperplasia is a pre-invasive condition for carcinoid, and they have distinct epidemiological, clinical, morphological, and molecular profiles when compared to high-grade carcinomas, which tells us that these two lines are two separate tumor groups with different carcinogenetic processes. Carcinoid tumors show neuroendocrine morphology, that means organoid patterns. They can be oncocytic, clear cell, or even melanin laden. And they show small, intermediate sized polygonal or fusiform cells. And typical versus atypical carcinoid tumor distinction is very important. Mitosis should be counted in areas of highest mitotic activity. Mitosis should be counted per 2 millimeters square rather than 10 high power field nowadays. And this area could be different in various microscope models. In tumors near the cutoffs, we should count at least 3 sets of 2 millimeters square and use the mean numbers. And mitotic rate and necrosis status should be included in the pathology reports. Here is a case, a central tumor. Some of it is in the bronchus, like so, and some cells with elidal spindling. We didn't see any mitosis or necrosis in this one. And this was a typical carcinoid. Here's another one. The tumor cells are different, more epithelioid, but we saw mitotic activity in this one, more than one in 10 high power field. This was a previous case, and this was an atypical carcinoid tumor. Now we have another entity, which is a carcinoid tumor or NET with elevated mitotic counts or Ki67 proliferation index. These tumors are rare. They are morphologically atypical carcinoids, but the mitotic count is very high, exceeding 10 mitosis for 3 millimeters square, and they have very high proliferation index for a carcinoid tumor. And the genomic analysis of a few such cases supports a relationship with carcinoids rather than small cell carcinomas or large cell neuroendocrine carcinomas. But these tumors are currently classified as large cell neuroendocrine carcinomas. But we should add a note stating the presence of histological features of carcinoid tumor and document the mitotic counts and the proliferation index. Here is some major clinical pathological features of lung and neuroendocrine tumors. Sometimes large cell neuroendocrine tumor versus small cell carcinoma can be unexpectedly difficult, but in most of the time, the only differentiation is the morphology, because no reliable immunohistochemical or genetic markers exists in this distinction. I can tell you that the mitotic index is very different in the high-grade carcinomas and the carcinoids, but in advanced stage or metastatic setting, carcinoids can show an increased mitotic count and a very high Ki67 index. And diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It's a multifocal hyperplasia of pulmonary neuroendocrine cells associated with tumorlets. That's a pre-invasive condition that may develop into carcinoid tumors. When we have a pulmonary neuroendocrine tumor, we should begin with a tumor with neuroendocrine morphology. Then, if necessary, we should confirm the presence of neuroendocrine markers by immunohistochemistry. Then we should go to this area. We should think on mitosis. How many mitoses do we have? Do we have tumor necrosis? If we have, is it focal necrosis, punctate necrosis, or is it extensive necrosis? And the cellular features, what about the size? Is there a nucleolus? Is the nucleus molding or not? We should think about this. By this way of thinking, we are going to arrive the conclusion of carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, or small cell carcinoma. But the important point is that we should begin this only if the morphology is consistent, because neuroendocrine markers are positive in about 30% of adenocarcinomas and squamous cell carcinomas. So if we're going to say that this is a pulmonary neuroendocrine tumor, it should have a neuroendocrine morphology in the first place. Now I'm going to talk about some new entities in this new classification. One is ciliated muconodular papillary tumor. This is a benign peripheral lung tumor. It has bilayered bronchiolar type epithelium, and this epithelium it shows TTF1 positive cells in the luminar side. On the other hand, it shows P40 positive cells in the basal layer. And there is another entity, hyalinizing clear cell carcinoma. It's a low-grade malignant epithelial tumors. It has epithelial cells with clear or eosinophilic cytoplasm and cells within myxohyaline or sclerotic stroma. Its immune profile is a bit like squamous cell carcinoma, and I didn't see any of these tumors. Maybe if I even saw them, probably I signed out them as a weird type of squamous cell carcinoma. Probably I should have a look at them. I never saw one in lung. This is another tumor new entity, and this is SMARCA4 deficient undifferentiated tumor of the lung. This is a very high grade neoplasm of the young adults, and it shows sheets of discohesive epithelioid cells like here, and it's this SMARCA4 deficiency with immunohistochemistry. So these are the three new entities in this version of WHO book. What about small biopsies? Just a small thing to say. For small biopsies and cytology, non-small cell lung carcinoma should be further classified when possible. And non-small cell carcinoma, NOS category should be used as little as possible. And when special studies are done, that means when you have immunohistochemistry, it should be clarified. Usage of large cell carcinoma is restricted to totally or thoroughly sampled operation specimens, and the tumors with sarcomatoid and giant cell features must be initially classified in relation to adenocarcinoma and squamous cell carcinoma. For example, if you have a core biopsy showing an adenocarcinoma lipidic pattern, you should never call this an adenocarcinoma in situ in a true-cut biopsy. A lipidic pattern could be used in small biopsies. And these are the terminology for small biopsies and cytology specimens, and terminology for resection specimens in this table that's also taken from the new classification. Previously, it was not a problem. When you see such a tumor, not adenocarcinoma, not squamous cell carcinoma, it looks like nothing. When you look at them, no keratinization, no glandular formation, no mucin. Previously, you would say non-small cell carcinoma, and that was sufficient 15 years ago. But now you cannot use this. You have to do immunohistochemistry. For example, this case is P40 negative and TTF1 positive. Then we have to report this as non-small cell carcinoma favor adenocarcinoma. If we have a biopsy in our, let me, this is a wrong thing. We must begin with here. If we have a tumor or biopsy cytology and we have typical morphological findings of any type of lung carcinoma, then we can say it without immunohistochemistry or any further investigation. But if we have no definitive finding for adenocarcinoma or squamous cell carcinoma, then we have to go to immunohistochemistry. And by immunohistochemistry, we must say that it's non-small cell carcinoma favor adenocarcinoma, or favor squamous cell carcinoma, or probable adenosquamous cell carcinoma. Only if they are inconclusive, then we can say that it's a non-small cell lung carcinoma, not otherwise specified. And these tumors, these favor adenocarcinoma groups, adenocarcinoma groups, and adenosquamous carcinoma groups, and also non-small cell lung carcinoma, not otherwise specified groups, should go to molecular or immunohistochemical and immunohistochemical analysis for therapy targets. And if we don't have residual tissue or sufficient residual tissue for these analyses, then we should go to the clinician and ask him or her to take a new biopsy or cytologic sample so that we can do these analyses. If this is not possible, maybe then we can go to liquid biopsies in these kinds of patients. And then I have very, very small to go on. Usually we have a very small tissue, so we have to use it wisely. We have many examinations to do in this small tissue. We have to diagnose the tumor, and we have to give hints to the management of this tumor. So how do we use the tissue wisely? First, we have to fix it properly. This is the first step. And we have to use this tissue for diagnosis and therapy. Also, we have to do 1, 2, 3 cuttings at least if we go this way. But we have alternative ways. One is to prepare a separate block for each fragment. Then we can use one fragment if there is tumor tissue, of course, for the diagnosis, and the second block for targeted for therapy targets. This can be a way, but we can also have spare sections in the first cutting to use them as necessary, as we need them. This is another way to save the tissue and not to cut it multiple times. Or in some cases, we can divide the first block when necessary and make, for example, 2 blocks out of 1 block. When we see that we are going to need it multiple times, then we can use the first one, for example, for diagnostic purposes, and the second one for the targeted therapies. So this was the end of my lecture, and it was a pleasure to be with you, and thank you for the invitation, and see you.
Mikrofon kapalı.
Thank you very much for this comprehensive review of lung histopathology and updates on the recent advances in the field. So I was following the chat here with the questions. I believe you addressed some of the comments from the audience.
I tried to address them, but unfortunately, I think not everybody see the questions. Just so
Yeah. So it was a question about the percentage of each of the components in the case of pleomorphic carcinoma.
You have to have at least 10% of every component to include it into the classification. However, if you have an adenocarcinoma component, let's say 5%, I would still, if even it's not enough, I would tell it, because it would be the component that would be the target for the therapy. So it's important to know it. Otherwise, it's always 10% in this blue book.
Okay, thank you. There was a question about TTF negative small cell lung carcinoma.
Yes. The question was that, is it prognostically important, TTF1 negativity in small cell carcinoma? But I don't know the answer really. You have to design a study, and I don't know such a study. Maybe there is, but even if you design such a study, then it will be very difficult to show that, because it's already a very poor prognosis.
Anyway, it's very poor.
It would take a lot of numbers to show it, probably. I guess so.
Thank you. It was a question about thymic carcinoma, but I think it's beyond the scope of your lecture because you covered lung tumors, not mediastinal. So you didn't cover thymic carcinoma, so it's unrelated to your talk. I'm sorry. So I just have a quick question before closing your session. There is this rare but well-known basaloid variant of squamous cell carcinoma that may be positive for neuroendocrine markers.
Yes, especially CD57. Yeah, you can have that positivity, but it's usually focal. It's usually just one marker, which is most of the time it's
but they remain positivity for both P50 and or 63.
Yes. 63 and 40. Yeah, okay. That's the main thing.
Yeah. Okay. Good. I think there is questions saying if we have solid tumor, single cell weak positivity and diffuse positivity with P40, how to classify this neoplasm?
If we have a tumor, single cell weak positivity or diffuse positive. The diffuse, usually in squamous cell carcinoma, you have diffuse positivity for the squamous markers, and you have no positivity for the for TTF1. But in adenocarcinomas, you may have a single cell positivity or focal positivity for squamous markers. But if you have a good positivity with TTF1, then it's an adenocarcinoma.
Okay.
Even though it may contain a few cells, especially this happens not with P40, but P63.
Yeah, in line with this, there is another question. If the markers for squamous and both squamous and adenocarcinoma are negative, how would you call this cancer on a small biopsy?
Yeah, if they are both negative, then I will call it non-small cell carcinoma, not otherwise specified. But I will write it in my report that it doesn't show any glands, it does not show any keratinization, and it's negative for both of the markers, and it does not contain mucin. Then I have the right to tell that it's a non-small cell carcinoma, not otherwise specified.
Okay, thank you. I think we need to close this session because it's nearly 1 hour. Thank you very much for your great contribution.
Thank you very much.
Thank you. Okay, now we move to the second session this morning. It's about lung cytology, not lung histopathology. So we have another great speaker, Dr. Ayşegül Aksoy Altinboga, who is coming from the Department of Pathology from the Ankara Yildirim Beyazıt University School of Medicine, where he is attending pathologist and associate professor of pathology. He has a good experience in diagnostics, but also in research and teaching. He has more than 30 publications related to diagnostic pathology. So our second session, next 45 minutes, is about lung cytology.
Hello, my name is Ayşegül Aksoy Altunboğa. I'm from Ankara Yildirim Beyazıt University. And now I will share my lung cytology presentation with you.
I have no relevant financial relationship. In this talk, at the beginning, briefly, I will talk about sampling techniques and normal cellular components of the respiratory cytology. And after this, with a case-based presentation, I will show you examples of non-small cell lung carcinomas, small cell lung carcinoma, metastatic tumor, and benign lesion. Many techniques are available for acquiring cytology samples from lung. Sputum cytology was one of the most common respiratory tract specimens because it is relatively easy to obtain and it gives no discomfort to patient. But however, today sputum cytology is generally reserved for symptomatic individuals. It is used as the mainstay respiratory in the respiratory cytology has declined significantly nowadays. Early morning deep core specimens are preferred for sputum cytology, and the advocacy of sputum cytology is established by finding numerous alveolar macrophages. Pulmonary macrophages indicate a deep core specimen of the lower respiratory tract has been obtained. Bronchial aspirations, bronchial washings, bronchial brushings, and bronchoalveolar lavage is maintained during bronchoscopy, and tiny lymph node and lesions just lie beneath the bronchial surface, sampling can be performed by bronchoscopically by passing the needle through the bronchi and by endoscopically by passing the needle through the esophagus. These two methods are shortly called as EBUS-FNA and EUS-FNA. Sensitivity and specificity of these techniques increases by using ultrasound guidance. And just for the lesions that are located peripherally, transthoracic CT guided fine needle aspirations can be chosen. During bronchoscopy, endobronchial ultrasound guided transbronchial fine needle aspirations can be performed from paratracheal, subcarinal, hilar, and interlobar lymph nodes. Normal cellular components of respiratory cytology include ciliated columnar cells, goblet cells, basal or reserve cells, and alveolar macrophages. Reactive bronchial epithelial cells may show marked nuclear size variation. Columnar cells can increase their nuclear area. They may have a coarse chromatin, large nucleoli. Binucleation, multinucleation can be present in these cells. Cilia and terminal bars, which are evidence of their benign nature, are retained in these cells. And malignancy can be excluded if the atypical cells have cilia. As the surface of the respiratory tract is shed during lung injury, reserve cells begin to proliferate, and they can be seen in bronchial washing and brushing specimens. Reserve cell hyperplasia is an unique small cell carcinoma, but it is usually easily distinguished from small cell carcinoma. The cells of the reserve cell hyperplasia show greater cohesiveness, so they are seen in tighter packed clusters. They have a smaller size. They have smudge chromatin pattern, and there will be no mitosis or necrosis on the slides. On the other hand, in small cell carcinoma, the cells are usually larger. They're about 1.5 to 3 times the size of a lymphocyte. They show marked nuclear molding. Necrosis and mitosis are common features in the smears. And in well-preserved samples, the cells have fine dark chromatin in small cell carcinoma. Fine needle aspiration of a reactive lymph node that do not contain tumor has the usual features with lymphoid cell population which range in maturation. There will be predominance of small mature lymphocytes and also occasional tingible body macrophages. Frequent plasma cells can be seen in these smears. An important consideration is that of specimen adequacy in lymph nodes when a tumor is present. There is no universally accepted gold standard for EBUS specimen adequacy. The specificity and negative predictive value of this procedure depends on ensuring that the needle is indeed sampling targeted lymph node and not just airway tissue. So, when FNA is used to sample a mediastinal lymph node, at least moderate amount of lymphocytes must be present to ensure adequacy of a specimen and avoid a false negative result. Lymphohistiocytic aggregates and anthracotic pigment-laden macrophages are other clues that lymph node is sampled during the procedure. In this literature, more quantitative measures are described, such as more than 5 lower power fields with more than 100 lymphocytes in each and less than 2 bronchial cells per low power field, are described as adequate in a smear. A specimen is generally considered adequate if abundant tumor is present, even in the absence of lymphocytes or histiocytes, because this typically represents near total tumor replacement of the lymph node. After this brief introduction in lung cytology, we will see the cases now and then. This is the first case. Case 1 is 68 years old man. On imaging, he has found to have a large mass in the upper lobe of the right lung with mediastinal, multiple mediastinal lymphadenopathy. Station 4 is sampled with EBAS guided FNA. Here we see the Megrunwald gives us stain slides, sheets of cells with abundant delicate cytoplasm and ill-defined cell borders are present here. The cells typically show nucleocytoplasmic polarity. Arrows showing acinar structures in these smears, and all of these features are indicating a non-small cell carcinoma. And here, arrow shows metachromatic granules in the cytoplasm of these atypical cells, and metachromatic granules in Romanovsky stain smears indicate intracytoplasmic mucin. This is what these cells look like on pap stain slides: foamy cytoplasm, excentrically located nuclei, abortive glandular structures are evident here. Here is the cell block section. Cell block section also shows non-small cell carcinoma. In the center and in the left picture, there is no evidence of gland formation or keratinization. But in the right picture, arrow shows gland formation. So here we see a non-small cell carcinoma which favor adenocarcinoma. The immunohistochemical panel that is the shortest for this case include TTF1 and P40, and tumor cells are positive with TTF1 and negative with P40. This case was diagnosed as pulmonary adenocarcinoma. So, if the case have clear morphologic patterns of adenocarcinoma, including acinar pattern, papillary pattern, the case can be diagnosed as adenocarcinoma. But a pneumocyte marker such as TTF1 is desired to address primary versus metastatic adenocarcinoma. Case 2 is 66 years old man with a history of pulmonary adenocarcinoma, which received chemotherapy and radiotherapy. The patient developed persistent CO, and sputum cytology was evaluated in this patient. Megrunwald stain sputum cytology is present here. On the left-hand side, squamous epithelium is present, which we often see on sputum cytology. And on the right-hand side, and in the right picture, irregular clusters of cells which have abundant vacuolated cytoplasm and excentrically located round nucleus are seen. And this is what they look like on pap stain slides. Atypical cells are seen on this pap stain slide. A cell block section shows small irregular clusters and isolated tumor cells, and TTF1 is positive in some of these atypical cells. And this sputum cytology is diagnosed as adenocarcinoma with a comment referring to previous biopsy. And after these two cases, we can summarize what we have learned from these ones. So if a case have gland formation or papillary pattern, or if we see intracytoplasmic mucin, we can diagnose that case as adenocarcinoma. But to address the primary origin of lung adenocarcinoma, you need to do immunohistochemical staining, and TTF1 or NAPSINA can be performed for this purpose, because in your differential diagnosis, still a metastatic adenocarcinoma is existing. You need to exclude a metastatic adenocarcinoma. Case 3 is 59 years old man with a large mass in the lower lobe superior segment of the right lung with multiple mediastinal lymph nodes. During bronchoscopy, no interstitial lesion was found, but apical segment of right lobe was found to be narrowed and irregular. This is how bronchial washing are seen on Megarin-White smears. Scattered atypical cells which have deep blue stained cytoplasm and hyperchromatic nuclei in a mucinous background are present here. In bronchial brushing, scattered atypical cells are seen. These cells have predominantly enlarged nucleus and skin cytoplasm. Also, a small cluster of similar cells are seen in this last picture. With all these features, this case was reported as suspicious for non-small cell lung carcinoma. We have seen isolated scattered sclerotic cells in the sputum site bronchial washing specimen. So with this feature, these morphologic findings are suspicious for squamous cell carcinoma. And after this report, transthoracic FNA of the mass was performed in this case. Transthoracic FNA smear of the mass is shown here. Three-dimensional cell clusters are seen, and the cells have hyperchromatic enlarged nuclei and skin cytoplasm. At the edge of this cluster, scattered cells have abundant cytoplasm. In these cells, cytoplasms are waxy and have a Robinek blue color in this Megarin-White staining. In Romanowski stains, Robinek blue indicates keratinization. And this is high magnification view of these cells. In other fields, similar cells are present. Robinek blue stained cytoplasm and dark, irregular, and angular nuclei are evident in these cells. Also, ghost of cells, which are anucleated scones, are present beside these atypical cells. And here we see the pap stain slice. On pap stain slice, dense orangeophilic cytoplasm and hyperchromatic, angulated, and often pycnotic nuclei indicate keratinization. And these keratinized cells are shown with the arrow. Core needle biopsy was performed beside this transthoracic fine needle aspiration in this case, and section of the core biopsy showing solid nest of tumor cells. In the center of these nest, occasional cells showing keratinization and similar to the fine needle aspiration smears. In another field, in some nests, prominent keratinization was identified, and in FNA smears, these isolated keratinized cells are representing these focuses. And this case was diagnosed as squamous cell carcinoma with these morphologic features. When a case clear morphologic patterns of squamous cell carcinoma, including keratinization or well-formed classical intercellular bridges, the case can be diagnosed as squamous cell carcinoma. Case 4 is 78 years old man with a mass in the right lung with multiple mediastinal lymph node. Station 4 lymph node, mediastinal lymph node, paratracheal lymph node was sampled with EVAS guided FNA. Megarin-White stain smear is shown here. Irregular clusters of cells which have enlarged nuclei, scan cytoplasm, and prominent nucleoli are seen. Scattered cells have abundant delicate cytoplasm and nucleocytoplasmic polarity, and another cell have fine metachromatic granules in the cytoplasm. These two-dimensional clusters do not show any evidence of keratinization or gland formation. Cell block section shows a solid nest of tumor which do not show any glandular formation or keratinization. Here in the site, a necrotic focus is present and high magnification view showing scattered cells which have eosinophilic cytoplasm and dark hyperchromatic pycnotic nuclei around the necrosis. In smears, nucleocytoplasmic polarity, intracytoplasmic fine metachromatic material, which is suspicious for Mucinver, suggesting adenocarcinoma. But in cell block section, these isolated cells are suspicious for either dyskeratotic cell or for apoptotic cell. So immunohistochemistry is needed in this case. And TTF1 is found to be positive in some of the tumor cells. And with the cytomorphologic features and immunohistochemical findings, this case was reported as non-small cell lung carcinoma, favor adenocarcinoma. Case 5 is 62 years old woman, which found to have 45 millimeter parahilar mass with multiple mediastinal lymph node. During bronchoscopy, no endobronchial bronchial lesion was identified, but right intermediate bronchi was found to be obliterated, and EBUS-guided FNA was used to sample station 7 lymph node in this case. Megarum Giemsa stain smears are shown here. 2 to 3 dimensional cell clusters which have scanned cytoplasm are shown here. And in some of these clusters, prominent large nucleoli are seen with moderate amount of cytoplasm. Some tumor cells have exantically located nuclei with pale stained large cytoplasm, and some tumor cells are forming glandular structures. And here, tumor cells have indistinct cell borders with nucleocytoplasmic polarity. Especially on the left picture, these features are prominent. Cell block sections are present here, and cell block section reveals solid nest of tumor cells. On the left upper picture, in the center of this solid nest, tumor cells have eosinophilic cytoplasm and dark pycnotic nuclei. We have seen this feature in the previous case. This may represent either a dyskeratotic cell feature or apoptotic cells may represent here. Cytomorphology in the smears were suggesting adenocarcinoma, but cell block section did not support this feature, and we have here a non-small cell lung carcinoma again, and we need immunohistochemistry. And in immunohistochemical staining, P40 was found to be positive in the tumor cells, and TTF1 is negative. And this case was reported as non-small cell carcinoma, favors squamous cell carcinoma. This table summarizes the morphologic features of poorly differentiated adenocarcinoma and poorly differentiated non-keratinizing squamous cell carcinoma. Cytoplasm will be dense and mucin negative in non-keratinizing squamous cell carcinoma. In poorly differentiated adenocarcinoma, the cytoplasm will be delicate and finely vacuolated. Cell borders will be more distinct in non-keratinizing squamous cell carcinoma, and nuclei will be darker and chromatin will be denser. In poorly differentiated adenocarcinoma, nuclei will have more open, delicate chromatin pattern. Nucleoli will be more prominent in poorly differentiated adenocarcinoma. If we have a poorly differentiated non-small cell carcinoma, looking through the cells at the edges of the large clusters may give us clue for squamous or acinar or mucinous differentiation. A few cells in squamous cell carcinoma may have intracytoplasmic metachromatic staining that mimics intracytoplasmic mucin. To see targetoid intracytoplasmic lumens containing mucin is more reliable criteria for adenocarcinoma. In the last two cases, we have seen a squamous cell carcinoma which mimics adenocarcinoma in the smears, and an adenocarcinoma which mimics squamous differentiation in cell block morphologically. So if we have any doubt about a glandular or squamous differentiation of if the tumor lacks true glandular or squamous differentiation, we need to use immunohistochemistry. TTF1 and NAPSNA are accepted markers for identification toward adenocarcinoma, and TTF1 is easier to assess as a nuclear stain. P40, P63, CK56 are markers for identification towards squamous cell origin. P40 is reported as the most sensitive and specific marker between these ones. And application of immunohistochemistry increases the refinement of diagnosis so that a diagnosis of non-small cell carcinoma not otherwise specified can be avoided in up to 90% of the cases. During immunohistochemical evaluation, if the case is TTF1 positive and P40 and or P63 negative, then the case can be diagnosed as poorly differentiated adenocarcinoma or non-small cell lung carcinoma favored adenocarcinoma. If the case is TTF1 negative, P40 or P63 strongly and diffuse positive, then the case can be diagnosed as poorly differentiated squamous cell carcinoma or non-small cell lung carcinoma favored squamous cell carcinoma. If TTF1 is positive and P63 is focally positive, your case can be diagnosed as poorly differentiated adenocarcinoma or non-small cell lung carcinoma favored adenocarcinoma. In this literature, P63 found to be focally positive in poorly differentiated adenocarcinoma, which is proved by immunohistochemical staining and morphologically in the resected specimen. We know that P40 and P63 had equal sensitivities. However, P40 is more specific than P40. P40 is more specific than P63. In this literature, which have large case series from Memorial Sloan Kettering Cancer Center and the Johns Hopkins Hospital, study 237 adenocarcinoma cases for P63 and P40. And they found P40 to be positive in 3% of the adenocarcinoma cases, in which the reactivity is no more than 5% of the tumor cells. On the other side, P63 was found to be positive in 31% of the adenocarcinoma cases, with a mean of P63 positive cells was found to be 26%. We know that there are some pitfalls in napsnate staining. Napsnate will stain the remaining alveolar lining cells and the scattered macrophages. So in a poorly differentiated squamous cell carcinoma, interpretation of napsnate is important. Remaining alveolar lining cells and scattered macrophages will be positive with napsnate, and these benign cells should not be interpreted as napsnate positive tumor cells. Case 6 is 57-year-old man who had hemoptysis. On imaging, he had found to have multiple mediastinal lymphadenopathy and also 23 millimeter lesion on the right lung, which was suspicious for a tumor mass, was found in this case. And EBUS guided FNA was performed from station 7 lymph node. Here we see the megawide stain slides. Three-dimensional cell clusters are seen in this low magnification view. If we look to the edges of these large clusters or on high magnification view, we see that some of the cells have intracytoplasmic metachromatic material indicating mucin. And on high magnification view, some of the cells have abundant pale stain cytoplasm, exantically located nuclei, and they're forming glandular structures. In different fields, similar features are present with glandular formation, intracytoplasmic metachromatic material. And on high power view, again, here we see intracytoplasmic metachromatic material in the slide too. And all of these features are suggesting an adenocarcinoma in cytology specimen. Here is the cell block section, which also show intracytoplasmic mucin in scattered tumor cells. And here we see a non-small cell carcinoma favoring adenocarcinoma. And now we need to do immunohistochemical staining to understand the origin of this tumor to exclude a metastasis. And with immunohistochemical staining, tumor cells are found to be negative with TTF1, napsnate, P40, CK56. Further evaluation is needed in this case to confirm a diagnosis of cancer, carcinoma, and also the metastatic tumor need to be excluded. And CK7 is positive in the tumor cells, so this is a carcinoma, a non-small cell carcinoma. Further, we need to exclude a metastasis. And we found CK2N to be focally positive in the tumor cells, and CDX2 is strongly and diffusely positive in the tumor cells. After these findings, we contacted with the clinician and they evaluated the case for another primary. And during CT computed tomographic evaluation of the abdomen, a tumor mass was found in the gastric ball. So this is a metastatic adenocarcinoma from gastric mucosa. So, if you have a carcinoma morphologically indicating a non-small cell origin, and with immunohistochemical staining, if TTF1 and P40 are negative in your case, step back before diagnosing non-small cell lung carcinoma not otherwise specified. You need to consider metastasis. If adeno or squamous markers are negative in a case, it is recommended that pathologists use the term non-small cell cancer rather than non-small cell lung cancer, because the lack of pneumocyte marker expression in small biopsies or cytology leaves open possibility of a metastatic carcinoma, and the determination of a lung primary must be established clinically after excluding primary sites. If these stains are negative, further evaluation to confirm a diagnosis of carcinoma and to exclude a metastasis is appropriate. Case 7 is 58 years old man who have dyspnea, found to have a large mass on the left lung. Bronchial brushing and EBUS-guided FNA for station 4 lymph node was performed in this case. First, we will see the bronchial brushing specimen. Between the slated columnar cells, scatter cells, which have small to medium in size, round to oval in shape, have a high nucleocytoplasmic ratio are present. Similar small to medium sized cells with fine dark chromatin and inconspicuous nucleoli are again seen here. These cells have scant cytoplasm. And here, these two groups exhibit marked nuclear molding, suggesting a small cell carcinoma. And station 4 lymph node aspiration is presented here. The smear is highly cellular on low magnification where prominent crushing artifact is seen. At low power, relatively uniform appearance is present. The cells are about 1.5 to 3 times the size of lymphocytes. Prominent molding is evident in these cells, especially in the right picture. Rosettes mimicking glandular structures are circled, and a blue body paranuclear cytoplasmic inclusion was shown with an arrow. And cell block section shows small round cells with prominent crush artifact. Differential diagnosis includes small cell tumors, and in this list, small cell carcinoma, purely differentiated small cell carcinomas, lymphomas, small cell melanoma, atypical carcinoid tumor, and other small blue cell tumors are present. In small cell carcinoma, small to medium sized cells are present. They have scant cytoplasm and they have fine hyperchromatic nucleus with inconspicuous nucleoli. Tumor cells may form rosettes mimicking glandular structures. Paranuclear blue bodies are important clues for small cell carcinoma. And in the smears, various mitosis and extensive necrosis are present. And in this case, we have seen all of these features, and small cell carcinoma is highly suspicious in this case. When we say poorly differentiated small cell carcinomas, here we mean the small cell, non-small cell lung cancer, especially the basaloid squamous cell carcinoma is present in this differential list. But in these cases, the chromatin is coarse and irregular distributed and hyperchromatic. A few prominent nucleoli are present when you search your case. Scattered squamatoid cells may be present. Metachromatic hyaline stromal material also can be seen. In this case, we do not see these features. In lymphomas, aggregates of cells can be present, but molding is not the feature of a lymphoma. And in most of the cases, totally dispersed cells are seen. And in the background, numerous lymphoglandular bodies are important clues for lymphomas. We have not seen lymphoglandular bodies, numerous lymphoglandular bodies in this case. Small cell melanoma will have large prominent nucleoli beside the small size of the tumor cells, and with immunohistochemical staining with the S100 HMB45 will help to differentiate small cell melanoma. In atypical carcinoid tumor, the tumor cell size are often larger than small cell carcinoma. Small nucleoli may be seen, and the cytoplasm is usually pale and lacy and more abundant than small cell carcinoma. Crash artifact is characteristically minimal or absent. There will be less nuclear molding, and the tumor cells will be less pleomorphic. So, when we evaluate this differential diagnosis list, our patient was an elder man, so have a lung mass. So firstly, in the differential diagnosis list, we need to evaluate small cell carcinoma, basaloid squamous cell carcinoma, and lymphoma. And immunohistochemical evaluation was performed, and TTF1, neuroendocrine markers, and pancytokeratin was found to be positive, with Ki67 proliferation index is very high in the tumor cells. P40 and the CT45 was negative, and all of these features was suggesting small cell lung carcinoma. And with these immunohistochemical findings, this case was diagnosed as small cell lung carcinoma. Case 8 is 58 years old woman in another outside hospital. On imaging, she has found to have multiple mediastinal lymph nodes, and she referred to our hospital for EVAS FNA. And in our hospital, station 7 and 4 right lymph nodes were sampled with EVAS. Major gives us stains. Slides of these lymph nodes are shown here, and we see scattered moderate amount of lymphocytes in a blood background. Here, some groups of cells which have haphazard arrangement in a pseudosyncytial pattern are evident. These cells have oval to spindle or boomerang-shaped nuclei and abundant pale stained cytoplasm. These features are characteristic for granulomas. These are epithelioid histiocytes. On pap stain smears, again, here we see another epithelioid histiocyte collection. Again, these cells have spindle to boomerang-shaped nuclei and abundant pale stained cytoplasm. A cell lobe section is present here. In the background, various dispersed lymphocytes are present and small tissue fragments are seen. On high magnification view, some of these microtissue fragments have non-necrotizing granulomas. Similar features are present in other microtissue fragments, and also special stains for microorganisms were performed for this case, and non-specific microorganisms were identified in this case. And this is diagnosed as non-necrotizing granulomatous disease. A comment is added to the report that if other causes of granulomas can be excluded, and if clinical, radiologic, and laboratory findings are compatible, non-necrotizing granulomas should be diagnosed as sarcoidosis. This is a recent paper which reviewed granulomatous pulmonary diseases. Approximately 50% of the pulmonary granulomatous diseases are caused by sarcoidosis and infections. Non-necrotizing granulomas usually have a non-infectious etiology, and the most common pulmonary disease typically presenting with non-necrotizing granulomas are sarcoidosis, berylliosis, hypersensitivity pneumonitis, and foreign body granulomas. Necrotizing granulomas usually have an infectious etiology, and most of them are caused by mycobacteria and fungi. And also we need to remember that granulomas can be associated with malignancies, and the most common malignancies that cause granulomatous reaction in the lymph nodes are squamous cell carcinomas and Hodgkin lymphomas. So when we see granulomas in an aspiration, before diagnosing a granulomatous disease, we need to exclude malignancy and we need to search our case carefully. I thank all you for attending this talk.
Thank you very much for this great talk on pulmonary cytology by Dr. Ayşegül. So I just noticed two quick questions about mainly about small cell morphology. One was about central nuclear clearing that is seen on GIMSA, on MGG stain.
Can you repeat, please? I'm trying to contact with video, but I'm not doing, yes.
Can you hear me?
Okay, I can hear you now.
Yeah, there was a brief question about is a central nuclear clearing a feature of small cell carcinoma on May-Grunwald GIMSA stain?
I don't have such experience. I don't see the nuclear clearing in small cell carcinoma in my practice.
Okay. Another quick question was about the presence of paranuclear bodies, again, in small cell carcinoma.
These are important clues for small cell carcinoma, but they are not specific to small cell carcinomas. They are seen as 3 to 5 micrometer small inclusions just near the nucleus. And on May-Grunwald GIMSA stain, they have a blue color. And they are important with other features of the small cell carcinoma like molding, scan cytoplasm, crash artifact, high cellularity, necrosis. You can use paranuclear inclusions as a clue for small cell carcinoma.
Okay. And there is one more question about the use of a cytoblock to perform ancillary diagnostic tools like biomarkers and PDL1.
Yes, in our written practice, most of the EBUS-guided FNAs are performed with on-site cytopathologic evaluation, especially for the malignant cases. And in most of the cases, if the patient did not have any complication and if we do not have to stop it early, we try to maintain a cell block section after preparing smears. And with these cell block sections, we can do our immunohistochemical staining. Also, molecular testings can be performed with these cell blocks. Also, besides cell blocks, we use smear slides for EGFR and BRAF mutations.
Okay. Very last question was about, have you got any experience with the PDL assessment in on cytology
Yes.
as a predictive biomarker?
It's not commonly expressed in the lung tumors, but we have positive cases in cell block sections.
Okay. Thank you very much. Thank you very much for a nice contribution. I think, guys, you will have now opportunity to vote for the first two sessions. Thank you very much,
Thank
Dr. Ayşegül. Now we will proceed with the third session, which is very much related to the previous talk. It's about the use of ancillary diagnostics in pulmonary cytopathology. This talk will be given by Professor Haldun Umudum. You know, those who attended the previous cytopathology schools, they know this guy. He was our guest a couple of years ago. Now you have the possibility to vote, guys, as you can see. So Dr. Haldun is professor of pathology at the Ufuk University in Ankara, Turkey. As he said himself, he graduated from the medical school in previous century. We don't know exactly when. After completing the residency in pathology, he moved to US and did his postgraduate training at Johns Hopkins University. Then he spent 3 beautiful years at the International Military Clinic in Belgium. After that, he switched to academia and joined the pathology department at the Ufuk University in Ankara. as he says, he's trying to marry pathology and genetics into tumor pathology, and he's also fond of cytopathology and believes who can imagine that one day fine needle of cytology would rupture the paraffin screen that separates the pathologists from clinicians. He likes this quotation of Carlos Bedrosian. So our next speaker, we are very pleased to have Dr. Haldun again with ancillary techniques in lung cytopathology. Thank you.
Thank you, and I'm sharing my screen. Okay. Can I do it or just? Okay. Good morning, everybody. My name is Dr. Haldun Udum, and as Semir told, I'm from Ufuk University in Ankara. Okay, this is Ankara during the night. This is an artificial lake or a big pool. There's an amusement park around this place, which call it Youth Park. And it's a beautiful city, especially during the night. And I hope to meet you face to face in some day after the pandemics in Ankara or in beautiful Bosnia, and who knows. Today, I'm going to talk about some advanced ancillary techniques in lung cytopathology. But first of all, I would like to have your comments with the hashtag of Bosnian Turkish Cytopath 2021 in your favorite social media. And my Twitter is this one. If you just leave me some comments, how bad I am during the meeting, and I really appreciate it. Okay. So I would like to start a new principle, which has been modified by me. About 2,500 years ago, the first medical principle was primum non nocere, means whatever you do, just do not harm first. That's the Hippocrates. This guy is the Hippocrates. In the 21st century, I had the chance to modify the first medical principle as primum non nocere, first, neither the patient, because it's the original idea. Second, know yourself, because there are medical legal issues. Three, not the cells, because we need molecular diagnosis. And this is my modification, just to be in case and to be, I would like to record it. Who knows, maybe after 2,000 years, they will remember me. Anyway, so today in my speech, I'm gonna give some questions and answers, but I'm not gonna get deep into the molecular diagnosis, and I'm not gonna repeat the same thing you can find on the internet or any published review articles. Instead, I'm gonna try to build a bridge between every level of discipline. So that means if you are working in a big university hospital, your practice is different, but if you are working in a private lab, so you need to do some testings. So I'm trying to fill that gap, okay? So what is different between cytological and the biopsy material in lung pathology? The cytological methods, less invasive, less morbid, and it's variated. So you may have FNA, pleural fluid, bronchial washes, brushing, and even sputum. And from the same lesion, multiple areas may be sampled. These are the advantages of the psychological method. And we need ancillary techniques in two purposes. First, diagnostic ones. Ayşegül told you about this in this perfect lecture. It's diagnostic purposes. Second, therapeutic purposes. So in diagnostic purposes, I'm going to give you some little bit information and the therapeutic purposes. So are cytological materials suitable for the ancillary methods? Yes. Cell blocks, perfect. Already stained materials, this is something unheard of for the biopsy material, but it's very suitable, the cytological materials for the molecular methods. And the leftover materials are all suitable. What does that mean? Let's say you have a patient with a pleural effusion for the 1 liter or 2 liter of pleural effusion, and you do some staining and you do some cell block, but you need more tissue than just give them the pleural fluid to centrifugation, and you'll get another cell block. And these techniques are very suitable for this method. This is a prop stained section here. And this is the corresponding fish analysis of the ALK analysis. This is the same tissue, cell rock, and this is the immunohistochemistry. Okay, so why do we need ancillary techniques for diagnostic purposes in lung cytology? Yes, because there are two things. First, what kind of cancer is it? Adenocarcinoma or squamous cell carcinoma? So just keep that in mind. We are looking at this cytological material. So material is so few, so limited to sacrifice. We need to save them. And we need tumor cells after diagnosing the case for molecular testing. So this is the regular markers, P63, P40, TTF1, and napsin. Okay, if you have plenty of material, you can do everything. But do we really need these four markers? No, just P40 and the TTF1 is good for the beginning. So do we need, and let's say we have a case of neuroendocrine carcinomas, and do we need ancillary techniques? Yes and no, because small cell carcinomas may display all, some, or none of the neuroendocrine markers. Diagnosis should be made on cytomorphology. So if you are suspecting neuroendocrine carcinomas, but in fact it was adenocarcinoma, so you finish and you waste all the tissue for immunohistochemistry. There is nothing left. So best thing to do, just pick up some specific stains. And my opinion is best to include one, especially the Ki-67. Why? Because crush artifacts can be seen in carcinoid tumors, low-grade tumors, and if you find any low Ki-67 in any neuroendocrine features, the tumors containing neuroendocrine features, then think about it may not be a small cell carcinoma. Rather, it may be a carcinoid tumor or a low-grade neuroendocrine carcinoma. So this is a case. As you see, it's the crush artifact, and this is the low Ki-67 index. So this is a low-grade neuroendocrine carcinoma. Okay, and when it comes to pleural effusion, can we use them? Yes, because lung cancers love to metastasize the pleura, as you see in the figure. This is the area. And TTF1 and napsin will identify about 70% of the lung cancers. But absence of these markers in tumor cells does not rule out the lung primary. So we need to be careful. And the best of information comes from the clinical information and the radiological findings. Because usually diagnosis is either a lung carcinoma, primary lung carcinoma, or a metastatic carcinoma. And chance of having a malignant mesothelioma is relatively low in the setting. And the diagnosis of the malignant mesothelioma must be made only in appropriate clinical context. So it's not a good idea to diagnose a simple case. This may be a malignant mesothelioma without no clinical information. Just be careful. So when it comes to the identification of the mesothelial cells in pleural effusions, yes, in pleural effusion, cells displaying mesothelial markers may be benign. However, any group of cells with displaying pneumocyte markers like TTF1, that should strongly imply malignancy. Why? Because pneumocytes or pneumocyte-like cells are not part of this environment, so they are invaders. And when it comes to mesothelial markers, mesothelial lesions or mesothelial effusion, it's best to have 3 epithelial markers and 3 mesothelial markers. And when it comes to a limited amount of material, let's say you have a little bit cell block, the calretinin is the most sensitive one for mesothelial cells. Okay, so this is a TTF1 positive cells groups in pleural effusion, which is cell block. These cells do not belong here. They are not part of the pleural environment. So such an observation should always raise the suspicion of metastatic lung carcinoma. Yeah, it may be other tumors, but most of the cases, it's the lung carcinoma. So when it comes to pleural effusion, we are talking about respiratory cytology and the diagnostic difficulties and using ancillary techniques. So let's say we have a pleural effusion and we have a question about it may be a benign mesothelial cells or a malignant pleural effusion. And the cytomorphological criteria are not easy to implement. Yes, there are some, excuse me, cytopathologists they look at the microscope and they say, okay, this is a mesothelioma and this is not a mesothelioma. This is just a benign reactive mesothelial hyperplasia. Yeah, you are not experienced then, but you have some issues and you need to diagnose. So what to do next? Be careful about the cytomorphological criteria. And when it comes to the immunohistochemical panel, any published immunohistochemical panel so far cannot be reliably distinguished these two layers on individual cases. Yeah, if you look at the literature, there are some series, but when it comes to a specific case, you cannot rely on this panel. So what to have then? We have two options. One of them is the FISH testings, 9P21. This is also termed as P16 FISH. Another one is an immunohistochemistry. It's the BAP1 immunohistochemistry. If you can use this test together, the combination of these results are the most reliable ancillary method to distinct malignant pleural effusions from the benign ones. So, give you some example. This is a suspicious case of pleural effusion with mesothelial hyperplasia, and this is the corresponding area of the FISH analysis, 9P21 FISH probe, and homozygous deletion was detected. What does that mean? That means these cells are malignant, are malignant mesothelioma, and this test so far has 100% positive prediction rate for the malignant mesotheliomas. It's relatively reliable technique. Okay, we are working in a commercial lab, in a private lab, and we don't have this FISH option. So we know that this 9P21 is related with the immunohistochemical P16. The question is, we don't have the 9P21 FISH. Cannot we perform P16 instead of FISH test on cytoblock material? The answer is no, a big no. Why? Because this translocation and the corresponding mutation, which is CDNK4 mutation, is not correlated with the P16 immunohistochemistry, and it's a big pitfall. Be careful. So if you have this one, it's okay. But do not try to replace this FISH with the immunohistochemistry. But we have another option, which is the BAP1 protein, which is a BRCA or breast carcinoma 1 associated protein. This is a highly specific marker for differentiating mesothelioma from reactive mesothelial proliferations. And you can use it in your own lab if you have an immunohistochemical facilities. So I'm going to give you some example of the BAP1, but if you have both tests together, 9P1, 9P21, and the BAP1, let's say you do it together in a suspicious case of mesothelial hyperplasia in a cytological material, and you can rely on your results because together, no false positive case has been reported. Both of them. This is the new era of the cytology. Combine the immunohistochemical results with the FISH results plus cytomorphological findings, and you have malignant mesothelioma diagnosis. You can be sure. What? Are there any limitations? Yes, because admixture of benign and malignant mesothelial cells may lead to some misinterpretation in cytological sample, especially in tough cases. Yeah, that's the Murphy's rule in pathology. The immunohistochemistry is useful only when it's not necessary. And it's not working when it's necessary. Okay, so this is the BAP1 immunohistochemistry. This is the benign case. This is from the literature, American Journal of Surgical Pathology. You see, and the BAP1 should be on nucleus of the cells. So nuclear positivity should be counted. We don't consider any cytoplasmic staining. So you'll see in the yellow can I show it? Yes. In yellow arrows showing the benign cells of the mesothelium with the BAP1 nuclear expression. In the slide B, you'll see another one, nuclear positivity, but here, this is a malignant case, and you need to spend some time and be patient, because in this area, you'll see there are some cytoplasmic expression of the BAP1, and this shouldn't be counted. But if you look at closely, the nuclei of these cells, especially the yellow arrows, so these are malignant mesothelioma cells, and they lost their BAP1 expression. And if you just have a little bit experience, and if you slow down, and if your cytological materials are just, if you have cytologic materials which is suitable for this test, then you can diagnose it. Okay, so as we said, this is the diagnostic purposes using ancillary methods. But we have another mission right now, which is a new technique and a new era for the pathologist. And we should tell the clinicians which tumor can benefit from which treatment. So it's like antibiotic resistance treatment in microbiology. So they send the tumors to us, and we'll tell them, okay, this medicine is not good, but this may be good. So this is another mission for the pathology. But when it comes to cytology, the cytologists have the same mission, especially in the lung oncology. We have a very, very interesting fundamental paradigm shift, which is we are required to perform timely and accurate detection of these predictive alterations. Just, I would like to take your attention to this sentence, because it's a accurate besides timely. And in CAP, College of American Protocols, says the molecular testing should be done in a reasonable time. But today is the most today we have many cases, and the results can be done in 30 days, 45 days, or sometimes 2 months. And this is not a good thing. So, can we use the cytological material for this molecular purposes? Yes. Why? As I said before, the cytological material are easy to obtain. And cytological material, even they were stained, we can use them. And we can identify a few number of cells in the cytological material and etch behind the back of the label, glass slide, and then it's easy to see it. And the best thing, I think the best thing is this. In any biopsy procedure, the tissues are put in a formalin. And formalin, what the formalin does, as I said here, as I say here, formalin fixation is the main enemy of the DNA. It destructs, it ruptures. So, but especially fine needle aspirations or pleural effusions, no formalin fixation is used. So the overall DNA or the nucleic acid are well preserved. That's the superiority of the cytology. And these tests are being done with the nucleic acid test like PCR, NGS, or FISH. And especially PCR and the NGS are just prone to the artifacts caused by formalin fixation. And the cytology is a very good alternative for this test. Yes, there are some issues about the cell blocks, and I hope in the future they will solve this problem. Okay, so today I'm not gonna get deep in these molecular methods. Rather, I'm gonna give you some alternatives to anybody. Let's say in a university hospital, in a state hospital, you don't have a molecular testing. So can we do something? That's my point of view. Yeah, because for the last 5 years, we have a specific immunohistochemistry, which is mutation-specific immunohistochemistry. Good old. And just a reminder, these 4 tests, EGFR, ROS1, and ALK, and the PD-L1 are the main targets for the lung adenocarcinoma cases. So first question, EGFR. Immunohistochemistry versus PCR. What is the EGFR? Yeah, activating mutation have been identified in lung adenocarcinomas, but there are many mutations related to the EGFR in the lung cancer, but two most common ones can be detected with mutation-specific immunohistochemistry. These two most common ones, about the 80% of all mutations. And immunostains have been validated in Cellulux, liquid-based cytologies, and the FNAs. And the scoring is like a HER2 staining in breast carcinoma. It is the 0, 1+, 2+, or 3+ score. Staining should be membranous, like similar to HER2. And how reliable are the results? Yes, if it's positive, if it's the 2+ or 3+, it's really reliable. But if it's not, then negative, it's negative. So you can send the specimen for the molecular verification. But this is the EGFR stain, 3+ score, membranous staining in a pleural fluid. You see, that's the EGFR. It's easy. And the best thing, you get your results in 1 day. If it's positive, and you can tell the clinician, oh, this patient may have an EGFR mutation. So, however, this immunostain, for some reason, not recommended by professional societies. On the other hand, it seems a valuable method. Cost is low, and the positive results are reliable. Test results can be done in 1 day. Test can be done on small amount of tissue, good screening test, and it is suitable for the low-income settings. In Turkey, which I live in right now, the test is going to cost about 20 or 30 euros only. That's it. Okay, another testing is ALK rearrangement in the lung carcinomas. It usually be done with FISH testing, and it predicts sensitivity for the tyrosine kinase inhibitors present in 5% of the lung adenocarcinoma. Let's say you are an oncologist, and then you have 100 lung adenocarcinoma cases, patients, and they are coming from low-income settings. So, do you order ALK rearrangement for these 100 patients? No, because you already know that only 5 of them will have this rearrangement, and the 95 of them would waste their money, and it's expensive. So best thing is to do mutation-specific immunohistochemistry as a screening test, which is EMN ALK4 is a fusion protein. When this ALK gene is rearranged, this is the fusion protein, and an immunostain is available, and this immunostain is FDA approved as an equivalent for the FISH test. So FISH, that's interesting. Then FISH and immunostain results may be different, but it doesn't matter. No clinical outcome to suggest the superiority of any methods. So this is and the EMN ALK4 immunostain is like EGFR stain. Staining pattern is given as 0, 1+, 2+, 3+. But it's a little bit different from the EGFR because right now the cytoplasmic granular staining should be present. This is another thing. Unless it's 0, +1, +2, +3, these all 3 categories may be considered positive. It's interesting, right? This is the ALK immunostain. This is the cytoplasmic expression. So it's a very good alternative to, it's a very good screen test. Another test is ROS1. ROS1 is another rearrangement. Can be done in FISH, NGS, or immunostain. Which one do you prefer? And it's very uncommon to find a ROS1 arrangement in lung carcinomas. So the same scenario, let's say you have 100 cases of lung carcinoma from low-income settings. So do you order ROS1 ROS1 testing for every patient? Because you know that only 5%, maybe less than 5%, will have this rearrangement. So best thing, and the ROS1 testing is strongly recommended for any patient with advanced stage carcinoma, adenocarcinoma. We have another immunostain, D4D6 clone of ROS1, and this has been validated as a screening test permutation. How reliable? This is something contrast with the EGFR ALK. If it's negative, you don't need to do another testing. It's gonna be negative. If it's positive, then you can send the samples to the FISH or NGS analysis. It's a good idea, right? So the famous PD-L1, that's the pembrolizumab, was approved for the first-line treatment of advanced stage non-small carcinoma cases, and we have a record for the PD-L1 because so far it is the one of, I think there are two most expensive medicines, medicine in the whole medical history of the world. The first one is, I think, either PD-L1 or the medication for the spinal muscular atrophy medication, but this is the, I think, either first one or the second one in regard to their price. It's really, really expensive, but it is working. So, non-small cell carcinoma cases with the PDL score over 50, and then it has been approved for the first-line treatment of advanced stage cancer. This scoring system is subject to debate for some times in pathological and cytological specimen. For lung carcinoma, the total positive percent of tumor cells are taken into account. Intratumoral lymphocytes are excluded. So this is a cell block. Yeah, we have many artifacts, but this is the malignant cells and with a perfect PD-L1 expression. Yeah, why we have a problems with the PD-L1 scoring? Let's say you have this area only. How are you gonna score this here? So it depends, it's open to interpretation. In my experience, if I see several cells with a undoubtedly positive for the PD-L1, I just call them positive and give a score like this. So I am coming to end of my session. Oops. Conclusion. Be careful when you're looking at the cytology because all cytological material can be utilized for diagnostic and therapeutic purposes in respiratory cytology. Be careful because immunostains will provide cheap and reasonable alternatives to expensive molecular methods. And besides, you can get the results in several days, which is very good for the clinicians and the patients, especially the patients who does not live in the same area. And if they're coming for treatment, this is another issue in my institution. Sometimes we need to speak with the patients and they tell us, okay, we need to stay in the hotel to get the results. So this is another problem in the 21st century, but if you can get the results in 2 days, that's very good. And for pathologists, immunostaining is easy to implement rather than molecular techniques because the molecular techniques are changing every day, and then it's very time-consuming to interpret their results. Now, it's time to get out of the comfort zone of the good old cytology to novel land of molecular environment. And thank you for listening to me. This is the end of my speech. Thank you.
Thank you very much, Haldun, for your excellent, brief but excellent talk.
Thank you.
I can see at least one question in the chat box about the method that you use for preparing the cell block.
Okay, it's a very good question because, yes, it's written in the literature, but sometimes this method is working, sometimes this method is not working. So it depends. If you are talking about the pleural effusions and if you have plenty of fluid, then we usually use ethanol plus formalin to just participate the preparations. But sometimes we need to use the another unusual methods like a fibrin thrombi to just get take the samples down on the tube. It depends usually, and we have several different methods. And I think there's another question which is what should be the fixative for the satellite? That's very good question, Mr. Javed Zaman. Yeah, I think if you can find a fixation which is formalin-free and do not destruct the DNA, you'll have first Nobel Prize and you will be counted as the richest man in the world or woman in the world. So that's a very good opinion. Usually we are using the regular formalin.
Okay.
Can you share? That's another question. Can you share the
EGFR immunohistochemistry does not specific exon defect, so it's not useful.
Yeah, that's another point. But just think about and the cost and the time. It's gonna cost 20 euros. It turns out to be positive, then you'll get something. But on the other hand, you need to wait at least 15 days, spend so much money, and you'll get the negative results. Which one should you choose? In my opinion, just practical one is do the EGFR immunohistochemistry, and then if it's really needed, confirm with the molecular methods.
Okay. What EGFR, last question, what EGFR clone do you recommend?
The most common ones, but I don't have in my file, but I can share afterwards. I don't have it with me right now, the clone.
Okay, thank you, Haldun. Thank you very much for your great talk. And with this, we close the first part of today's Cytopathology School. Now we will have a brief industry symposium that comes from our sponsor. It's the company Berg. They will have 10 minutes presentation, after which we will have a short break. So we are supposed to resume in 20 minutes, which means I think it's 10 minutes, so we should be back 11:35 or so. Thank you very much.
You're welcome.
Thank you.
Hope to see you again face to face Monday.
Yeah,
Great.
Thank you.
Hello, can you hear me? I will share my screen now. Okay, I hope you can hear me. Hi all, good morning and greetings from sunny Neum from Bosnia. My name is Tarik Demirovic, and I am a lead manager in software department in a company Berg. My goal for today is to show and tell you something more about our company Berg, our engagement in the healthcare sector, and our some specific work in a pathology field. We work with our strategic business partner Sectra, who is a worldwide leader in providing services for a diagnostic imaging and digital pathology. Our colleagues from Sectra are with us today, and in the second part of this presentation, they will speak more about what's new in the digital pathology world and the current state of the art when it comes to digital pathology. First, I would like to thank to organizers of the 5th Bosnian Turkish Cytopathology School and all participants here today. We are really happy to be part of the story by helping and supporting our local healthcare sector and also to contribute to worldwide research and development. So let me introduce you our company Berg. We are located in Sarajevo. For the last 15 years, we have been a regional leader when it comes to digitizing and performing digital transformation in healthcare sector with specific focus on diagnostic processes and diagnostic imaging. We do this and we help our customers to improve, optimize, and speed up their work process with our software and services. And we do this by learning, designing, and developing software products. During our journey in healthcare development and let's say mutual research and experience which we gained with our customers, we have developed specialized software products to help and optimize everyday work for our customers. In Berg, we as a team, we are very passionate about about tech and the research and development, our focus is always high quality of user experience for our solutions. We do this by developing quality products and that are specific to our customer needs. What we believe as a company is that key to success is to constantly learn and grow and do this together with our customers. So we we are present and we operate in our region through our partner network with more than 300 facilities, including clinical universities, hospitals, medical centers, and 2 major national diagnostic medical platforms. They all operate on our Berg Health Cloud platform, which automates and improves the customer's process, which in the end leads to the better patient outcomes. Together with our customers, we recognize the value and efficiency of cloud-based platform. Our portfolio consists of specialized application units that are connected, and every application is specific to a specific diagnostic, which enables really efficient work in this corresponding discipline. We have covered pathology, radiology, cardiology, breast imaging, and other ologies, how we like to say this. Our biggest application units are pathology and radiology. Deep integration with our PACS providers allow our system to become a major entry points for our end users. Modules for archiving and advanced searches, comparison of findings, teleconsultations, and data sharing facilitate the daily work of our users. Also, as a part of our applications suite, we developed and we follow process with the mobile applications. With the mobile applications, we really speed up the user engagement and reduce hardware necessities in healthcare facilities. We have various examination modules which include cardio and breast imaging. Also, we help our customer to organize mass screenings. Okay, yeah. So, what is our particular work in the pathology field? So, our solution is mainly used in all major subfields, and we provide digital pathology services through PACS integration with our Sectra partner. When it comes to digitizing pathology process, we believe that 3 value areas need to be identified, and we always try to improve and optimize these value areas for our solutions. We use our applications and solutions for mobile phones and tablets to help our customers to digitize pathology process and their labs in their native environments, which are not very computer friendly. For example, in the immunohistochemistry process is implemented, and every step is performed by scanning barcodes from samples and slices. Yeah, as I mentioned, all of these tasks are supported: container labeling, description of specimen character, photo documentation, macroscopic works, and also creating protocols in form of orders of a lab procedures. When it comes to final reporting, our goal is to free pathologists of time-consuming tasks so they can focus on what's most important, and that is setting the diagnosis. We do this with our various tools like voice dictation, speech to text, and they can really boost up the performance and efficiency. Also, our modules for learning enable post-processing of pathology orders, and basically final reports are archived, and some of them are tagged with specific keywords and future research. So because we recognize that learning is important part of the process, we implemented it through our advanced search of a reports, and our pathologists are able to perform complex search of their archives using keywords and tags. Sorry, I have one question. What we basically do is we recognize user language and perform full text search of the keywords and phrases. So that was brief introduction in our work. I would like to call now our colleagues from Sectra, Mr. Marcus, to tell us more about the current state of the art when it comes to imaging and digital pathology.
Thank you very much, and thank you for having me. Oh, I see there is an issue with my camera, so I will swap camera and hope that will help. That was good. So what I'm going to talk about today is digital pathology for primary diagnostics. We all know that digital pathology has been around for many years now, over 2 decades, and it has been used in limited settings for MDTs or for teaching, research, but not really taking this step into full primary diagnostics. But what we now see is that starts to happening, and that is also reflected among the users that we have on our systems. Since within the ecosystem of digital pathology, there are many different items that is needed. So on the image you can see on the top row, there are multiple software components with the image management systems, could be also called packs, viewers, image analysis, sharing cases, teaching, and archiving. And that is also important together with the hardware that is needed, not only computers, but also scanners, micro cameras, and so forth. So what we, Sectra is an imaging company. We are handling medical imaging. We do have our background in radiology, but we have been passionate about pathology for almost a decade now, where we are now delivering a IT solution for primary diagnostics within pathology. And if you want to read more, I can recommend a survey done by a research organization called KLAS, K-L-A-S, KLAS Research. And they have both done a report on what solutions there is out there. And they also did a ranking this year. And we were very fortunate to be ranked #1 in pathology. We've been ranked #1 in radiology for many years, but now also in pathology. So globally, the adoption of digital pathology is also reflected in our installed base. So as of now, we are having our pathology customers in the countries marked with the dark blue. For radiology, we have a global coverage, but for pathology, we have seen that the adoption has been mainly in Northern Europe. But we now see that's changing, and that's why we participate here today together with Berg Health Solutions. So, so why is then separate software needed for digital pathology? Since with most scanners, there is software attached to it that comes with it. And that works probably fine for a limited use case within a department or a smaller use. But what a separate IT system does to handle the images is it gives you standardization when it comes to integrations. both when it comes to LISs and scanners. So the Paxron Sectra can handle all high volume scanners globally. So you can pick and choose scanner. Maybe you want one brand for your high volume, another one for fluorescence, a third one for mega slides. And also it has support to support the workflow, because when you do not hand out glass trays any longer, it needs to be an IT system for it. And also ensure that you can integrate with all the AI solutions that is now coming within the pathology field. It is a lot of them popping up, and then an IT backbone can support you doing that. And the rest of the underlying needs of the iceberg comes to IT security, patient integrity, and stability. Because with our experience from the labs that has went digital is that when you start to rely on it and you do not have the physical glasses at your hand, then it is super important that the system is always up and running and fast, even if you are multiple persons working at the same time. So I know that the time is short since the break is over in 5 minutes, but I just wanted to say a few examples. One of them is a healthcare organization in Sweden. They are a multi-lab institution with 4 labs. They are doing over 100,000 histology cases annually, and they do not hand out glasses any longer, and they do it completely digital. Another example is from the Netherlands, where they have integrated AI from, or actually multiple different AI solutions into the department, into routine diagnostics, where you can really see the benefit from having a separate IT system for that. Before I end, I just wanted to say that this can be in your institution delivered as a subscription. So it is a pay-per-use model where you can have it in the cloud or as a local installation, and it's provided to you together with Berg Health Solutions. We ran over time a little bit, but if there's any questions, I'm happy to answer that, or we can take a deeper dive into if there's any questions.
Thank you for your nice presentation. I cannot see any question in the chat box that is available here. The question that is here is related to the previous session, not to your presentation. So what are the options that are currently available for the local potential customers in Bosnia?
So it is possible to get started working with the digital pathology with a where you can use the system for primary diagnostic. Of course, it can be used for other cases as well. But what we do see is that the trend is now changing from being used just for a few cases into actually full-scale clinical production. And that is now viable, and it is fast, it is safe now. So I think it's just a matter of time now how fast the adoption will be, and also the drive with all the different AI applications that can be added. So I think that the time is now. And if you have more interested in digital pathology, there are multiple congresses, and we have a lot of webinars and articles on our webpage if you want to learn more.
Yeah, thank you. I completely agree. The pathology is completely moving in the digital. So I'm sure you will have a lot of opportunities in the very near future here. Although the market and the situation locally in Bosnia is not that developed as in developed world, but still there is a big perspective for you, I'm sure.
Yeah, I mean, we do see interest from many countries as of now. So I don't think the future is too far away.
No. On the contrary, it's a reality actually. In some countries, it's already reality actually, not future. Thank you very much. Thank you very much for your quick introduction to your company. Thank you.
Thank you.
Thank you.
All right, Tariq, is there anything else you wanted to share with the audience?
No, that's it. If any questions, if we have any questions later, our presentation will be there and our contacts. So we will be happy to answer all other questions.
Okay. Thank you very much for your very nice and brief but nice introduction to your company. And thank you for the support of this important event to us. Thank you.
Thank you. It was our pleasure.
Thank you. I believe we have 2 minutes more before we start the second part of today's school.
Hello, Semir.
Yes.
Do I directly start the second session, or will you be introducing?
No, you are supposed to chair the second part.
Okay. Yes, it is okay with me. Right after the break, I am beginning.
Okay, I think we are nearly done with the break, so maybe it's a good time to start. Maybe just a couple of more slides that Aisha wanted to share. I mean,
okay.
Slides, you know.
Just so I'm waiting to stop the video running now.
Yeah. Okay. Let's Aisha run a couple of more slides before you take you start the next session.
Okay.
I think it's now time to start the second part, please. Seven again, please.
Now start? Okay.
Yeah, you can start now, please.
Hello, everyone. After this short break, we are passing through the second session of today's program. Our first speaker is Dr. Sanela Vesnic. She's graduated from Sarajevo University School of Medicine in 2001. She is specialist in diagnostic radiology since 2009 at the Department of Radiology Clinical Center of the University of Sarajevo. She has extensive experience in diagnostic and interventional radiology, particularly in pulmonary and thoracic diagnostics. She holds master's degree in medicine and published several papers on the various aspects of diagnostic and interventional radiology. She is currently doing her PhD project related to the role of the interventional radiology in the diagnostics of solid and lymphoproliferative tumors. Now I give the camera to Dr. Senela Vesnic for her topic, which is radiological approach to the peripheral lung lesions. Dr. Vesnic, please.
Hello, everybody. First, I want to thank organizers for the pleasure and opportunity to participate in this cytopathology school. As a radiologist, I'm going to talk about radiological approach to the peripheral lung lesions. For radiologists, MD-CT is the main radiological modality for evaluation of lung lesions, because it can provide high-resolution images when performed with small slice thickness up to 1.5 millimeters. In that way, we can recognize very small lesions in few millimeters, so we can detect them on MD-CT. Peripheral lung lesions can be detected on CT as a solitary pulmonary nodule, lung mass, or pneumonia-like opacity. The focus of this session will be on solitary pulmonary nodule, as the most challenging for radiologists to differentiate if it is benign or malignant. So solitary pulmonary nodules are defined as a single radiographic opacity up to 3 centimeters in diameter. They are almost benign, but 1 to 12% of them may be malignant. On the other hand, lesions larger than 3 centimeters in diameter are usually considered malignant, and they are defined as lung masses. It is important to know that pulmonary nodules are found on 13% of non-screening chest CT scans as incidental findings. Knowing that lung cancer is the leading cause of cancer death in the world, early diagnosis is crucial for survival. We know that the 5-year survival rate of patients with lung cancer extremely drops from 82% for stage 1A to very small 6% for stage 4. So once again, early diagnosis is crucial for survival. Peripheral lung lesions can be detected on CT as solid, part solid, and ground glass opacities. Solid lesions have a density of soft tissue. Their incidence is most frequent, between 60 and 80%, and most of them are benign subpleural lymph nodes. However, they have a certain risk of primary malignancy, which is related to lesion size. So lesions, solid nodules up to 1 centimeter, have a small risk of primary malignancy up to 15%, while lesions older than 2 centimeters have a risk of primary malignancy between 50 and 75%. Part solid lesion, we can see here, have at the same time solid and ground glass opacities. Their incidence is a small 7%, can be benign, but this is most common appearance of lung adenocarcinoma, between 48 and 63%. The size of a solid component is related to invasiveness of these nodules. On the other hand, ground glass nodules have a density which is smaller than surrounding a lung parenchyma, but it is higher than soft tissue or solid component. Their incidence is 12%. Most are benign, infectious, or inflammatory, but lung adenocarcinoma can occur and can appear in this form. But when diagnosis is adenocarcinoma, ground glass opacity, it is usually non-invasive type with nearly 100% curable with resection. There are some clinical and radiological risk factors that can help us to identify nodules at high risk for malignancy. Smoking, advanced age, more than 65, history of malignancy, interstitial lung disease, emphysema, exposure to asbestos, uranium, and radon are associated with a higher risk of malignancy. SPNs are usually asymptomatic, but when symptoms present, the patient is usually in advanced metastatic disease. CT scans for accurate characterization of small nodules should be obtained with thin slice up to 1.5 millimeters. In that way, we can get high resolution images that can help us to analyze specific morphologic features of the nodule, such as the size, attenuation or density, location, borders, calcification, morphologic pattern, as well as nodule enhancement. All of these things can help us to distinguish benign from malignant disease. Regarding the size, we know that malignant potential rises with the size. So nodule less than 5 millimeter have minimal chance of malignancy, less than 1%. Nodules between 5 and 10 millimeters have risk of a malignancy between 6 and 28%, while lesions older than 10 millimeter have 33 to 60% risk of malignancy. The minimal size of nodule determining the need for CT follow-up is 5 millimeter, according to the British Thoracic Society guidelines, and the 6 millimeter for the Fleischner Society guidelines. These are once again different densities of solitary pulmonary nodules, with each of them having a certain risk of malignancy. Location of the nodule itself can help us to suspect the nodule as benign or malignant. We know that upper lobe's location of a solitary pulmonary nodule is considered an independent risk factor for malignancy. It could be due to high concentration of inhaled carcinogens in the upper lobes caused by cigarette smoking. Spiculated margin of a nodule is highly associated of malignancy. Up to 90% of nodules with the spiculated margins are malignant. However, there are some benign conditions that can also have spiculated margins, such as lipoid pneumonia, focal atelectasis, tuberculoma, and progressive mass fibrosis. Benign nodules usually have well-defined, smooth or polygonal margins, but 1/3 of them may be malignant. Nodules with lobulated margin has an intermediate risk for malignancy. This is a typical malignant lesion located in the upper lobe of the right lung with solid component and spiculated margin. Calcification and the pattern of calcification in the nodule can also help us to suspect the nodule as benign or malignant. Benign patterns of calcifications are diffuse solid calcification, lamellar, popcorn, and centrally located. Popcorn calcifications are typical for hematomas, while the others are typical in granulomatous infections. Eccentric or stippled calcifications are associated with malignancy. We can see here some typical benign type of calcification. This is a diffuse, dense calcification in granuloma after granulomatous infections. This is a popcorn classification typical for hamartomas, and this is also centrally located classification benign type, as well as the laminated classification. This is a typical malignant type of calcification, peripherally located, eccentric, and with solid component located in the upper lobe. Lesions and nodules with a fatty attenuation also can help us to suspect nodule as benign, because nodules, especially hamartomas, because they usually have minus density in Hounsfield, the units usually between 40 and 120. But we have to know that some other lesions, malignant lesions, can also have a fatty attenuation on CT, such as a metastasis, liposarcoma, renal cell carcinoma, or lipoid pneumonia. Cavitary lesions or cavitation of the nodules can occur in both infectious and inflammatory conditions, but also in malignant solitary pulmonary nodules, particularly in squamous cell carcinoma. In that case, we can use wall thickness as a helpful marker, because we know that 95% of cavitary nodules with the wall thickness greater than 15 millimeters are malignant, while 92% of cavitary nodules with wall thickness less than 5 millimeters are benign. However, cavity with the wall thickness between 5 and 15 millimeters are not reliable to differentiate benign from malignant nodules. This is a typical malignant lesion, excavated cavitary lesion with a thick wall. Enhancement of the nodule after intravenous contrast injection can also help us to suspect nodule as malignant or benign. So enhancement of the nodule, more than 20 Hounsfield units after intravenous contrast injection, it suggests a malignant etiology, while enhancement of less than 15 Hounsfield units suggests benign etiology. However, it is not applicable for small nodules smaller than 5 millimeters, as they have a higher chance of benignity. Growth of the nodule is assessed by the volume doubling time. As a spherical structure, the volume of nodule is calculated using this mathematical formula for spherical structures. So if we get increase the diameter of 26%, it is equivalent to doubling of the volume. So malignant solid SPNs usually have a volume doubling time between 20 and 400 days, with the majority of them having VDT less than 100 days. On the other hand, benign processes such as infectious process has usually much less volume doubling time, less than 20 days. Reveal reported that when the volume doubling time exceeds 500 days, it is almost 100% benign lesion. As I mentioned earlier, intraparenchymal lymph node is a common cause of benign solitary pulmonary nodules. They have oval, rounded, lentiform or triangular shape and sharp borders, and usually attached to the interlobar septum. So all of these features are enough for Fleischer Society guidelines to not recommend the follow-up of them on with the CT, even if their dimension exceed 6 millimeters. This is a typical intraparenchymal lymph node, triangular in shape, with a sharp border and attached to the lung fissure. Here we can see some common models established to estimate the probability of malignancy of solitary pulmonary nodules that can help clinicians and radiologists to guide and to manage patients with the solitary pulmonary nodules. Mayo Clinic calculator takes into account age, upper lobe location of the nodule diameter, speculation, smoking, and extrathoracic cancer in 5 years ago. So using this formula, we can get malignancy probability. By Brock University calculator, using more variables such as emphysema, nodule type, sex, nodule count, or family history of lung cancer. And using this formula, we can get malignancy probability. So based on these models, the probability of malignancy is classified into low when the result is less than 5 millimeter, intermediate if the result is between 5 and 65, and high if result is more than 65%. The Fleischer Society and the British Thoracic Society guidelines are established to help professionals, to help clinicians and radiologists and others to manage and to guide patients with the solitary pulmonary nodules. Both of these guidelines do not recommend further follow-up and investigation for nodules with benign patterns of calcification, having a macroscopic fatty tissue, or a typical intrapulmonary lymph node. However, prior imaging studies should always be reviewed if available to determine possible growth and or stability of nodules. These guidelines give us separate recommendations for solid and subsolid nodules, and they are based on nodule size and the cancer risk of the patient. So for subsolid nodules less than 6 millimeter, there is no routine follow-up is recommended. Subsolid nodules of more than 6 millimeter and ground glass opacity are recommended for CT at 6 to 12 months interval to confirm persistence, and if it's stable, then every 2 years CT for next 5 years. For nodules more than 6 millimeter and part solid nodules, CT is recommended at a short interval between 3 to 6 months to confirm persistence. So if a solid component is less than 6 millimeter, then annual CT for next 5 years is recommended to follow up, and if the solid component is more than 6 millimeter, it is important because there is a high risk for malignancy. So depending on the location, surgical risk, and patient preference, there are 3 options: surgical resection, biopsy, or CT follow-up. For solid nodules, there is a different recommendation. The most important are nodules over 8 millimeter. They should be undergo PET-CT with a malignancy risk assessment with modality, as I mentioned earlier. So if a patient is at high risk, he should go to staging, and if no metastasis, depending on the surgical risk and patient preference, there are 3 there are two treatment options, surgical or non-surgical. For patients at intermediate risk, depending on location, surgical risk, and patient preference, biopsy or CT at 3 months follow-up is recommended. A patient at low risk can undergo CT follow-up. For solid nodules between 6 and 8 millimeter and less than 6 millimeter, if they are at low or high risk, CT follow-up is recommended at a certain interval, usually between 6 and 12 months, and if they are stable, then at 18 to 24 months interval. Only for solid nodules less than 6 millimeter at low risk, no follow-up is recommended. To summarize, nodules with a suspicious morphology that having a solid component of more than 8 millimeter or growing solid component, there is a strong recommendation for early follow-up with CT at 3 months, and PET-CT, maybe biopsy or surgical resection, or a combination of these modalities. However, depending on a patient preference, management could be follow-up for a low-risk patient, surgical resection in high-risk operable patient, and additional diagnostic tests such as PET-CT or tissue sampling for patients in intermediate risk of malignancy. CT-guided needle biopsy or FNA is widely used and recommended for establishing the diagnosis of peripheral lung lesions, particularly when we know that the conventional bronchoscopy in patients with peripheral lung lesions has limited diagnostic yield. It is dependent on lesion size with the overall diagnostic sensitivity about 57%. On the other hand, CT-guided needle biopsy and FNA, according to the literature, have sensitivity of 90% and specificity of 97% in establishing the diagnosis of peripheral bronchogenic carcinoma. Its accuracy is most dependent on nodule size, the number of needle passes, or presence of on-site pathologist. The size of the needle may have an important role if lymphoma or benign etiology are suspected. We usually use for FNA 22 gauge needle and 18 gauge needle for true cut biopsy. We can see here on CT scan small ground glass peripheral lung lesion. And during CT-guided needle biopsy, it is very important to differentiate, to define optimal entry point of the needle and needle track in order to avoid ribs, bulla, vessels, and fissure, and in that way to avoid possible complications. So this is another one lesion. This is a huge lesion. This is not a nodule. This is a lung mass, over 3 centimeter density of soft tissue with the spiculated margin, highly suggesting malignoma. And after biopsy, lung adenocarcinoma is confirmed. The most common complication of CT-guided biopsy or FNA is pneumothorax, that we can see it in 15% of cases, requiring chest tube insertion at almost 7% of patients. hemorrhage is less common, and we can see that in 1% of patients, air embolism or tumor seeding are also reported, but very, very rare. We usually use core biopsy. I would like to say when the lesion is peripheral located, very close to the chest wall. But if the lesion is located too deep, surrounded with huge vessels, and when we expect to have a complications such as uncontrolled bleeding, we rather use FNA. It is important to know that the false and negative results are more frequent in average of 22% of CT-guided needle biopsy or FNA, while the false positive results are very rare. So when we get benign results or non-diagnostic results, but clinical and imaging findings strongly suggest malignancy. Malignancy should rule out with other diagnostic modalities, particularly surgery methods, VATS or open surgery, in order to establish and confirm definitive histopathological diagnosis. So this is all from me, and thank you very much.
Thank you, Dr. Vesnic, for this excellent and concise presentation of yours on the radiological features of the peripheral lung lesions. I think it is one of the utmost important issues for pathologists as well, not only for clinicians, but also pathologists, to be aware of the characteristical radiological features of lung masses when dealing lung cancer patients.
Yes, usually pathologists ask us how it looks on CT. What do you think? Is this benign or malignant?
Right. Even at least they should be aware of whether there is a mass or not, because especially in cytology, there are many mimickers, benign lesions, mimickers of malignancy. So a pathologist should know the presence of a mass, because if there is no mass, possibly you may not be dealing with a tumor. So it is utmost important. Thank you for this excellent presentation.
Thank you very much.
Now I am. Yes. I'm turning to audience, and I see two questions. Do you recommend serological testing for tuberculosis or fungal infection, or they can be superimposed and may deceive for accurate diagnosis of malignancy?
Usually we discuss with the clinician. If the clinician asks from us to take the tissue for another additional analysis, we use that.
Mm-hmm. Oh, I think there's the second one here.
Second one is about excavated lesion.
Yes.
There is it is sometimes a very very hard to say if it is a solid or subsolid, but it is not so important. If we have a big lesion, it is not, and it is important clinical characteristics, and usually we have to diagnose with the FNA or bronchoscopy. It depends where the lesion is positioned, deep, centrally located, but usually in our institution, we try to get cytology or pathology diagnosis. So subsolid or solid, it is academically important, but in daily practice, in daily routine, we have to check, we have to follow up if after 3 months, it is quite enough period to decide what to do next with that patient.
If I'm not wrong, your first choice in the diagnosis or in the sampling of these nodules is core biopsies, right? You prefer cytology only for limited cases, which are very close to pleura and small UV.
Yes, yes. Core biopsy, usually we perform core biopsy. There is no risk for, very small risk for complications. But if the lesion is deeper, surrounded by huge vessels, I really had a major complication, and I couldn't help that patient, even if I had anesthesia with me. Patients died. And from my colleague, doctor.
Yes, right.
From uncontrolled bleeding.
Yeah.
And it was drama.
Exactly. So just to know it, your experience in your institute, how often you perform FNA cytology? Very rare, half of patients maybe?
1/5 or 1/3, 1/4 of all the cases.
Yes, and I think they should be, if possible, accompanied by a pathologist for on-site evaluation.
Yeah,
otherwise,
no, we don't have on-site pathologists. Never.
Yeah.
There is no. We don't have a lot of pathologists to get pathologists on the when we perform. It is impossible to have pathologists.
I am turning to audience, but I cannot see any other question. The first participants thanks you. I think this has been a good talk, and I'd like to thank you. Thank you for your nice presentation and for accepting to be a part of today's program.
It was my pleasure. Thank you very much.
Thank you very much, and have a nice day. Bye.
Bye. See you.
I think we can pass to our second speaker in this session. She's Dr. Çisel Aydın Meriçöz. She completed her residency at Ankara Hacettepe University Department of Pathology in 2015. She participated in several studies in field of cytopathology at Johns Hopkins Hospital in 2014. Then she started molecular oncology doctorate program at University of Health Sciences in 2017. She's been working in Istanbul Koç University Hospital Department of Pathology since 2018, and she is currently the board member and also the secretary of Turkish Society of Cytopathology. And now I am turning my microphone over to Çisel for her lecture, which is biomarker testing in lung cytology materials. Çisel, please.
Hello, I'm Dr. Çisel from Koç University, Istanbul. First of all, I want to thank IAP and Turkish Society of Cytopathology and the Association of Basic Medical Sciences of the Federation of Bosnia and Herzegovina for giving me this chance. Today, I want to talk with you biomarker testing in lung cytology materials. Lung cancer still remains a major health problem for both sexes, Every day we diagnose new patients. Over this time, the diagnoses rely on minimally invasive tissue sampling techniques such as CT-guided needle biopsies or bronchoscopic-based modalities such as EBUS-TBNA. Therefore, cytology becomes the primary modality for establishing a pathologic diagnosis of lung cancer. It has been increasingly appreciated that the ancillary molecular testing performed on this cytology for identify potentially targetable oncogenic driver mutations. Therefore, molecular cytopathologists now play a critical role. In the settings, their role is to review the adequacy of retrieved cytological material in terms of neoplastic cell content and the presence of contaminants such as which may lead to false negative results, such as non-neoplastic cell or necrosis, or inhibit the amplification process such as mucus. On the other hand, when samples are inadequate for molecular analysis, cytopathologists must revoke clinician requests for analysis, making sure to explain the reason for its rejections in a detailed written report. And another possible scenario is the possibility of requesting biomarker right after the morphological diagnosis, which we call this reflex testing. Prior to molecular testings, it's important to know the tumor categorizations. For making these categorizations, we are using cytomorphologic features and immunostains. For TTF1 and NAPSNA favor adenocarcinoma, P40 and cytokeratin 5-6 favor squamous cell carcinoma, synaptophysin chromogranin, and CD56 favor neuroendocrine tumors. This characterizations is important because testing algorithms are largely designed around tumor classification. So, which cases and specimen type? In general, it has become standard of care to test all advanced stage non-small cell carcinoma. Because of the possibility of tumor heterogeneity, especially given limited sampling from cytology, the updated CAP guidelines acknowledge that physicians may use molecular biomarker testing in tumor with histologies other than adenocarcinoma. Although traditional molecular testing has been primarily run and validated on paraffin tissue, the updated CAP guideline now acknowledge that any cytology sample with adequate cellularity and preservation can be tested. So, what is the adequacy? For real-time PCR, for example, EGFR testings, it be at least 20% tumor cells, and for immunohistochemistry like ALK or ROS, it must be at least 20 tumor cells. And which specimen type? You can use all cytological specimen types, cell block, direct smear, or cytospins. All of have their own positive and negative sides. So, how fast should test be results? From the clinician's perspective, the sooner the better. Treatment plans are often kept on hold until the oncologist has known the tumor genotypes. Indeed, a recent study demonstrated that less than 20% of the lung cancer patients had their tumor molecular testing results available at the oncologic consultations. Those patients who did have molecular results have significantly shorter time intervals to treatment choice and treatment starts than those patients who were still waiting for the testing results. The CAP guidelines recommend the following testing turnaround time. Testing should be available within 2 weeks for all site molecular pathology laboratories within 3 working days of receiving requests. So, which targets should be tested? Guidelines stratifies molecular targets in a tiered system. The top tier represents the must tier group of genes as these have proven and FDA-approved therapies. This tier includes the EGFR, ALK, and ROS, but with ASCO and NCCN guidelines also include BRAF in these mandatory test groups. The second tier groups are should be tested groups. They should be tested as a part of an extended panel either initially along with the tier 1 targets are negative. These should test groups include MET, significantly the MET exon 14 splicing mutation, RET, HER2, and KRAS. They show promising results from late-stage clinical trials. And finally, the third tier includes all other emerging genomic alterations that have potentially for treatment with targeted therapies. And there is an escalator effect in these tier classifications, with may tests becoming should test and should test becoming to must test status. Traditionally, molecular testing has relied on one gene, one assay model, and single gene assay for the tier 1 targets are still recommended as a viable first steps for EGFR, ALK, ROS for the CAP guidelines. However, for small biopsies or cytologic specimens with a limited amount of tumor material, this approach may not be sustainable as new testing targets emerge. The average percentages for each of the 8 major genomic alterations, including the tier 1 and tier 2 group represented in the figure, and the remaining are the tier 3 target groups. And I want to make a brief discussion of each of these targets. Okay, first start with EGFR. I want to discuss EGFR with a case. My patient is a 59-year-old female. She applied to hospital with 3 centimeter mass in the upper lobe of the lung, and we performed 5 times EBUS TBNA to the mass. And I'm going to show you the slides belongs to the EBUS TBNA. As you can see from the low magnification, it's very hypocellular. And when we look closer, we see scattered cells with eccentric round to oval nucleoli, and they resemble benign bronchial epithelium. Okay. And another area, we see these cells are trying to make acini structures, or they are crowded, or and they show nuclear overlapping, and sometimes you can see nucleoli in here. And in another area, the cells becoming more pleomorphic with eccentric round to oval nucleoli. Because of the similarity between the benign bronchial epithelium, we thought that it must be a well-differentiated adenocarcinoma, and we performed just 2 immunohistochemistry to the cell block, and we found TTF1 positive in these neoplastic cells and P14 negative. Since the cell block was hypocellular, the smear preparate was opened and scrapped, and RNA was extracted, and the next generation sequencing were studied. Why we choose NGS? Because if we study EGFR first and EGFR was negative, we don't have enough sample to make ALK and ROS in the tier 1 group. And we found EGFR points mutation in exon 21 in the NGS, and we put a note to our pathology report that this mutation is associated with sensitivity to tyrosine kinase inhibitors. So, as you know, EGFR is a member of ERK-B family, which is transmembrane thyroid receptor tyrosine kinase, and they regulate proliferation and apoptosis in the cells. Oncogenic driver mutation localized to the tyrosine kinase domain, and most clustering in the exon 19 and 21. And we have a number of approved tyrosine kinase inhibitors for EGFR mutations. However, disease progression is usually seen after 9 or 12 months of treatments, most often secondary to the acquisitions of a secondary T790M missense mutation in exon 20, which can be targeted with third generation tyrosine kinases. So, methods for detect EGFR rearrangements are PCR and sequencing-based methods, and most commonly real-time PCR. And in the latest CAP guideline, they said that at least 20% of cancer cells should be for detect these mutations. And in CAP guideline, they said should not use EGFR immunohistochemistry. And another method is liquid biopsy. So recent studies have demonstrated that lung cancer cells shed their DNA into the circulations at levels that are detectable with several modern technologies such as droplet digital PCR, allospecific PCR, and NGS. Analytic methods for cfDNA have high analytic specificity with very low false positive rates that can be used to guide treatment with a targeted inhibitor. However, sensitivity of cfDNA analysis is lower. This means is absence of mutation finding does not exclude the possibility of a mutation. And there is an overall correlation between burden of disease and prevalence of mutations in cfDNA. And we can use plasma cfDNA for identify EGFR T790M mutations with patients' progression or secondary clinical resistance to EGFR targeted tyrosine kinase inhibitors. Such testing is particularly appropriate because third generation EGFR inhibitors are proven to have significant benefit for T790M mutant cancers. And in the latest CAP guideline, they say that do not use circulating tumor cells for analysis mutations. Okay, let's talk about ALK now. My case is 70-year-old female patient. She had pleural fluids, malign effusions, and mediastinal lymphadenopathies. And I want to show the pleural effusion slides to you. As you can see here, it's very cellular, and when we look closer, you can see that it's very hypercellular slides. And when we look closer, the cells are very neoplastic, pleomorphic cells. You can see there is a giant cells in here. They are trying to make three-dimensional group. And it's very undifferentiated tumor. When we perform EGFR for these patients, EGFR was negative, and we test ALK with immunohistochemistry. As you can see in here, we use Ventana ALK D5F3 clone in the cell block, and you see there is diffuse positivity with cytoplasmic membranous positivity in the tumor cells. It's cytoplasmic granular and membranous positivity in all of the neoplastic cells. And also we confirmed the immunohistochemistry result with the next generation sequencing, and we found EML4 and ALK fusion. And ALK, how about ALK? ALK is a member of the insulin receptor tyrosine kinase family. In lung cancer, ALK can undergo gene fusion, and most frequently with EML4, and they fusion protein driving cells divisions and growth pathways. And there is growing numbers of approved inhibitors, tyrosine kinase inhibitors, such as crizotinib and alectinib and ceritinib. And they show efficacy in treating patients which have ALK gene rearrangements. Biomarker testing for ALK rearrangements have traditionally relied on FISH testings, which validated can be successfully applied to cytology specimens. The ALK cutoff probe is typically designed by labeling the 3' telomeric part of the fusion breakpoints with the 1 flochrome and the 5' central part with another flochrome. There are some differences between the different commercial probes in terms of the specific genomic regions covered by the probes and the different flochromes used for labeling. We accept the split pattern when the 5' and the 3' signals are separated. The separation between the 5' and the 3' signals must be 2 or more times the diameter of the largest signal. And this scheme is from the EICL guideline. At least 4 zones and 50 cells should be counted. We considered FISH positive if more than 20% of the tumor cells are positive. This 15% threshold allows errors due to background noise, reading, or abnormal hybridizations. If there are between the 10 and 50 positive cells, at least 20 cells should be counted with a second 50 cells count by a second reader. So FISH is a widely accepted reference method. It can detect ALK gene rearrangement independently of the partner gene. And it has their own limitations, such as needing 50 cells. But in the overall the lung cancers, 20% of the specimens don't have that much cells. And in the most recent CAP guidelines, we recommend that ALK immunohistochemistry equals the FISH results. And we have 2 clones for ALK now, D5F3 and 5A4 clones can be used for ALK rearrangement detections. In here, immunohistochemistry is an equivalent alternative to FISH for ALK testings. And you can see ALK specificity and sensitivity for the different clones very high, like 100% with specificity and at least 98 sensitivity. And another case, 75 years old male patients which have lung adenocarcinoma and ALK mutations, ALK rearrangements. He had crizotinib for 20 months, and 1 year ago he developed progressions and transferred to another tyrosine kinase inhibitor, and he had again progression under alectinib, and they performed EBUS. As you can see in the slides, it's very hypocellular again, but when we look closer, we see this acinar structure with adenocarcinoma morphology. And when we look to the cell block, it has very low neoplastic cells. As with EGFR mutated tumors, resistance mechanism eventually develop in ALK rearrangement tumors due to either ALK-dependent mechanism or ALK-independent mechanism, and we can detect these alterations with reverse transcriptase PCR or next generation sequencing for help to patients for using third generation ALK tyrosine kinase inhibitors. And we sequenced that patient's cell block too, and we found a point mutation which may be susceptible with third generation ALK inhibitor, and also found the EML4 and ALK fusion in these patients. And when we perform ALK immunohistochemistry, we found positivity in the scattered neoplastic cells. Okay, what about ROS? Again, I wanted to discuss ROS with my another patients. This patient is 62-year-old female, and she has EGFR ALK ROS and HER2 negative, PD-L1 positive, and she developed progression after 6 cycle immunotherapy, and now they send us her paraumbilical region aspiration for molecular testings. You can see this is the cell block, and when we look closer, we see neoplastic cells. You can see here they are performing acinar structures in here, and we try to we isolated RNA, but we don't have enough quality RNA from cell block. And we want patient's effusion slides. This is the slides of the effusion. It's very hypocellular. There are very few number of neoplastic cells. You can see here they are performing three-dimensional balls, and they have vacuole cytoplasm with pleomorphic nuclei. Again, we perform NGS to these patient's slides, and also performed Ventana ROS1 immunohistochemistry to the cell block, and you can see there is a diffuse positivity with the ROS1. The positivity is the membranous and cytoplasmic granular, and we found ROS1 fusion in the next generation sequencing. Like ALK, ROS1 belongs to the insulin receptor family and can undergo gene rearrangement with a large number of gene targets. ROS1 fusion protein drives pathways in cell proliferation, cell survival, and cell migrations. Tumor with ROS1 gene rearrangements show response to the multi-target tyrosine kinase inhibitors. Currently, testing for ROS1 fusion can be achieved through the RT-PCR and sequencing technologies and FISH break-apart for testing for ROS1 or ROS1 immunohistochemistry. For FISH, at least 20 tumor cells should be scored per specimens, and the cutoff value may vary according to the accumulated laboratory experience, including the hybridization protocol the ROS1 probe set used. The criteria for classifying split pattern in each clinical laboratory must be based on its interval validation studies. This point is crucial because the size of the probe differs among probe set designs, and the larger probe usually results in both a larger signal and the shorter distance required for the definition of a split. And we have two clones, immunohistochemistry clones for ROS, and in the latest CAP guidelines, they said that immunohistochemistry should be used, but we should test if we found any positivity, we should confirm this results. But ROS1 immunohistochemistry differs from ALK immunohistochemistry because ALK expression is virtually specific to the tumors with ALK gene rearrangement, whereas ROS1 positivity can be seen other conditions. Therefore, non-specific ROS1 protein expression may be seen in ROS1 negative tumor. That's why we see the percentage of the true positive immunohistochemistry results are very low. So when we see positivity in ROS1 immunohistochemistry, we should confirm this with FISH or sequencing methods. So what about BRAF? Unlike the cell surface tyrosine kinases, EGFR, ALK, and ROS, BRAF is an intracellular protein kinase, and it's involved in the MAP kinase signal pathway. And the most commonly encountered activation driver mutation is the V600E, and it has a specific FDA-approved therapy. And BRAF testings can be performed using PCR or sequencing-based method, as well as using immunohistochemistry with the VE1 clone. But there aren't any published studies to use BRAF VE1 clone immunohistochemistry on lung cytology specimens. And most recent CAP guidelines appropriate to test BRAF as part of larger testing panels, but both ASCO and NCCN recommended that BRAF belongs to the same must test status with EGFR, ALK, and ROS. So KRAS, my last case, 52 years old patient, he have a mass in the left lower lobe and have hilar lymphadenopathies, and EBUS TBNA was performed. As you can see from the low magnification, it's very cellular, and when we look closer, we see pleomorphic nuclei with performing acinary structures. And in the cell block, it's more than solid pattern. We perform TTF1 and found positivity and diagnose this adenocarcinoma. And we perform this patient's new NGS and found KRAS G12C mutations. As you can see in the pie, KRAS has a great place in the cake. And most of this part is composed of KRAS G12C. So why is this important? Because now we have a specific drug for G12C inhibitors. And a recent study showed that these drugs changed the tumor burden in the patients. So what about NGS in cytology material? As there is an increasing number of molecular markers to be tested, we have to do more with less. We wait for this, but we have this. Because of this natural process to use NGS, because many markers needed to be tested. And there are amount of papers using NGS on cytological materials, and all of them say that cytological materials are excellent for next generation sequencing. Even they discuss which preservation method is better, PUP or DIF-Quick or cell block. But in the overall, we can use a cytological specimen for sequencing. And as you can see here, cytological specimens mostly adequate for next generation sequencing. In the molecular cytopathology workflow, after microscopic evaluations of neoplastic cell content is carried out by the manual dissection of cytological samples, or laser, you can use laser dissections. Before extraction of nucleic acids, extracted DNA and RNA is adequately adapted for next generation sequencing analysis, specifically hybrid capture or amplicon-based platforms to define the molecular status of clinically relevant biomarkers. And two basic designs of NGA assays are used in molecular oncology, amplicon-based and hybrid capture-based. Both of these designs generate a library of amplified DNA or RNA that is sequenced as single molecules using one of several sequencing platforms. And in our departments, we tested 60 cytological non-small cell lung cancer specimen. And this is the distribution of our cases. As with the literature, we found the most common mutation is KRAS G12C mutation in our department too, and second is EGFR mutations. And what about immune checkpoint inhibitor? Immunotherapy is now part of the standard therapy, and it distributes the inhibitory signal between tumor cells and the immune cells, typically T cells. PD-L1 is on the tumor cells and PD-1 on the T cells. So how can we detect? We can detect with immunohistochemistry or tumor mutation burden with NGS or neoantigen from whole exome sequencing data. Today I want to talk immunohistochemistry. We use tumor proportion score for non-small cell lung adenocarcinoma. What is tumor proportion score? Tumor proportion score is percentage of the tumor cells showing partial or complete membranous staining of any intensity for PD-L1. Currently, 5 different predictive biomarker EEK assay were available and 5 different drugs using variable cutoffs for positivity. And each drug has paired assay consistent with different antibody clone. For example, nivolumab for DACO antibody, and it used at least 50% of TPS score. Or CP263, it used at least 25% TPS score. In the latest CAP guideline, they don't recommend PD-L1 because they don't have enough evidence supporting specific method or agents. But a new guideline is planned to focusing specifically on evidence-based evolution of methods to select patients who receive immunomodulator therapies. And as our results of PD-L1 cytology specimen equivalent to surgical biopsies and resections, yes, there are many studies comparing cytological and surgical material PD-L1 evolutions. In these studies, when samples with less than 100 cells were excluded from cytological materials, a very high concordance was found. Therefore, it would not be wrong to consider at least 20 cells as a threshold value, especially in the cytological material. So an article from our institute showed the same results. On the cytological cell blocks and the surgical resection specimen, PD-L1 expression generally was membranous with or without a light cytoplasmic staining and may have been expressed homogeneous or heterogeneous through the tumors, complete circumferential or partial linear cell membrane staining on tumor cells, and any intensity is enough for saying positive. So, what types of cytological specimen can be used? It's feasible on all cytological preparations. And with cytological preparations, most published PD-L1 studies on cytological specimens, including the part of the blueprint phase 2, have been performed on cell blocks. Although concordant with matched histological specimens and promising, they are limited that only used in the pop slides relative to cell blocks. So what are the advantages of cytological specimen? First and foremost, cytology specimens represent a significant proportion of lung cancer specimens and therefore provide greater access to patients for potential systemic therapy options. Second, the back and forth or fanning tissue destructive motion of FNA occlusion, the advantages for sampling So what are the potential drawbacks of cytology specimens? It's the low yield and insufficient cellularity, and there can be false positive staining in the macrophages. So which type of cytology preparations? You can use FFPE cell blocks, and in the future, dual immunohistochemistry staining can be used for differ the neoplastic cells from the macrophages. Finally, when we come to the key points, biomarker testing in lung cancer is a rapidly evolving field with new test targets appearing regular. Biomarker testing has become standard of care for the advanced non-small cell carcinoma, and it's got appropriate treatment selection. And guidelines recommendations published by various groups broadly outline requirements for molecular testing, including which targets to test, how to test, and how results should be reported. And immune checkpoint inhibitor therapy has emerged as an important therapeutic modality in non-small cell lung cancer, and therefore routine PD-L1 biomarker testing has also become the standard of care. And cytologic specimens are adequate testing substrates for biomarker testings in non-small cell lung carcinoma. Those are the references. And I want to thank you for listening to me.
Thank you, Chisa, for this nice and comprehensive presentation of yours about biomarker testing in lung cytology materials. You covered almost all important and critical points when dealing with cytology material and management of lung cancer patients. I think you had one question and you have in the chat box, and you have already answered in the chat box, and I see no other question. As we are running a bit out of time, I'd like to pass to other speaker, but maybe you can share your experience with us very briefly. What is the most common problem you encountered during making these tests in your daily cytological practice? The hypocellularity of the specimen, the way of the fixation, what is it, your personal experience? Briefly, please.
Yeah, okay. Hypocellularity is the most common problem, actually. And actually for communicate with oncologists is another problem, because they want a very large panel, but we don't have enough material. So I think two of them are taking my time mostly during the routine practice.
Yeah, these are the most critical parts of dealing with a lung cancer patient. If it is a cytological material, we must put an extra effort to handle the material. It is very important. So I see no other question, and I'd like to thank you again and turn to microphone over Dr. Yasemin Özlük for her speech, which is a case discussion in lung cytology. Dr. Yasemin Özlük received her medical degree from Istanbul University, Istanbul Faculty of Medicine in 1999. She completed her residency in the same department and works as a professor of pathology in the same department since 2005. She is mainly experienced in cytopathology and nephropathology, and her other areas of interest are genitourinary pathology, pulmonary pathology, as well as molecular pathology, and she is currently one of the board members of Turkish Society of Cytology. Thank you, Yasemin, for being with us today, and the microphone is yours.
Dear chairs and dear participants, before I begin, I'd like to thank the organizing committee for giving me this opportunity. In this session, I will share cases of lung cytology from our department. I am Yasemin Özlük from Istanbul University, Istanbul Faculty of Medicine. I have nothing to disclose for this presentation. Okay, let's start with our case 1. This is a 71-year-old man who has a subpleural 14 millimeter mass in left upper lobe. A transthoracic FNA was performed under CT guidance, and the clinical diagnosis was lung carcinoma. When we look at the smear slides, we can see that there is an extracellular acellular material in the background, and we can see these cells within this matrix. Here, again, we see the extracellular material, which looks homogeneous. And we see these cellular fragments, which look like some spindling cells, and again, this material. So we have a cellular component and an acellular component. Here we see these multinucleated giant cells. Again, one of giant cells is also seen here. And we can see that in these cellular fragments, there are neutrophils, maybe some macrophages, and some cells which have these spindle cytoplasms. On high power field, we can see again the same cellular features and giant cells. And this amorphous material is more look more smudgy in some areas. And we can see here that this giant cell try to ingest this acellular matrix. Here again, these cellular fragments, and in all areas, the morphology look similar. Maybe we can think of some type of granulomatous reaction here. We see these spindle nuclei, which some places look like footprint sign. This may come from a granulomatous reaction. So what are the differentials? This may be a non-small cell lung carcinoma, but this is unlikely, I think. There is a granulomatous inflammation with foreign body reaction. This may be related to an infection. Or these spindle cells may be coming from a granulation tissue, a scar tissue in the lung. But what is this extracellular matrix? We thought that during the sign-out, this may be an hyalinized stromal fragments or some spindle cell proliferation. And in our report, we described our findings and mentioned these multinucleated giant cells. And we put our differential diagnosis entities as low-grade mesenchymal lesions or maybe reactive proliferations. And they did a PET scan in this patient, and they saw that the mass seen in the lung does not show an increased levels of uptake with PET scan. And the patient underwent left upper lobe wedge resection. On gross examination, we can see that this subpleural nodular mass was 1.2 centimeter in diameter. And it's a very well circumscribed lesion. And here is the adjacent lung parenchyma, and we don't see any specific features in the neighborhood in this lung parenchymal tissue. But here we see this pink amorphous material seen within this nodule, and there are some ossification and some giant cells and some lymphocytes in the stroma. And like in our cytology slides, we can see that this multinucleated cells try to ingest this material, and this is very same at the histologic sections of the resection material. Here are the multinucleated giant cells, ossification, and these pink amorphous material seen in the tissue. So in pathology, if we see these pinkish amorphous extracellular acellular material, then we first think of a possibility of amyloidosis, and we did a Congo-red stain. Under polarized light, we can see this. We can see that this is a very nice apple green birefringent with this polarized light, and this accumulation of eosinophilic material is consistent with amyloidosis. The AA immunohistochemistry was negative, and with the antibodies kappa and lambda, we see that the amyloidosis shows lambda monotypia. So this case is diagnosed as primary amyloidosis, which shows lambda monotypic amyloidosis. So we go back to our cytology slides, and the extracellular matrix that we saw on our smear slides, our differentials were hyalinized collagen, fibrin, amyloid, and light chain deposition. And we repeated our Congo-red stains on previously stained cytology slides, and we saw that this cytologic material also shows apple green birefringence under polarized light. So amyloidosis could be seen in the cytology preparations. And afterwards, the patient underwent a bone marrow biopsy and get a diagnosis of multiple myeloma. So pulmonary amyloidosis may be either in systemic form or localized form. And any type of amyloid can be seen in lung parenchyma. There are two scenarios in which we see amyloid in the lungs. First is that the disease is a respiratory system disease, which complicates a systemic amyloidosis, Or maybe there is a systemic or localized amyloidosis, which involves the respiratory system. AA amyloidosis, which is also called reactive systemic amyloidosis, not expected to be seen in lungs. There are only some case reports showing AA amyloid in the lung parenchyma. And tuberculosis, bronchiectasis, cystic fibrosis, which are primary respiratory system diseases, may cause reactive systemic amyloidosis. The lambda amyloidosis, which is also called primary amyloidosis, may be either in systemic or localized forms. Systemic forms may be related to some monoclonal B-cell dyscrasia or Sjögren's syndrome, which can involve the respiratory system, or maybe the lung may secondarily affected with the presence of a multiple myeloma like our case. When lung shows localized amyloidosis, it can be in 4 patterns. The respiratory system may show localized amyloid in larynx, in the tracheobronchial tree, and the lung parenchymal involvement may be seen as solitary or multiple nodules, or diffuse alveolar septal pattern. So there are 2 types of patterns, which is nodules or diffuse alveolar septal pattern in the lung parenchyma. There also can be mediastinal and hilar amyloid lymphadenopathy. The parenchymal primary amyloid is the most frequent form. When we see these nodules, they are mostly localized lambda type amyloidosis. When it's a systemic amyloidosis, we most frequently see diffuse alveolar septal pattern. Can we diagnose amyloidosis by cytology? Of course we can, but first we should think of a presence of amyloid on slides. And amyloidosis can be accurately diagnosed by FNA, and we always should consider malignant tumors such as carcinoid tumors, which usually sometimes may show amyloid in their stroma. We should think of this entity in the differential. So the presence of amyloidosis does not exclude the possibility of a malignant tumor. Do we see granulomas along with amyloidosis? Yes, we can. In nodular forms of amyloid, we can see granuloma in 67% of the cases, and they are associated with osteocartilaginous metaplasia. As you remember, in our case, we saw some granulomatous reaction on the slides, but we could not demonstrate granulomas on the tissue. And primary pulmonary lymphomas may show granulomas in 80% of the time. So, last verse of case 1, we should pay attention to extracellular material present on the slides. Congo red stain can be performed on previously stained cytology slides and should be interpreted under polarized light. Amyloidosis is frequently in primary form when the lungs get involved. Calcification, ossification, multinucleated giant cells, and even granulomas may be present in an amyloidoma. Pulmonary involvement may rarely be the initial presentation, and our case is an example of an initial presentation of multiple myeloma with a nodular amyloid deposition in the lung parenchyma. So let's move on to our case 2. 68-year-old man presented with a 5 centimeter mass in right lower lobe, and this is PET positive. During bronchoscopy, no endobronchial lesion could be detected, and the patient underwent a transthoracic FNA, and the clinical diagnosis was lung carcinoma. Here we can see this mass, this nodular mass, which is suspicious for a malignant tumor. And at the PET scan, we can see that the PET is positive at the peripheral regions of this nodular lesion. On FNA smear slides, we can see that the background is highly crowded and looks some necrotic cells. Here, these are the large cellular groups, they are small cellular groups, and we see these extracellular material present, which looks like the one we saw in the previous case. Here also again these extracellular material and a mixture of cells here. We will go further in detail these cells present on the slide in the next slides. And here is again these amorphous extracellular material. And when we come to the cells, we can see that there are some atypical squamous cells in the background. Neutrophils, lymphocytes, maybe plasma cells, and here again atypical squamous cells, and these aggregates of cellular structures and this necrotic background. In some of the cells, we can see these eosinophilic nucleoli and abundant cytoplasm. But these cells somewhat look like polygonal cytoplasm they have, and maybe they are metaplastic or atypical alveolar epithelial cells. They may be, why not? Here again, these neutrophils and these mixture of inflammatory cells, and this is extracellular material. And here we can see these spindled nuclei, which remind us about the possibility of a granuloma. These are the atypical cells which have vesicular nuclei with nucleoli and these polygonal shaped cytoplasms, which reminds us about squamous metaplasia or alveolar reactive atypical epithelial cells. So what are our differentials? This may be an amyloidosis. This extracellular matrix may be colloid, and then thyroid carcinoma metastasis we should put in under our differential diagnosis. This may be a non-small cell lung carcinoma, mostly consistent with squamous cell carcinoma with the presence of this necrotic background, these atypical squamous cells, or this may be an infection-associated granulomatous inflammation with atypical squamous cells. You know that atypical squamous cells are frequently present in infectious diseases and cavitary lesions in the lung. Now we start to see these multinucleated cells, these extracellular material, and this looks some compact or maybe chunky. Here is more thinner than the other parts, but in some places we can see that this is a very compact extracellular structure, and it looks pink with top stain. These are again these atypical cells which look highly metaplastic to me. And this material is positive with Giemsa stain. We see that these inflammatory cells on the background, which forms these cellular aggregates, are macrophages. Because when we look at the high power, we can see that the cytoplasm of these cells are look vacuolated, they look very foamy, and they are the foamy macrophages, which in some places try to form granulomas. And here we get it, we see these nice granuloma. Here we can see this granuloma with the spindle nuclei, and in some places, this nuclei mimics footprints on the sand. Here also again, we see this granulomatous reaction. These foamy macrophage aggregates, and we can see that there are bronchial epithelial cells here with this cilia and terminal plaque here, and the nuclei is different than the cells we see at the other sides. Now we get new clues going to our diagnosis. We see that this amorphous acellular material in some places look laminated. And this laminated structure of this acellular matrix, we start to think about the possibility of hydatid cyst. This is the cell block section. We see here this eosinophilic acellular extracellular material, and here we can see this laminated structure, and also we now see our granulomas, and this is the inflammatory cells which contain neutrophils and lymphocytes. This is the cytology picture, and this is the cell block. We can see that these are the granulomas, and these are the PAS positive laminated membrane structures which are consistent with hydatid cyst. Very nice lamellation seen in this membranous structure. So we have granulomatous inflammation, we have a laminated membrane which is consistent with cuticula, and our diagnosis is cystic hydatid disease. Unfortunately, we could not see any scolex or hooklets in this patient. This patient was an immunocompetent patient, but in the clinical history, we demonstrated animal contact and the ELISA test was turned out to be positive. And the patient put on albendazole treatment and surgery planned. Unfortunately, we haven't get the surgical excision material yet. But this is another example of a pulmonary hydatid cyst from our archive, and we can see this cuticula, this white membranous structure on gross examination. And this is another case from another cyst hydatid, and we see these scoliosis and these hooklets, which are highly diagnostic of a cystic hydatid disease. Here we can see that this is a freshly prepared smear from the cyst fluid, and we can see that these birefringent hooklets can be easily seen with these freshly prepared smears. Lungs are the second most common site of involvement of hydatid disease, and with the long-standing infection, this disease may mimic malignancy. The diagnostic cytomorphological features of hydatid cysts include cuticula, scoliosis, and hooklets. And the hooklets are pathognomonic, but the presence of cuticula is presumptive. Do we see granulomas in hydatid disease? Yes, when we look to the literature, we can see that in any localization, and mostly the subcutaneous localizations was reported, that pulsating granulomatous reaction may be seen in hydatid cyst. And when pulmonary hydatidosis gets complicated, such as bacterial infection, fungal colonization, or tuberculous granulomas, we can start to see granulomas. And even bronchocentric granulomatosis, which is mostly seen in asthmatic people, without the presence of asthma, hydatid disease may accompany it by bronchocentric granulomatosis in the lung. FNA is mainly contraindicated in the diagnosis of hydatid disease due to the risk of dissemination and the possibility of anaphylaxis. But because this lesion mimics malignancies, then the patient goes to FNA. And FNA is diagnostic for hydatid disease if we see scoliosis, hooklets, and cuticula. So the third question comes to my mind about this case is that whether hydatid disease may coexist with a presence of a carcinoma. This is the only paper in English literature I could find that there is a lung carcinosarcoma originated along the outer surface of the hydatid cyst wall. Because we don't have the excision material yet of our cases, we don't know whether our patient had a coexistent malignancy. So take-home messages for this case is we should pay attention to extracellular material present on the slides, like the first message of case 1. Granulomatous reaction may be present in hydatid disease, and hydatid cyst may mimic malignancies. Case 3 is a 73-year-old man with a mass in right upper lobe. Percutaneous FNA was performed, and a needle washed out into a preservative solution for liquid-based cytology. This is a highly cellular preparation of liquid-based cytology, and we can see that there is a monotonous looking small round cell tumor present on the slide, and these are all apoptotic cells in the background. So this is highly apoptotic lesion, which has these small round cells, and the cells are mostly seen as individually, and in some places they get together. Here we can see these cells try to form a group here also. And in some places we can say that there is molding between these cells. Here also again molding. And the chromatin looks somewhat granular. Maybe remind us about salt and pepper chromatin pattern of neuroendocrine tumors. And here is again these apoptotic bodies at the background. And these are the cells, naked nuclei, here we see. Molding again present. So we think about small cell carcinoma or non-small cell carcinoma, but because the cells look, the cells have scant cytoplasm and the cellular morphology most consistent with small cell carcinoma, maybe this may be a lymphoma or sarcoma. So we need to perform immunocytochemistry for correct diagnosis. In this patient, no available cell block was present, and we performed immunocytochemistry on newly prepared liquid-based cytology slides. This is the pancytokeratin. Because the cells are intact on cytology slides, the immunocytochemical antibodies look positive on each part of the cell because the cytoplasm covers the nuclei. So these are, and we hardly see the nuclei of the cells. These are pancytokeratin positive tumoral cells. This is P40 because basaloid squamous cell carcinoma is one of the differential diagnostic entities of small cell lung carcinoma, and P40 is negative. Chromogranin A was negative. When we come to synoptophysin, it's hard to decide whether this is positive or not because there is some background staining. And here we see this cytoplasmic positivity. And in some places, it is more easily seen. TTF1 is positive. In immunocytochemistry, in my experience, nuclear markers are more easy to interpret. But when we come to cytoplasmic antibodies, then the interpretation has some challenges. And this is very nice nuclear positivity for TTF1 antibody. Ki-67 is a very helpful antibody that we use in differentiating neuroendocrine carcinomas into grades. And in this case, Ki-67 was shown to be over 80% or maybe 90%. So it's a very high proliferative index present. And this is small cell lung carcinomas. So cell block is the gold standard for our ancillary testing. But sometimes we don't have available cell blocks or the cellularity of the cell block may be insufficient. So we need to do our additional stainings on cytology slides. Any type of cytology preparations such as smears, cytospin preps, or liquid-based slides are appropriate for immunocytochemistry. But there are some problems, pitfalls of immunocytochemistry, which are, for example, our material may be scarce with low cellularity, or the number of slides may not be enough for all antibodies that we want to see. Usually there is a lack of controls, but in some centers with a previously known antigen panel, for example, about some effusions, they have control slides, but we don't use controls for cytology material in our department. And lack of a standardized fixative is another pitfall because we have air-dried smears, we have wet fixation. And as in our case, sometimes we can see background staining and we can have difficulties in interpretation. So for immunocytochemistry, optimization is required for best results. So last verse about small cell carcinoma and ICC pitfalls. Chromogranin A is usually positive, but when it's positive, it's focal and weak. So in low powers, we can just say negative and go to another slide. But we need to go to high power and be sure that the chromogranin A is negative, because in the high power, we can see the nice positivity in the cytoplasm. CD58 is the most sensitive but least specific marker. And these neuroendocrine markers may be negative in less than 30%, in less than 10% of small cell lung carcinoma cases. So we should remember that. And positivity for neuroendocrine marker is not required for a diagnosis of small cell lung carcinoma, but this is not true for large cell neuroendocrine carcinoma. Keratins are mostly positive, and they may be in dot-like pattern, but this is not a rule. It can be cytoplasmic, not dot-like. But we should remember that in cytologic materials, keratins may be negative. Chi67 is helpful, and helpful for what? Helpful for differentiating low and intermediate grade neuroendocrine carcinomas from high-grade carcinomas. When you go through the literature, you can see some different cutoffs for this differentiation. They say that 20 to 25%, you can say that 30%, if 30%, if the proliferation index is 30%, then we can say that this is a high-grade neuroendocrine carcinoma. If we take this cutoff to higher levels, for example, 50%, 60%, 70%, then our specificity increases. Take-home messages for this case is that immunocytochemistry can be performed on cytology slides, but optimization is necessary, and Chi67 is very helpful in the diagnosis of high-grade neuroendocrine carcinomas. Case 4 is a 39-year-old man which had coughing for 2 months, and he has a 2-pack year smoking history and lost 4 kilos in the last 2 months. And he had a pleural effusion, and thoracentesis was performed. There was 40 cc clear yellow fluid, and we prepared cytospin slice and cell block. Here we can see these 3-dimensional adenoid groups in this effusion, which make us think of adenocarcinomas. And here we can compare, these are the mesothelial cells which are binucleated, which have fenestra between cells, and this is 3-dimensional group of adenocarcinoma cells. In Giemsa stains, we can see these intracytoplasmic mucin droplets. This is the cell log. We can see these, again, adenocarcinomas. Our immunohistochemistry panel revealed cytokeratin 7 positivity, TTF1 nuclear positivity, and so this case is an adenocarcinoma with pulmonary origin in the pleural effusion. PET scan showed intraparenchymal 1.5 centimeter nodular opacity in the left lower lobe, and there are multiple mediastinal lymph nodes and bilateral supraclavicular lymph nodes also. So molecular tests requested, and we performed EGFR and PD-L1 on cell block, and they were both negative. And we performed break apart FISH analysis on ALK and ROS1 on cell block. And here we can see that in a normal cell, we see 2 green and 2 red signals, and green and red signals may present together. So we should have 2 yellow signals. But when there is a gene rearrangement in ALK gene, we should see that the green and red signals break apart, like here. And in this case, we saw 54% of the cell showed these positive signals, and most of them were break apart signals, and in 13%, we saw isolated 3 signals, which are these red dots in the cell. So this is an ALK positive case, and the patient put on tyrosine kinase inhibitor for ALK, which is the 2nd generation drug. And 4 months later, the patient developed resistance to the drug. And new PET-CT scan showed bilateral pleural effusion, pericardial effusion, and his disease progressed under treatment, and with the addition of COVID-19 pneumonia, the patient deceased within 18 months from the initial diagnosis. So molecular testing on cell block is the gold standard, And if cell block is lacking, we can perform molecular tests on cytology slides. Cytology slides are ideal for PCR-based tests, and validation is required for FISH analysis. Cytology slides, if we use cytology slides for FISH analysis, we have some disadvantages and advantages. The disadvantages are that the evaluation of malignant cells in a dark field is generally complicated, and threshold for a positive result established for tissue slides. So each lab needs to determine its own threshold for cytologic material, and selection of the type of slides to perform FISH is critical, whether it's air-dried smear or pap-stained smear, so it depends. Cell overlapping makes the interpretation difficult, but we have some advantages also. We avoid signal loss by section truncation artifacts on cytology and adequacy for sufficient tumor superior to cell blocks, and we can have automated platforms which combine morphology and FISH assays and helps us to select the tumor cells on a background having non-tumoral cells. This is an example of a case of our archive that we performed FISH on cytospin slide, and with the help of this software, we analyzed the tumor cells become to be negative for ALK translocation. So cytologic materials are appropriate for molecular testing. FISH testing can be performed on previously stained cytology slides. Pleural fluid is an optimal material for molecular tests with numerous viable tumor cells. So case 5 is a 23-year-old female who has 3 centimeter mass in right upper lobe and is PET positive. CT-guided transthoracic FNA was performed with a diagnosis of lung carcinoma. Here we can see that the aspirates are cellular, and we have these small round cell groups, and the cells show overlapping, and we can see that some rosette-like or adenoid-like structures, these cells come together forming these round appearance. It looks monotonous. The cells are uniform. Here, no, not that much of nucleoli we can see. They are not very prominent. Here, again, these round cells, and maybe they have clear cytoplasm. No nucleoli, no specific features, no neuroendocrine chromatin, I guess, but why not? Maybe neuroendocrine tumor is in the differential. Clear cytoplasm. This is the Gimza stain. So this looks like maybe adenocarcinoma, low-grade adenocarcinoma it may be. Carcinoid tumor with these rosette-like structures and uniform appearance, or maybe salivary gland type tumors. We know that salivary gland type tumors are present in the lung, and the ones with basaloid morphology may look like this tumor. But there are more on slides. We can see these hyaline structures, these hyaline globules. Some of them are naked, some of them are within these glandular structures on the slide. And these are metachromatic with Gimza stain. Here also. You see these are the naked, these are not cells. These are naked metachromatic hyaline globules, and these are the tumor cells. This is a cell block, very similar features to the smears. And here you can see these hyaline globules in the cell block also. So adenocarcinoma still under our differential diagnosis. Carcinoid tumor, salivary gland tumor still is present in the list, especially the adenoid cystic carcinoma. But with the presence of these hyaline globules, we should at least 3 tumors under differential. Renal cell carcinoma, yolk sac tumor, and clear cell carcinoma of gynecologic tract. This is the immunos. TTF1 and napsine is negative, P63 is negative. So what is it? We were lucky in this patient because we had the history. The patient had a history of clear cell carcinoma of the uterine cervix and 1 month also had a vaginal recurrence of this clear cell carcinoma, and these are the pictures of tissue biopsies. So we added 2 antibodies to our panel, which is hepatocyte nuclear factor 1 beta, which is nuclear positive in this case, and PAX8, which should appear to be positive in gynecologic system tumors, and this was also positive. Here you can compare the cytologic features with these hyaline globules to the tissue, which also show these hyaline globules and clear cell cytoplasm. So this is consistent with metastatic clear cell carcinoma of the uterine cervix. Hepatocyte nuclear factor 1 beta is reported to be a specific marker for clear cell carcinoma, but we can see that in a large series, pancreatic carcinomas, cholangiocarcinomas, gallbladder carcinomas, stomach carcinomas, and even 1/4 of lung adenocarcinomas may also be positive for hepatocyte nuclear factor 1 beta. So we should pay attention to this positivity and we should use it in a panel. The clone also differs, Atlas or Santa Cruz antibodies. Atlas antibodies show minimal background, but maybe more positive in lung and gastrointestinal tract carcinomas. Santa Cruz antibodies show cytoplasmic and background staining, but better for differentiating clear cell carcinomas from serous carcinomas. This is an old paper, but very nice series which analyzed metastatic clear cell tumors which are diagnosed by FNA. And this series had 12 pulmonary metastases of clear cell carcinoma, and one of them was a cervical clear cell carcinoma like our case. So take-home messages: clinical history is crucial for differential. Metachromatic extracellular material is a clue in morphology. Hepatocyte nuclear factor 1 beta and PAX8 immuno, although not specific, are helpful diagnostics. And we should be careful with this antibody, HNF1 beta, particularly in the setting of metastasis from an unknown primary tumor. So we move on to our last case. This is a 92-year-old man, no previous history of malignancy and right lung mass in thorax CT, and the patient underwent bronchoscopy, no endobronchial lesion detected, and bronchial lavage was sent to our lab. This was a 40 cc lavage with cloudy yellow, blurry, and bubbly appearance. We prepared 2 slices and stained with PAP. And here we see this necrotic background. And here we see this hyperchromatic nuclei. The NC ratios are high. The cytoplasm are hardly seen. Here, these cells you see, and the necrotic cells on the background is present. These cells somewhat look like squamoid. So we say that we reported this case as atypical squamous cells, suspicious for malignancy, and we had necrotic cells in the background. Then the patient underwent FNA. And there is a clinical finding that his mass was multiple and bilateral in the lung. Here again, the preparations of the FNA material. The cells are small. They have eccentric, scant cytoplasm. The nuclei are hyperchromatic. Here is the hyperchromatic cells. They somewhere show some, maybe try to form glandular structures, 3-dimensional groups. Sorry. And necrosis. And in this Giemsa stain, we see similar features. Again, these look like adenoid structures. Scant cytoplasm, no nucleoli. This is the cell block. Here are the cells with these apoptotic bodies, and this is pleomorphic tumor cells. So for all lung materials, we perform immunospore subtyping, and we perform mainly TTF1 and P40. TTF1 was negative and P40 was positive. So, is this a squamous cell carcinoma? We have bilateral multiple masses. Sometimes primary lung carcinomas may present with these multiple tumors. This may be either primary or metastatic. And P40 positive tumors are mainly squamous cell carcinomas, salivary gland type tumors, and urothelial carcinomas. So we go on with our panel. This is cytokeratin 7 and cytokeratin 20. They were both positive. And because these were both positive and because of the morphology, we also ordered GATA3. And GATA3 was also positive. And we signed out this case as carcinoma, non-small cell carcinoma, but most consistent with a metastatic urothelial carcinoma. And we suggested investigation of the urinary system. And we reached this data that the patient had hematuria and he has been having intermittent self-catheterization for many years. And he had diagnostic cystoscopy, which appeared to be normal. And this lung masses was detected during the preparation for anesthesia of this cystoscopy. So we suggested to look for ureters and renal pelvis. And the patient had total abdominal MRI and renal pelvic mass was detected on his right kidney. And urine cytology was sent to our lab. And we here see these atypical urothelial cells, these hyperchromatic and these tailed cytoplasm, hyperchromatic nuclei, again this tailed cytoplasm, hyperchromatic nuclei. And we signed out this case as atypical urothelial cells suspicious for high-grade urothelial carcinoma. So let's review cytomorphology in metastatic urothelial carcinomas. They show papillary fragments, syncytial clusters, pleomorphic vesicular nuclei with small multiple nucleoli, scant to abundant vacuolated cytoplasm, and multinucleated tumor giant cells. And in literature, you can see a type of cells which are called sarcariform cells, which has shown to be a useful clue for the diagnosis of urothelial carcinomas. They are nucleated globular bodies with unipolar, non-tapering cytoplasmic processes, which looks like fishtails. This is the cells from our case. You see these cells, not very typical, but I think they look like these sarcariform cells described. So are all P40 positive carcinomas of the lung squamous cell carcinomas? Of course not, although most of the time it is true, but cytomorphology and clinical and radiologic findings are important for correct diagnosis. So last messages from case 6 is keep metastatic tumors always in mind in lung cytology. None of the immunomarkers is specific and should be used as a part of a diagnostic panel. Detailed clinical information is important for a correct diagnosis. Upper urinary system tumors should be remembered in any suspicion for urothelial carcinoma, especially in patients with normal cystoscopy findings. I'd like to thank you for listening, and I want to send special thanks to cytopathology team in our department, and especially Dr. Doğu Bakkaloğlu and Dr. Hafize Özdemir for their great support during the preparation of this presentation. Thank you very much.
Thank you very much, Yasemin, for these excellent cases and beautiful images, and most importantly, the very important messages you gave us at the end of each case. I think this has been a very educative session. Thank you very much for sharing again. When I turn to chat box, actually, I see the chatting between you and another participant also called Yasmin. Hello to her here. And you already finished a question and answer session between yourselves, and I think other participants also saw them, which is beautiful. But at the last second, I've got one question. PAX8 positive, Vimentin negative, and WT1 negative is quite specific for endocervix, even in the absence of P16. The PAX8 does not mean my threshold for positive, but it can be funny in clear cell tumors, and we have appropriate history. This is a comment, actually, not a question. Do you have any comment on this?
No, I thank for the comment of this participant. And I hope everyone enjoyed this presentation.
Yes, you are having thank yous. I also thank you again, and all other speakers, two other speakers of this session. As we are running out of time, I am closing this session and giving a 10 minutes of break, and hope to see you after 10 minutes. Thank you very much again, everybody, and bye. Herhalde çıktık yayından. Tamam.
Oylama olmadı gene.
Oylamalar iyi geliyordu, sonra bir şey oldu. Bana da gelmedi. Bana da gelmedi.
Gelmedi değil mi?
Okay. Tamam Ayşe Hanım, teşekkürler. Now, the lung was in the morning. Now it's time for thyroid. And in this session, we are going to have two talks. And one of them is going to be my talk. And I'm not going to talk on cytology as aspect, but I will try to give you some baseline information on the histopathology classification of thyroid tumors. I think we can begin now. Good afternoon, friends. This is the second session today with me. And in this session, I'm going to talk about thyroid tumors. Let me share my screen with you. We are going to talk on the histopathology of thyroid cancer in this session. And as you know, we have the classification, the last classification was in 2017, but they are, I guess, preparing the next edition now. And next year, this time, we will have a new classification, I guess. But at the moment, we in this latest classification, we have tumors from follicular cells that are thyrocytes and the parafollicular cells, and we are going to go on with them shortly. Now, in the thyroid, if we think that there is a spectrum from benign to malignant and more malignant, then in the most benign spectrum, we have follicular adenoma and hyalinizing trabecular tumor. And then we have well-differentiated thyroid carcinomas that are the PTC and FC. And in the most malignant part of the spectrum, we have anaplastic thyroid carcinoma. And we have in the spectrum another entity in between well-differentiated thyroid carcinomas and anaplastic carcinoma. We have poorly differentiated thyroid carcinoma. And also in the spectrum, we have NIFT-P, and we have a totally different animal, which is the medullary carcinoma. These are the entities that I'm going to discuss about today shortly. First, let's talk about the organization of thyroid tumors. We know the normal thyroid follicle, which is roughly a spheric structure, and we have follicular cells that are thyrocytes around, and we have the pink staining colloid in the center. We may have likened it to a soccer ball like this, and the cells like that, and in between, in where the air is, we have the colloid in the center, but we see them in two-dimension naturally in our sections. And the follicular organization is either microfollicular or macrofollicular or the normal-sized follicles we can have. But this is one of the organizations that we see in benign and malignant thyroid tumors. And also we have the papillary organization in thyroid tumors. That means papillae with fibrovascular cores that we may have likened it to a arborizing tree, branching tree. And we have a STI pattern, that is the solid trabecular insular organization. By the trabecula, we mean tumor cells forming cords separated by stroma, like so. And by solid organization, solid pattern, we mean diffuse infiltration of tumor cells without an organization, like so. And we may have insular, that is island-like pattern, groups of tumor cells surrounded by stroma, like so. So in the epithelial tumors of the thyroid, there are some major immunohistochemical features. That is, in the thyrocyte-derived lesions and C-cell-derived lesions, we have cytokeratin positivity. In the thyrocyte-derived lesions, we have TTF1, thyroglobulin, and PAX8 positivity. But in the C-cell-derived part, we have TTF1, but not thyroglobulin, obviously. And by PAX8, if we are using the appropriate clones, we
we do not see any staining. But cell-derived lesions have calcitonin staining, can have carcinoembryonic antigen staining, and neuroendocrine markers are positive in these tumors. By neuroendocrine marker, I mean chromogranin and synaptophysin. In this classification, we have these entities, and the organospecific markers that are thyroglobulin, TTF1, and PAX8 are going less and less and to non-existent when we go on the scale from benign to malignant. Now let's talk about follicular adenoma, HTT, and well-differentiated thyroid carcinomas firstly. First, let's go on follicular adenoma. Follicular adenoma is the benign tumor of thyroid follicular cells. It's encapsulated, it's non-invasive. This is a tumor that means being neoplastic needs monoclonality, and monoclonality is the key feature to decide between adenoma and adenomatoid nodule. But in this context, morphology alone is not helpful to decide on monoclonality, and differentiation is not so much necessary for management. So we are lucky. We can go with the morphologic features, but morphologic features do not really consistent with molecular features. Follicular adenoma is usually a single solid nodule, and it's solid white and demarcated lesion. It usually has a hemorrhage because usually they are needled. The capsule can be thin or thick in some cases, and the inside and outside are usually architecturally distinguishable from each other. That's one criterion that we use to call it an adenoma. They can be microfollicular, macrofollicular, normal follicular, but we may have solid trabecular insular pattern also in follicular adenomas. But the main feature is that nuclei are round and uniform, and mitosis are rare. In follicular carcinoma, on the other hand, which is the malignant counterpart of follicular adenoma, we have a follicular tumor without the characteristic nuclei of PTC. It's usually well encapsulated, but we have to have invasion, that is vascular or capsular invasion. Follicular carcinoma incidence is not much among thyroid carcinomas, and the incidence is declining in many countries. It's a tumor that is very related with iodine insufficiency, and most of our patients are women, and follicular carcinoma likes to do a hematogenous distant metastasis, that is to lung and bones mostly, but also to other organs. The molecular features of follicular carcinoma and also the follicular adenoma are quite different from, for example, papillary thyroid carcinomas. They have RAS mutations, PAX8 PPAR gamma rearrangements, and others. In macroscopy, we can have an infiltrative nodule, or in most cases, we may have a single nodule very much like a follicular adenoma. And cells are normal thyrocytes, and we have to look for the invasion, either capsular invasion, that is cells invading all the way through the capsule like here, or vascular invasion, or both. Vascular invasion is the invasion of blood vessels located on or beyond the tumor capsule, and the extent of vascular invasion is important in determining the prognosis of follicular carcinoma. In the latest edition of the WHO classification, if we have capsular invasion only, then we have a minimally invasive follicular carcinoma. We may have encapsulated angioinvasive carcinoma, which is we must have vascular invasion, but we may have or may not have capsular invasion. But in most cases, I can say that when I see vascular invasion, there is usually capsular invasion too.
And there is another type, which is the widely invasive follicular carcinoma. We usually have prominent vascular invasion and intrathyroidal invasion, and we can see it very easily. And in some cases, we may have extrathyroidal invasion. And another entity is hyalinizing trabecular tumor. A hyalinizing trabecular tumor is a tumor of follicular cells, and almost all cases has a benign clinical course. It's a well-demarcated, encapsulated nodule of follicular cells, and intratrabecular and intertrabecular hyalinization and calcification like here is prominent. It's composed of elongated or polygonal cells forming trabeculae, and the tumor cells aligning perpendicular to the long axis of the trabeculae. The cells are those of like papillary thyroid carcinoma, very much like so, maybe even more so than papillary thyroid carcinoma itself, like here. And we have yellow bodies here, which are very prominent in hyalinizing trabecular tumors. Now let's go to papillary thyroid carcinoma. Papillary thyroid carcinoma is a cancer derived from follicular cells, and its main characteristic is its nuclear features. And they're generally invasive, but not all of them. This is the most common type of thyroid carcinoma. Most of our patients are female. But the molecular characteristics are quite different from follicular tumors. That is, we see red PTC gene rearrangements, BRAF point mutations, and in a follicular variant, especially RAS mutations in this tumor. Ionizing radiation is an important reason to have papillary thyroid carcinoma, and especially in exposure in childhood. It's usually an asymptomatic nodule. Sometimes it presents with cervical lymph node metastasis, but this metastasis to the neck, it does not affect prognosis significantly. It's fatal only in a small proportion of the cases. It may present as a single focus, like in here, but it has multiple foci, and this is not rare. In a lot of cases, we have multiple foci of papillary thyroid carcinoma. It may be solid, or it may be cystic in some cases. It may have infiltrative borders, or it may be a well-demarcated, encapsulated nodule, like a follicular adenoma. In some cases, it has widely invasive borders, and it's very easy to say that it's a malignant tumor on cut section. PTC nuclear features are very characteristic, and they are large and oval when compared to normal thyrocytes, and they are described as optically clear or vesicular or often any like nuclei. Like here, the eye of the characters of this cartoon. Here are the characteristic vesicular cells, vesicular nuclei of papillary thyroid carcinoma, and overlapping, like this X in a basket, is very typical for PTC, like here. And the nuclear features has grooves like a coffee bean. These are indentations of the nuclear membrane, and like here in these cells that I show you. And there are nuclear pseudo-inclusions. Nuclear pseudo-inclusion is cytoplasm originating into the nuclei, forming inclusions in the same color as of the cytoplasm, like here or here. And there are other microscopic features. The papillae, which gives the name to the tumor, is the most prominent and the first described organization pattern of PTC. We can see papillae with fibrovascular cores, but seeing papillae is not necessary, because we can see follicles or we can see solid trabecular insular organization. The other typical feature is Samoma body. Samoma body is a concentric lamellar calcification, and it presents itself in the core of the papillae, and we see it in papillary thyroid carcinoma with papillary organization, like here, and groups of Samoma bodies here. We have some types of papillary carcinoma. One, and the most classical one, is the classical type. And that means that we are going to have papillae with fibrovascular cores, like in this example. But in papillary thyroid carcinoma, the classical type, there is almost always some follicular organization. So follicular organization does not rule out a papillary carcinoma. In some cases of classical papillary carcinoma, papillary organization is very limited. And this is the follicular variant of papillary thyroid carcinoma. It's the most common variant of papillary thyroid carcinoma. It makes follicles. And does the follicular variant of papillary thyroid carcinoma make papillae? According to some authors, true papillae is acceptable, being under 1%. But according to other authors, papillae, even a single papillae, but a true papillae with the fibrovascular core is not acceptable in follicular variant. And if you see it, you must decide that this is the classical type with follicular predominant organization, but not the follicular variant. So follicular variant, like so, has RAS mutations, the mutations that we see in follicular tumors, follicular adenoma and follicular carcinoma. It has similar mutations to that. And we divide follicular variant into 3 types. One is the infiltrative follicular variant of PTC, which is an infiltrative tumor without a capsule, but having typical PTC nuclei. And we have encapsulated follicular variant. The encapsulated follicular variant is a well-circumscribed or encapsulated tumor. It has PTC nuclear features, but these features are not very prominent. The prognosis is usually very good. And according to vascular invasion, we divide this variant to 2 types. If we have vascular and capsular invasion, then it's invasive encapsulated follicular variant PTC. If we do not have vascular or capsular invasion, then it's non-invasive encapsulated follicular variant PTC. This brings us to another entity. Like here, we have a tumor, a very circumscribed tumor, not very much encapsulated, but circumscribed, definitely, follicular architecture. And in all areas, it's divided from the outside by a very circumscribed architecture. So here, like here, and the cells are those of, or very similar to papillary thyroid carcinoma. This brings us to NIFT-P. NIFT-P is an encapsulated or well-circumscribed follicular tumor. It has PTC nuclear features and no vascular or capsular invasion. These types of tumors can be called, of course, or was called previously, papillary thyroid carcinoma, follicular variant, encapsulated and non-invasive. But now we have a subset of these tumors that we have some criteria to call for them as NIFT-P. And by this criteria, if those are met, then we're going to call them NIFT-P. It isn't a totally benign tumor, but we do not call it carcinoma because it has very low potential for malignant behavior. There are criteria in the WHO book, but the criteria
are revised by the authors that originally proposed those criteria. So I'm going to talk on revised criteria for NIFT-B. These are encapsulation and clear demarcation, and follicular growth pattern. And if there is a solid trabecular insular growth pattern, this should be less than 30%. No psammoma bodies, you cannot see any psammoma bodies because psammoma bodies are told to be the tombstones of the papillae. So if you're seeing it, you're going to see a papillae somewhere. You cannot see any well-formed papillae in these tumors. And you're going to see a nuclear score, I'm going to come to that, of 2 or 3 to call it as NIFT-B. There is no capsular or vascular invasion. There is no necrosis or high mitotic activity. This is the visual aid that accompanied the first description of NIFT-B. You are going to evaluate the nuclei of the cells by 2 areas, size and shape, and membrane characteristics and chromatin. If you're going to say 0, not enough, or present, 1. And you're going to add your score if you have let me say, sorry, what did I do? If you have a score 3 to 2, then it's going to be NIFT-B. It can be NIFT-B. If your score is 0 or 1, then you say that you're going to have a benign nodule. So I'm going to give an algorithm to you. If you have an encapsulated circumscribed tumor, which the capsule is totally sampled, and you have follicular organization without any papillae or mitosis, high mitosis or necrosis, you are going to look for the invasion first, the capsule. If you have any invasion, then it's carcinoma. If your invasion is equivocal, then you can stay in uncertain malignant potential category. But if it's not invasive, and it has PTC nuclei, or you think them of, are these nuclei are PTC, then you are going to evaluate the nuclei very, very, very carefully. And if the nuclei are not PTC, then you are going to tell that this is an adenoma. If the nuclei are suspicious for PTC or they are absolutely PTC, then you have 3 different options. You are going to score it. If the score is 0 or 1, then it's an adenoma. If the score is 2, then it's a NIFT-B. But if the score is 3, then you have to look at your tumor more closely. You have to take it in total. You're going to look for papillae, and very, very diligently, you're going to look at the papillae. In the total examination, if you do not have any papillae, and it's advisable to do BRAF immunohistochemistry at least for this mutation, and if there is no mutation, then it can be called NIFT-B. But if you have papillae, even a single formed papilla, or you have BRAF mutation, then you're going to return to carcinoma category. But this time, this will be a classical PTC with a predominant follicular organization, okay? We have a lot of variants, but some variants are more important than the rest. One is the tall cell variant. Tall cell variant usually presents on higher stages in older patients, and it has aggressive behavior. Its organization is predominantly papillary, but the cells are tall, and these tall cells have to be at least 30% of your tumor, like so. You're seeing the cells, and you're seeing the height and width, and they are really, really high cells. So I suggest in all the tumors that you begin with the classical type in your head. Look closely at the cells if they are tall or not. This tumor is in most cases, is a BRAF mutant tumor, like in this immunohistochemical examination. Another variant that I'm going to talk about is cribriform modular variant. This variant can happen in the context of familial adenomatous polyposis, but it can also be sporadic. The most prominent feature of this tumor is nuclear beta-catenin positivity. Another variant is diffuse sclerosing variant, which happens in young patients, and fibrosis and sclerosis is very prominent, and metastasis to cervical lymph nodes. It has many psammoma bodies, usually, and it's usually on the background of a prominent lymphocytic thyroiditis. Another important variant is the hobnail variant. It makes papillary and micropapillary organization, and the cells have hobnail features. Its prominent thing is that it has a poor prognosis, and it can have p53 mutations, which is not a thing that you usually see in a well-differentiated thyroid tumor. There are other variants that I'm not going to talk about because of time limitations. But there is also papillary microcarcinoma, which can be any variant that you know, but the size is less than 1 centimeter or equal to 1 centimeter. Now, we did this part. Now we are going to that part, anaplastic thyroid carcinoma. Luckily, we do not have much of that. They are undifferentiated tumors. Some develop on well-differentiated tumors, and the mortality is very high. In anaplastic thyroid carcinomas, we can see all the mutations, not all, but most of the mutations that we see in well-differentiated thyroid tumors, but we have some additional mutations we are going to talk about in a minute. They can be sarcomatoid. That means they are composed of spindle cells, reminiscent of high-grade spindle cell sarcoma. They can have giant cells, atypical giant cells, some showing multinucleation. Or in some cases, they may have some epithelial squamoid or even squamous islands. But they have in common necrosis, a very high mitotic activity, invasive growth, and vascular invasion. Large areas of necrosis, as you see in this slide, many mitosis. It's very easy to see mitosis in anaplastic carcinoma. It can have well-differentiated or poorly differentiated carcinoma components in it, like so. What about the markers of thyroid origin? They are TTF1 and thyroglobulin negative in almost all areas, in almost all of the cases. But PAX8 can be positive in about half of the cases. Cytokeratin is usually positive, but it can be focal or totally negative. And to say that it's an anaplastic thyroid carcinoma, we must use immunohistochemistry and clinical findings to rule out other tumors. For example, in this tumor, we have an anaplastic thyroid carcinoma. Cytokeratin is definitely positive here, but in here, cytokeratin is negative. That makes it difficult in some cases to diagnose it as a thyroid tumor. What about poorly differentiated thyroid carcinoma? Poorly differentiated thyroid carcinoma is a tumor of follicular cells, but the follicular differentiation is limited. Morphologically and biologically, it's a tumor between differentiated thyroid carcinomas and anaplastic thyroid carcinoma, and the molecular profile is very similar to anaplastic thyroid carcinoma. It's a rare tumor, and its definition was variable in older literature. But after the Turing criteria are induced, there are about 2% in the United States, but it's very common in other, it's much more common, not very common, but much more common in other parts of the world. It's a tumor of older individuals. it's very related to iodine deficiency, and it has benign thyroid lesions in the background, like nodular follicular disease or well-differentiated carcinoma in some cases, papillary or follicular. It's usually a large tumor. It may show necrosis. Partially encapsulation can be seen, and extrathyroidal invasion is not rare. The solid trabecular insular organization pattern is the hallmark. The main difference from well-differentiated thyroid carcinoma are the prominent mitosis and or necrosis, and how we can differentiate it from anaplastic carcinoma. In this tumor, ATP and pleomorphism is not prominent. And morphologically and immunohistochemistry, you can recognize it as a thyroid originated tumor. Here are the Turin criteria. The predominant pattern should be solid, insular, or trabecular, or a mixture of these three patterns. The absence of nuclear features characteristics of PTC, but you may have a PTC in some area of this tumor as the originating tumor. And you're going to have at least one of the below criteria, which are tumor necrosis, 3 or more mitosis in the 10 high power field, or convoluted nuclei. Let's look at that. Solid, trabecular, insular or solid trabecular pattern or a mixture. You can have follicles, but they are not prominent. Nucleus is not papillary. You can either see mitosis and or necrosis and or convoluted nuclei that are described as a resinoid, a hyperchromatic, not round nuclei. The definition of convoluted nuclei is not very clear to me, and I don't think that it's very clear to the original describers of this entity. Hurtle cell tumors, we are coming to Hurtle cell tumors. Hurtle cells are oncocytes or oxyphilic cells. We call them by these names also. This is a cell with a large granular eosinophilic cytoplasm and a large nucleus and a prominent nucleoli like here. What gives us the Hurtle cell morphology? It's the proliferation of abnormal mitochondria in the cytoplasm, and these abnormal mitochondria are in the cells because these cells have mitochondrial DNA mutations or mutations of the nuclear genes that are related with mitochondrial functions. Hurtle cell tumors can be seen in Hurtle cell adenomas and Hurtle cell carcinomas, which are practically follicular adenomas composed of Hurtle cells and follicular carcinomas composed of Hurtle cells. But other tumors can also show Hurtle cells, and non-tumoral lesions can have lots of Hurtle cells. Hurtle cell nodules in lymphocytic thyroiditis, benign Hurtle cell nodules in nodular follicular disease. It may be a non-tumor composed of Hurtle cells. So Hurtle cell morphology is for me like a red dress, and the biology and the behavior of the cell depends on the wearer, not the dress. Hurtle cell tumors, if they have no capsular vascular invasion, they are adenomas. With capsular vascular invasion, we are going to call them Hurtle cell carcinomas. Males are more prominent in Hurtle cell type tumors. They are usually seen in older patients. They are usually larger tumors, and the survival is poorer when compared to non-Hurtle cell tumors because of the radioactive iodine resistance of this type of tumors. To call a tumor Hurtle cell, then 75% of the nodule should be composed of Hurtle cells. They are encapsulated, yellow, reddish-brown nodules, total necrosis with a minor trauma is common. So sometimes we see tumors totally gone to necrosis after fine needle aspiration biopsy. They are usually Hürthle cell tumors. Encapsulated Hürthle cell tumor. An organization can be follicular. Follicular organization is more common in benign tumors, and solid trabecular organization is more common in carcinomas. And we are examining the capsule to decide which is which. So I'm going to make a short summary of molecular findings in follicular tumors. In different follicular tumors, we have different characteristic molecular changes. In PTC, it may either happen from the red PTC rearrangement way or from BRAF, or the follicular variant can derive from RAS mutations. The follicular tumors, on the other hand, in addition to RAS mutations, have different mutations like PAX8, PPAR gamma. And we have the other set of tumors, which are the poorly differentiated carcinoma and anaplastic carcinoma, the wild type of thyroid tumors. They may have exactly the same mutations that the driver mutations that are seen in well-differentiated tumors. But some mutations don't go wild. Okay, you see there, here, they do not usually go to this stage. Then we have a second set of mutations that is P53 and third mutations, third promoter mutations. Then we can, if it's happening this way, then we can think that these are necessary in the initial tumorigenesis, but the second set is necessary for tumor progression. Okay, now the medullary thyroid carcinoma. Medullary thyroid carcinoma is a tumor of C cells, and it's about 5% of all thyroid carcinomas. It produces calcitonin, which we use in the diagnosis and follow-up of these patients. It can be sporadic, and it can present as a mass lesion or symptoms related to peptides from the tumor. In the familial setting, in addition to these mass effects, we may have some additional symptoms related to other organs that are also part of the syndrome, for example, adrenal or parathyroid. And we may have some medullary thyroid carcinomas that are screened family members of the index cases. In some cases, we have very early performed prophylactic thyroidectomies in familial cases. Sporadic cases are the majority, and they are in adults. But familial cases can be encountered in younger patients in first decade in some cases, and bilaterality and multicentricity is a known thing in MEAN-associated familial medullary thyroid carcinoma. These tumors are gone to this tumoral way by activating red point mutations. These mutations are totally different than the red PTK mutations in papillary thyroid carcinomas, and we may also have RAS mutations. The macroscopic features, sporadic cases are single tumors usually, but familial cases are usually multiple, and solid gray-white tumors, infiltrative nodules. There may be necrosis and hemorrhage in larger lesions. The microscopic features can be spindle, like here, or oval. They make nests and trabeculae, or polygonal, like in here. A stromal amyloid deposition is very common, and the source of the amyloid is calcitonin. There may be very different presentations, morphologic presentations of a medullary thyroid carcinoma, like here in this spindle cell variant or giant cell variant. In some cases, not much, but they can be totally encapsulated. And They can mimic thyroid follicles in some cases, but they are calcitonin positive, and they are also synaptophysin and chromogranin positive, but not the thyroglobulin. In immunohistochemistry, as I said, calcitonin may stain cytoplasm of the tumor cells and the stroma, and carcinoembryonic antigen is usually positive, and we have neuroendocrine marker positivity. We do not have thyroglobulin positivity in medullary thyroid carcinoma, and we have TTF1 positivity. In multiple endocrine neoplasia patients, we can see multiple tumors, like here. This should be calcitonin, I guess. I didn't write it and I forgot it. And also in familial cases, we are going to see C-cell hyperplasia in most of the cases, in addition to multiple tumors. So I hope that we covered the whole spectrum of thyroid tumors in such a short time, and I hope I could tell you what I meant to tell, and this is the end of my presentation. And thank you very much, and hope to see you somewhere in Turkey or in Bosnia, but I would prefer Bosnia. See you.
Yes, this was the end of my presentation, and I'm looking for the messages now. Could I use P53 immunohistochemistry in hobnail thyroid carcinoma? Yes, you could use, and probably you will find it positive. You wouldn't find it positive in well-differentiated thyroid carcinomas, but this one is an exception. So you can use it, and you can use it to say that this is an hobnail variant. Yes. And do I see any other question here? No, I don't. Okay. Then now it's the time for the second talk. Now we are going to talk on the cytology of thyroid tumors, and Dr. Çisel Aydın will talk on that. Now we are listening to you, Çisel.
Good afternoon, everyone. In this part of the course, I want to talk about thyroid cytology and the latest Bethesda system. Fine needle aspiration has an essential role for the evolution of a thyroid nodule. For this inception, the Bethesda established a uniform tiered reporting system for thyroid FNA specimens. With using the Bethesda, cytopathologist and the physician understand each other in a uniform and a universal way. There are not many big changes in the second edition. There are only changes in the recommendation and expected malignancy rates. In the second edition, patient demographics, nodule selection criteria, cytopathologist experience, and the application of cytomorphologic diagnostic criteria were taken into consideration and changed the management. And a newly described entity of NIRT-P overestimate risk of malignancies, and some of the criteria's risk of malignancy rates are decreased. So how to report? There are 6 diagnostic categories in the Bethesda system. For 3 of the 6 categories, Bethesda offers a choice of 2 different names: eosphulous or follicular neoplasia, or suspicious for follicular neoplasia. A laboratory should choose the one of its prefers, and synonymous terms should not be used to denote 2 distinct interpretations. Each category has an implied risk, which ranges from 0 to 3 for the benign category to 100% for the malignant category. As a function of these risk associations, each category is linked to evidence-based clinical management. But after NIRT-P terminology, risk of malignancies are changed, especially follicular neoplasia and suspicious for malignancy. Risk of malignancy is decreased. In the Bethesda system,
there are 6 main categories, but 3 of them, benign follicular neoplasia or suspicious follicular neoplasia, and malignant category are morphological categories. The other categories, AUS and suspicious for malignancy, those are intermediate categories. We use them when we cannot fit into any of these categories. And most of these cases falling into indeterminate group were follicular variant papillary carcinoma and specimens with technically of low quality efficiency. First category, non-diagnostic category. For useful diagnostic informations for clinical management, a fine needle aspiration should be representative of the underlying lesion. Cellularity or adequacy is not only dependent on the technique, but also on the nature of the lesions, such as cystic nodules. Fine needle aspiration is defined both the quantity and the quality of the cellular and colloid components. Fine needle aspiration considered adequate if it contains minimum of 6 groups of well-visualized follicular cells with at least 10 cells per group, preferably on a single slide. And second scenario, colloid nodules. Specimens that consist of abundant colloid are considered benign and satisfactory for evolutions. A minimum number of follicular cells is not required. And one another scenario is inflammations. Nodules in the patients with lymphocytic thyroiditis or thyroid abscess or granulomatous thyroiditis may contain only numerous inflammatory cells. Such cases are interpreted as benign. And of course, cytologic atypia, if a sample that contains significant cytologic atypia is never considered non-diagnostic, and it is mandatory to report any significant atypia. Of course, quality is important too. Fixation defects, tick drops, being covered with blood may cause the non-diagnostic. Nodules that do not meet the qualification criteria should not be diagnosed. If we try to diagnose nodules that do not meet this criteria, our false negativity rate increases. Therefore, samples with poor preparations containing less than 6 cells should be considered insufficient. But a cyst fluid may yield only macrophages, but the risk of malignancy is low for these lesions if they are simple and under 3 centimeters. But of course, we cannot exclude the possibility of a cystic papillary carcinoma. These specimens may be considered clinically adequate, even though they are reported as non-diagnostic. How to manage them? Nodules with an initial non-diagnostic result should be reaspirated unless the nodule is purely cystic, because overall risk of malignancy for these lesions are low. It was expected at least 3 months before taking a repeat biopsy, because it was believed that frequent aspiration would increase the rate of atypia due to inflammation. However, there is not enough evidence that aspiration performed for more than 3 months ago increased the rate of atypia. And for this category, reaspiration can be done with on-site evolution. And in the absence of the on-site evolution, taking at least 3 separate samples will reduce the insufficiency rates. For example, in this slide, this is very hypocellular slides which contain a few inflammatory cells. This is a histiocytes and the polymorph nuclei. We report this as non-diagnostics, and it's non-diagnostics due to an insufficient cellularity. How about these slides? These slides contain numerous histiocytes. They have vacuolous cytoplasm. Some of them contains hemosiderin pigments. And there isn't enough follicular cells in here. And we report this as cyst fluid only. Slides consist almost exclusively of histiocytes interpretation is limited by insufficient follicular cells, and put a note that recommend correlation with T size and complexity on the ultrasounds to assist with further management of the lesions. And in another scenario, you can see there are follicle cells, but they are obscured by the blood, and we are not read them, and we report this as unsatisfactory because obscuring blood hinders the evolutions of the follicular cells. And put a note that reaspiration should be considered if clinically indicated. Second category, benign. Because of the most of the thyroid nodules are benign, benign result is the most common FNA interpretations. Almost 60% of the all cases are benign. In the Bethesda system, benign term choose instead of negative for malignancy and non-neoplastic. Benign cytopathology is associated with a very low risk of malignancy, and patients are usually followed conservatively with periodic clinical and radiologic examinations. And benign results are further subclassified as benign follicular nodule, thyroiditis, or other less common entities. In the benign follicular nodule, similar cytological features that are classified histologically as nodular hyperplasia in a nodular gutter, hyperplastic nodules, colloid nodules, they all have the same cytological features. In the cytologically, benign follicular nodules are characterized by variable amounts of colloids, benign appearing follicular cells, oncocytic cells, and macrophages. In here, you can see the thick colloids, and you can see a stained glass cracking appearance. And in here, this is a watery colloid. This is light green or pinkish in alcohol-fixed pop stained preparations. If you just see this colloid and no follicular cells, even we report this as benign and consistent with colloid nodules. In these slides, you can see monolayered sheets of follicular cells. They are arranged in honeycomb, and there is a watery colloid in the background. And we report this as benign follicular nodule consistent with nodular gutter. And in here, three-dimensionally variably sized balls and spheres. Within the spheres, there is maintenance of polarity, including relatively evenly spaced nuclear arrangements. And we report this as benign too. Benign follicular cells have round to oval monomorphic nuclei with granular chromatin and inconspicuous or absent nucleoli. You can see watery colloid present in the background and report this as benign. And also you can see macrophages or with enlarged nuclei, granular cytoplasms with Hürtel cells admixed with the follicular cells. We report this as benign too. Graves hyperreactive nodules are benign entities. This is an autoimmune diffuse hyperplastic thyroid disorder commonly seen in middle-aged women, and most patients have diffuse nodular enlargement of the thyroid gland and do not require FNA for diagnosis. But if they perform FNA, we will see follicular cells are arranged in flat sheets or loosely cohesive groups with abundant delicate foamy cytoplasms. Nuclei are often enlarged and maybe show prominent nucleoli. A few microfollicules may be observed, and the distinctive flame cells may be prominent and are represented by marginal cytoplasmic vacuoles with red to pink frayed edges. But do not forget that flame cells are not specific for Graves' disease and may be seen in other non-neoplastic thyroid conditions. In here, you can see the flame cells. They have marginal cytoplasmic vacuoles with red to pink frayed edges. And the thyroiditis, lymphocytic thyroiditis applies to a cytologic sample composed of many polymorphic lymphoid cells associated with benign thyroid follicular cells and or Hertel cells. And the chronic lymphocytic thyroiditis or Hashimoto thyroiditis is the most common of these conditions and typically affects the middle-aged woman. And in the granulomatous thyroiditis, asperities, hypocellular, and you can see epithelioid histiocyte aggregates, multinuclear giant cells mixed with inflammations. A few follicular cells may be seen. In here, you can see numerous lymphoid cells and scattered Hertel cells. And when we see Hertel cells, they can be arranged in flat sheets or isolated cells. They have abundant granular cytoplasms, large nuclei, and prominent nucleoli. We report this as benign and put a note that these findings are suggestive of chronic lymphocytic thyroiditis in the proper clinical setting. And granulomatous decurrent thyroiditis is a self-limited inflammatory condition. FNA is generally performed only if there is a nodularity that raises the possibility of a coexisting malignancy. And you can see in here epithelioid histiocytes mixed with inflammatory cells and maybe associated benign thyroid follicular cells. And of course, multinuclear giant cells. We report this as benign and put a note that these findings are suggestive of granulomatous thyroiditis in the proper clinical setting. Our third category, a TP of undetermined significance. We choose this term in our laboratory. Again, please choose one of the terminology, a TP of undetermined significance or follicular lesions undetermined significance. And we use these terms for specimens that contain cells, follicular, lymphoid, or other, with architectural and or nuclear atypia that is not sufficient to be classified as suspicious for follicular neoplasms or suspicious for malignancy or malignant. On the other hand, the atypia is more marked that can be described as benign changes. This is a heterogeneous category and characterized by cellular or structure atypia. Okay. Since this is not a diagnostic category, we can consider many scenarios. Let's look at them, some of them now. For cytologic atypia, it can be focal cellular atypia, common but mild cellular atypia, atypia in cells similar to cyst epithelium and histiocytoid cells. Let's look at the slides. In these slides, the rare cases have nuclear enlargements, pale chromatin, and irregular nuclei contours. There isn't any nuclear episode inclusion or plasmoma. We report this as AUS, follicular cells predominantly benign apparent with focal cytologic atypia, and put a note that repeat aspirates or molecular tests may be helpful. What about in these slides? Most of the cells have mildly enlarged nuclei with slightly pale chromatin, and there are limited nuclear contour irregularity. There isn't any nuclear pseudo inclusion or psammoma. And report this as follicular cells with mild cytologic atypia. What about in here? Actually, in the cis lining cells, they easily recognize as benign. But in rare cases, like in these slides, atypia is more than usual in here. There are grooves, nuclear grooves, prominent nucleoli, and elongated nuclei and cytoplasms. And it is appropriate to diagnose this as AUS. What about architectural atypia? Hypocellular smears containing microfollicles, or cellular smears with abundant but do not dominant microfollicles, or papilla-like structures, papillary patterns. For example, in this slide, this is a hypocellular slides, and we can see rare microfollicule clusters. And we report this as AUS. This is sparsely cellular aspirate comprised of follicular cells with architectural atypia. Collate is absent. What about those slides? Those are very cellular slides with papillary-like structure, but there isn't any nuclear atypia, because if you have nuclear atypia, it can at least suspicious for malignancy, and it's in predominantly macrofollicules in here, and we report this as AUS, but it can be a papillary hyperplasia. And cytological and architectural atypia can be seen together, and the presence of both mild cytologic in here, like the enlargement of the nuclei, pale nuclei, and the microfollicles. Both of them generally may be more common with NIFT-P, but this has not been firmly established. What about the Hertel cells aspirates? Hypocellular smears with almost entirely Hertel cells. It can be, the sampling may be inadequate, and repeat aspiration is helpful because it may be a Hertel cell neoplasia. But cellular smears, like Hashimoto thyroiditis, in the thyroiditis, cellular smears consistent almost entirely of Hertel cells, the benefit of reaspiration is limited. For example, in here, Hertel cells are all in cohesive flat sheets without nuclear atypia. And if there is a colloid, a benign diagnosis is right category in the absence of high-risk clinical or radiological findings. There may be a clinical evidence of lymphocytic thyroiditis, but lymphocytes are absent. Alternatively, a clinical diagnosis of Hashimoto thyroiditis has not been established, yet the presence of some lymphocytes raises the concern for Hashimoto thyroiditis. A repeat aspirate or additional clinical evolutions may resolve the diagnostic uncertainty. But when multiple nodules in the same patients show features of eosphilus, may be preferred on the presumption of multinodular goiter with multiple hyperplastic Hertel cells nodules is more probable than concurrent Hertel cell neoplasms. And we report this as AUS, and the specimen is moderately cellular and consists almost exclusively of Hertel cells. And put a note that in a patient with multiple Hertel cells nodules, these findings likely present Hertel cell hyperplasia in the settings of multinodular goiter. And atypia not otherwise specified, we can see distinct nuclear atypia like large nuclei, but incompatible with papillary carcinoma or pseudomatous bodies. We use AUS and report this as AUS marked cytological atypia. And if the patient is treated with radioiodine, these findings likely represents reactive or atypia pseudomonas calcifications are present, and put a note that pseudomonas calcifications are associated with both benign and malignant conditions. Okay, so when we are using EUS, it's important to find the EUS rationale. EUS papillary carcinoma could not be completely ruled out, or EUS follicular neoplasia completely ruled out, or EUS fertile cell neoplasia could not be completely ruled out. Because it can give an idea what to do next, and the malignancy risks are different. In our department, when we use EUS, it's mostly because of the cytological atypia. So how to manage them? Reaspiration is a standard and widely accepted practice, but molecular tests have become another method used in the approach in these cases. And in order not to use the EUS category as a garbage category, EUS interpretation should be approximately 70% of all thyroid FNA in your lab. Or you can use EUS malignant ratio at 3. But in practice, it's struggle to achieve this figure. You can use at least 10 for your laboratory. Our fourth category, follicular neoplasm or suspicious follicular neoplasm. In our lab, we are using suspicious for a follicular neoplasm. Again, please choose the one of the term. This category identify all potential follicular carcinoma and refer them for appropriate follow-up. In this category, cytological preparations are moderately or markedly cellular, and there is a significant alteration in follicular cells architecture characterized by cell crowding, macrofollicles, and dispersed isolated cells. Follicular cells are normal sized or enlarged and relatively uniform with slight or moderate amounts of cytoplasms. Nuclei are usually round and slightly hyperchromatic with inconspicuous nuclei. Some nuclear atypia may be seen, colloidescent or absent. So what is microfollicles? Microfollicles is crowded, overlapping flat groups of less than 15 follicular cells arranged in a circle that is at least 2/3 complete. And it is noteworthy to remember that cellularity by itself is not sufficient to merit these designations. So this is the cellularity we are talking about. High cellular aspirates composed of uniform follicular cells arranged in crowded clusters and microfollicles. And we report this as suspicious for follicular neoplasms, cellular aspirates composed of predominantly crowded uniform cells without colloids. The features suggest the follicular neoplasm. But do not forget that microfollicles can be seen in other conditions, such as this is the hyperplastic nodules, this is the follicular adenoma, or you can see in follicular carcinoma, NIFTS-P, follicular variant papillary carcinoma, or poorly differentiated carcinoma. And of course, pyrothyroid can be seen in microfollicles. And these slides belong to one of the latest papers that compare cytology and histology of the tumors diagnosed as NIFT-P. In cytology, overlapping nuclear atypia and microfollicles were identified. And report this as suspicious for follicular neoplasms, and it can be a NIFT-P or invasive follicular variant of papillary carcinoma, but it is not possible on cytologic material. And this is a really good paper
that summarize the architectural features and nuclear atypia. If you have a slide with microfollicular architecture and the nuclear atypia is prominent, it can be infiltrative follicular Y and papillary thyroid carcinoma. But if the nuclear atypia is moderate, it can be a NITSP or invasive encapsulated follicular Y and papillary thyroid carcinoma. But if the nuclear atypia is low, it can be a follicular adenoma or follicular carcinoma. And Bethesda offer that you can put an optional note that it can be a NITSP. What about the Hertel cells? If your slides almost exclusively consist of Hertel cells, and you can recognize Hertel cells with abundant, finely granular cytoplasms and enlarged central or eccentrically located round nucleus with prominent nucleoli is Hertel cells. And if you are almost entirely with Hertel cells, you can report this as follicular neoplasms, Hertel cell type. But if you have features of papillary architecture or nuclear grooves, yeah, it can be a oncocytic neoplasm with papillary features. It can be a papillary thyroid carcinoma. Of course, you can put this slice to a suspicious for malignancy category 2. Okay, in the follicular neoplasia Hertel cell type or suspicious for follicular neoplasia Hertel cell type, Hertel cells predominantly as isolated cells. Binucleation is fairly common, no collate, no lymphocytes, because if you can see lymphocytes, it can be a Hashimoto thyroiditis. And some cases may have intracytoplasmic colloid inclusions. What about the management of the follicular neoplasia? Actually, the standard approach is still lobectomy, but if the lesion is low risk, then patients may remain under follow-up. And of course, risk of malignancy rate decreased after NIFT-P terminology, and you can always consider that it can be a NIFT-P which cannot fully carry the classic papillary carcinoma features. And you can also use the molecular tests. With the molecular test, you place nodules in risk groups, and the main goal is to select patients who will be followed up with a test with a high negative to predictive value. And the molecular test using different combinations to detect point mutations, insertion, deletion, gene fusions, gene expression changes, and or copy number changes. I want to shortly summarize you the molecular tests. This flowchart illustrates the cytologic and molecular testings results. Okay, when we have an indeterminate cytology, we can use molecular tests. And if the molecular test put us in a high-risk group, total thyroidectomy can perform. But if the molecular test put us in a mid-risk group, then lobectomy can be performed. But the molecular test put us in a low-risk group, then the clinical follow-up, you can follow up your patients. And it is noteworthy to remember that tumor genotype is associated with phenotype. For example, in classic papillary thyroid carcinoma, we commonly see BRAF mutation or RET fusions. But in the follicular adenoma or follicular thyroid carcinoma, RAS mutations are more common. And the 30 mutations or TP53 mutations common together with in the fully differentiated thyroid carcinoma or anaplastic thyroid carcinoma. We have different commercial tests for using in the thyroid cytology, each of them using different analytes. For example, Tygenix using DNA, but Tyramir and Rosetta GX using microRNA, and the Afirma using mRNA, or you can use BRAF via immunohistochemistry for protein expressions.
And there is no evidence to date that one of the commercially available tests is superior to any other. And the ideal test should have a high accuracy rate in distinguishing between benign and malignant, high sensitivity and high specificity. But as a general rule, as one increases, the other decreases. Tests with high sensitivity and high negative predictive value are good for excluding the presence of the disease. Tests with high specificity and the positive predictive value for saying the diseases really exist. And another category, suspicious for malignancy. We use this category when some cytomorphological features raise a strong suspicions of malignancy, but the findings are not sufficient for a conclusive diagnosis. The risk of malignancy rates are like 50% to 60% when NITPs are not counted as malignant. And there are many scenarios, of course. For example, the sample can be hyalocellular. We can see nuclear atypia, maybe inclusions. What we are not seeing, psammoma or papillary architecture. Or we can see it's again in a cellular slide, but mild nuclear atypia, no inclusion, no molding, no psammoma. Or we can see sparsely cellular, but the papillary nuclear features. Or it can be a cystic changes, nuclear atypia, but there isn't any inclusion, molding, psammoma, or papillary architecture. For example, in the loose sheet of follicular cells with enlarged nuclei, powdery chromatin, nucleoli, and nuclear grooves. There's changes were patchy. However, the follicular cells can look like entirely benign. And we report this as suspicious for malignancy, suspicious for thyroid carcinoma. Again, these slides belong to the latest paper. You can see that the nuclear features suggestive of papillary carcinoma, but some of them, they have microfollicular architecture. And the histological correlations are NIFT-B of these cytological specimens. And what about management for suspicious for malignancy? They still suggest lobectomy. And the latest guideline says that not reflexively or routinely recommend that molecular test for suspicious or molecular cytological category, but may be requested if clinically indicated. And also you can use on-site evolutions for ancillary techniques such as calcitonin for medullary carcinoma or flow cytometry for suspicious for lymphoma. And our finally category, malignant category, I'm just talking papillary thyroid carcinoma. Papillary thyroid carcinoma is the most common malignant lesion of the thyroid. In conventional papillary thyroid carcinoma, this malignant epithelial tumor derived from the thyroid follicular epithelium and display a papillary architecture and the characteristic nuclear alterations. Generally, aspirates are cellular and cells arranged in papilla and or monolayers, cellular swirls, like onion skin pattern, enlarged and crowded nuclei, often molded they can be, oval or irregularly shaped nuclei, longitudinal nuclear grooves, intranuclear cytoplasmic pseudo-inclusions, and pale chromatin, thick nuclear membranes, marginally placed micronuclei, some bodies, multinuclear giant cells can be seen, and variable amount of colloid can be seen, but the colloid is like ropey or bubble gum-like. And oncocytic metaplasia and squamoid metaplasia, you can see them too. What about liquid-based preparations? Some of the features are more frequent, some of the features are less frequent. For example, convoluted nuclei, perinuclear halo, naked capillaries are more common in liquid-based preparation, but papillary pattern and tissue fragments are less frequent in the liquid-based preparations. In these slides, you can see that monolayer sheets with a functional appearance. This is characteristic of papillary thyroid carcinoma, and this flat sheet resemble benign follicular nodules. Please attention to the nuclear features because it's essential for the distinction between the benign and the papillary carcinoma. And in here you can see there are true papillary tissue fragments comprised of fibrovascular cores and lined by neoplastic cells. And we report this as malignant papillary thyroid carcinoma. And the cellular swirls are highly characteristic of the conventional classic papillary thyroid carcinoma. There are concentric aggregates of the tumor cells. Many of the peripheral cells are ovoid rather than round, nuclear, and oriented perpendicular to the radius of the swirl. And giant cells often accompanies to the papillary carcinoma. You can see giant cells and some bodies which are concentric rings, and in here lined by atypical cells with oval pale nuclei. Of course, intranuclear cytoplasmic pseudo-inclusions, you can see them too, but don't forget that pseudo-inclusions are not specific to the papillary carcinoma. You can see other neoplastic conditions too, such as medullary carcinoma. What about the variants? Follicular variant and NIFSP. Follicular variant, papillary thyroid carcinoma with an infiltrative growth pattern is more likely papillary thyroid carcinoma. They have more nuclear ATP and they generally associated with BRAF mutations. But encapsulated follicular variant papillary thyroid carcinoma and NIFSP, they don't have papilla, they don't have some bodies, and they generally associated with the RAS mutations. And the final aspirations from the follicular variant papillary thyroid carcinoma, you can see PTC nuclear features, and but also you can see mild nuclear atypia. And we have other variants such as macrofollicular cystic variant, oncocystic variant, Wharton-like variant, and tall cell variant or columnar cell variant. It's important to know that variants because most of them because of them, they can be, you have to distinguish them from the benign mimickers. For example, this is the macrofollicular variant. You can see there's abundant colloid. And if you not look close to these flat sheets, you can easily report this as benign. And this is the oncocystic variant. You can see that the HER2 cells have the papillary thyroid carcinoma nuclear features. And it's really important to recognize that columnar cell variants, it's resembling colonic adenoma or secretory type endometrium. And the cystic variants, it's important to know that these features, and you can report this as malignant papillary thyroid carcinoma favored columnar cell variant, but you do not have to favor a variant. But for example, if you favor a tall cell variant, maybe they add to surgery to lymph node dissections, but you don't have to. Finally, special thanks to Professor Dr. Pınar Fırat for sharing her beautiful pictures and slides with me. And thank you for your attention.
Okay, thank you everybody for your attention. I think we are a little tired now and probably hungry. So we'll have a half-hour break. But before that, I'm looking at the questions. But I think that Chisel already gave answers to all of them while she was speaking. So I I think there are no questions to be answered, and I think we can go to break, and we'll be back in half an hour. That will be about 2:40, I guess, Eastern European time, the Bosnia time, and it'll be 4:40 for the Turkish time, and it'll be just half an hour. So see you when we are back. Thank you for listening.
Thank you.
Yes. Good afternoon, everybody. I'm very happy to be with you, Bosnian colleagues again. I hope we can be together again face to face. And now we are coming to the end of this meeting. And we have three speakers in this session. First speaker is Dr. Haldun Umudum. You know him, we listen him in this morning again. And his lecture is Advanced Ancillary Techniques in Thyroid Cytopathology. Yes, Haldun, we are listening to you.
Yeah, okay, I'm sharing my screen. Thank you very much. And thank you everybody being so patient today, because this is a little bit tougher for you, I think. So, okay. So what I'm gonna talk about this afternoon. Okay, so, oops, excuse me. Okay, so it's me again. And for those who didn't join this morning, I'm Dr. Haldun Umudum from Ankara, Department of Pathology, Ufuk University Medical School. So I'm going to give you a brief perspective about the advanced ancillary diagnostic techniques in thyroid cytopathology. If we were in a meeting with the face-to-face or just any meeting, I would ask you this question. Just before the start, for your comments and for your opinions, I really appreciate if you can share with this hashtags, this one and this one, and this is the Twitter, so we can share our opinions. Okay, this is the website. Have you ever wondered, what is this cytology? I do, and I think it's the thyroid. And I look at these pictures many times, and I couldn't decide whether it's benign, malignant, or suspicious. Maybe after my speech, Dr. Semir or Faruk sent me a message and tell me what kind of cytology is it and what's their diagnosis. But today, I'm just looking at it. It might be an AUS, I think, right? So today we cannot do some molecular testing on the images yet, maybe in the future. Okay. So since we are a little bit tired, I took the liberty to show you some pictures. Thyroid diseases are so common, and any kind of art, I think, should have some traces. So I'm going to show you some examples of art that contained thyroid disease in the human history. So this is an Indian pipe figure in United States, dating back to 2000 years before Christ. As you see, it's probably a female figure with a huge goiter on her neck. Okay. This is another figure from 15th century that depicts the resurrection of the Jesus. And this is very well-known scene. As you see the soldiers here, and one soldier is either dead or sleeping. And this soldier, if you look at close, he has a interesting lesion on his neck. So it's probably not a goiter, but probably a thyroglossal cyst. Okay. Another picture, which is my favorite. Oops. Okay. There's something wrong with the slides. Okay. Anyway, this is another sculpture wood. This is sculpture, not a painting. It's a little bit crowded. That's the Jesus. Christ is flagellated by two men with goiter. You cannot see it, but if you look at close at this figure, which is here, and he has a huge goiter here. Okay. And this is my favorite one because this is the Judith and her maid servant Artemisia, painted by Artemisia Gentileschi in 17th century. It was in Italy, and the painter herself here depicts herself, and she has a huge, not a huge, but goiter, right? It's in, and look at her eyes, probably an exophthalmic. She has some issues, right? So this is the art. Okay, contents of this presentation. I'm gonna ask some questions and then I'm gonna try to answer them. So first is, why are the advanced ancillary techniques are needed? Are results given as positive, negative, or is interpretation needed? What is the endpoint of all this mess? What are the methods and what are we looking for? Limits and benefits and practice examples in different regions of the world. Okay, so first question is, I'm not sure, can you see my whole thing? Just a second, okay. And who needs this ancillary techniques? Why are we requiring this test? Because about the 30% of the thyroid FNA give indeterminate results. So that means one cannot say if it's clearly benign or malignant. And ancillary techniques may help to refine therapeutic approach in these categories. In AUS and the FLUS categories, molecular testings are advised in the United States in these categories. However, Korean, European, and Japanese friends have different algorithms in these cases. So we're gonna talk about it. And why do we need thyroid FNA? Because thyroid nodules are so common, present in 10% of all population, as you see in the pictures and sculptures. So you cannot do surgery in 10% of the whole population. So we need to choose which patient needs surgery, which patient does not need surgery. And in specific situations, we would like to know if it's a cancer or just a benign nodule. And based on this finding, patient will undergo surgery or not. And in 70% of the cases, thyroid FNA answered these questions. However, in 30% of the cases, we cannot be sure. And these cases termed as indeterminate categories in thyroid FNA. This term is interesting. We don't use in cytology, but in the world of molecular cytopathology, this is the correct term for categorization. Okay, is the Bethesda system only system in the thyroid FNA? No. There are Italian, British, Australian, and Japanese classification also exists. And what is the rule in and rule out terms? This is a new term because based on molecular testing, and the results can be as rule in or rule out. That means if you hear a rule in test, that means surgery is necessary. If you heard the term rule out, that means surgery may not be necessary now. Okay, so what are the indeterminate categories in the Bethesda? It's the AUS, FLUS, and suspicious for malignancy sometimes. These are the indeterminate cases, in indeterminate categories. So when it comes to ancillary techniques, they are not general malignancy testing. However, in 21st century medicine, everybody needs a clear-cut results, like pregnancy test. If there are 2 lines, the patient is pregnant. If there is only 1 line, patient is not pregnant. So it's very easy to understand. This is what we expect from the molecular testing. And if you look at the marketing and the advertisement, yes, the tests are being advertised as this. Is it negative or positive? Present or absent? Is it category 3 or 4? This is what we expect from any test in the 21st century. But what is the reality? Or expecting such a molecular testing in thyroid FNA, whose test performance is similar to pregnancy test, today is unrealistic, maybe in the future. So dreams versus reality. Dream, in every FNA case, for the indeterminate case, do a molecular testing, get the results about benign or malignant results. That's very good, right? In reality, instead of benign and malignant category, you get results like suspicious for malignancy, medullary carcinoma, whoever needs it, most likely benign, and the malignancy chance is 5%. So this is the dream, this is the reality. Or this is the dream, this is the reality. Okay. What kind of material is needed in ancillary methods? They are basically nucleic acid test, which is DNA and RNA. What do? They look for the point mutations, chromosomal aberrations, and they use also proteins. And what proteins for what? That they are the mutation-specific proteins, and they are being utilized in immunohistochemistry. And for last maybe decade, we are starting to hear another molecular method, which is the miRNA. What is the miRNA? It's the non-coding RNA, negative post-transcriptional regulators, and it's being used in any fields of medicine. Which methods are we using? The PCR, NGS, this is the next generation sequencing, FISH, and any other methods. Besides, there is good old immunohistochemistry. This is the mutation-specific immunohistochemistry. Which genes are important in the thyroid molecular studies, especially for diagnostic purposes? There are 7 genes. This is the RAS HKN, BRAF V600 mutation, PAX8, and RET PTC translocations. I was just Googling for a keyword to give you a reminder about the 7 genes. I wrote down the 7 genes in the Google, and it turns out 7 genes also a name of Japanese drama, which is very famous. And after this meeting, I'm gonna look online and watch it. This is just a reminder, the 7 genes. Okay, when it comes to ancillary method, what should we do for testing? Should we do it in every case or in specific categories? Answer is yes and no. It depends on your budget or on your country and on your institution. So in Bethesda system, indeterminate categories, if it's an AUS, FLUS, or NIPTP, if you can diagnose on cytology, that's okay. Not me, but the guy here is the Koray. He can diagnose it, not me. So you can do molecular testings, and molecular tests are being advised in this group. This is a category-based approach, which I like it very much. This is the FN or Tier 3 category. What is the Tier 3? Is this is the Italian system, which corresponds follicular neoplasia in the Bethesda system. So in this category, just be careful, okay? We are looking for a follicular carcinomas, not papillary carcinomas. So if you look at the literature, in follicular carcinoma, RAS is present in 50%, and the PAX8 PPAR is present in 30 to 40% of follicular carcinomas. So, and if you look at the overall performance of this category, then 30% of the cases malignant and 70% are benign non-followable. So it's very smart to do RAS testing and the PAX8 PPAR testing in this category. What does that mean? You look at the slides and you think it may be a follicular neoplasia, then RAS testing and the PAX8 or PPAR testing can give you some results. Okay, another category is the suspicious for malignancy, or Italian system is the TDIAP category. So that means we are looking for a papillary thyroid carcinoma, not anything else. So in papillary thyroid carcinoma, we know that about 100% of the cases has BRAF V600 mutation. So it's very wise to use this mutation, to look for mutation, and it's turned out positive. It's probably it's a carcinoma. However, if we add RET and PTC to the molecular testing, to just in case of the papillary carcinoma variants may be missed, so with these 2 tests, we can identify many of the carcinomas. Okay, there's another approach, which is the 7-gene panel. It's a rule-in test. That means if that test turns out to be positive, the patient needs surgery. So based on the cytological categorization, it should be an indeterminate category. Do a 7-gene panel test. And if any of the tests turn out to be positive, which called as mutation positive, then patient needs surgery. If it turns out that none of the 7 genes have any kind of mutation, so it's called as mutation negative, indeterminate case. So they are either being referred for lobectomy or being followed up. This is based on the 7-gene test based on the category of the thyroid FNA. Okay, and there is another miRNA-based assays. A specific type of miRNA, which is miRNA 375, is a powerful discriminator of the benign and malignant lesions. Yes, it's very powerful, but who has it? Application of single miRNA or a panel of MRI analysis just is limited to some university institutions or in the United States or some special commercial laboratories or another research institutions around the world. So as long as you are not a part of this process, it's unlikely you will have access to miRNA-based assays. Okay, so let's look at some practices around the world. In the United States, there are many tests, but the famous ones are Veracyte, Afirma, and the Chisel gave you some details. So this is an interesting test because a specific collection medium is required. Nucleic acid-based testings and miRNA expression levels are studied, and the results are given as benign and suspicious for malignancy. Very good rule-out test. That means if it turns out benign, patient does not need surgery. That's a rule-out test. In USA, there is a Rosetta and the Tyrosec, and Chisel gave you some details. In the Rosetta GX, results are given as benign, suspicious, or medullary carcinoma. In the Tyrosec, results are given as the cancer probability. And there's another company, which is the TIGENX7. This is the 7-gene panel. And they do 7G testing and the miRNA, and the results are given as mutation negative or mutated. So just to feel it better, stop here and look at their results. Just to give an example, these are the results. Okay. None of the tests give you the results as malignant, except for the medullary carcinoma. So this is probably because of the medical legal issues. They are not saying the patient has a malignant disease. They are really are careful. Okay, in Korea, there is another example. BRAF V600 mutation studies are covered in any social security system, so it is kind of routine. And the incidence of the red PTC translocations in thyroid carcinomas is different in this country from those in the other countries. So based on the Korean results, FNA alone, sensitivity is about 70%, FNA plus BRAF, and the sensitivity reaches about 90%. Okay, these are the information I can gather on the literature. So, yes, these are useful advanced techniques, but they are either expensive or unreachable. Does an alternative solution exist? Yes, we do have. What is it? Good old immunohistochemistry may offer some solutions, right? Good old days are back again. Okay, mutation-specific immunohistochemistry is another ancillary technique. Mutation-specific means any mutation results in a different protein. And if you look at this expression of this protein in the immunohistochemistry, then you can tell the cells has mutation or contains mutation or not. So this mutation-specific immunohistochemistry can be performed on cell blocks or any cytological smear. What are these? It's the BRAF V600 and the NRAS 61. They are the most extensively studied markers, and their results are highly correlated with their nucleic acid analysis. So this is the BRAF V600 mutation-specific immunohistochemistry. It's very easy to interpret, cheap to try. And the cost in Turkey is about 30, maybe not more than 50 euros. And you can get your results in 1 or 2 days. It's a very good rule-out test. That means if it's positive in any indeterminate FNA category, the case is most likely a carcinoma. Not a good rule-out test because, you know, all the participants in this lecture knows about the limitation of the immunohistochemistry. One day it's working, some days they are not, some problems. So you cannot rely on the negative results. But if it's positive, if it's undoubtedly positive, then you can rely. And this test is very useful for the papillary thyroid carcinoma variants also. A positive BRAF V600 immunostain should upgrade any category to upper level. What does that mean? Let's say the cytomorphologist thinking about a case maybe suspicious for malignancy, and if BRAF, if she can find a BRAF V600 positivity, then she can upgrade this lesion as a positive for malignancy. And this test can be done on cell blocks, liquid-based cytology on already stained FNA styles. This is the BRAF V600 mutation. This is pictures from the literature, Cancer Cytopathology, 2018. This is the cell block, and this is the BRAF V600 mutation immunohistochemistry, and this is the smear of the same case. And this is verified with the molecular testing. And if you look at the other correlations, you can just check with this article, which is very useful. Mutation-specific immunohistochemistry, we are continuing. This is the NRAS 61, and it's a funny name, right? So NRAS is the most common mutation in the RAS gene, and the 61 is the most common ones. Immunostain is sensitive and specific for this mutation. And this mutation has an interesting part because it's very common in follicular lesions, including follicular adenoma, carcinoma, NIFTP, follicular variant, papillary thyroid carcinoma. So if you are looking any case with follicular pattern, just think about this one. So it's a follicular neoplasia or FLUS category, just do it. If it's undoubtedly positive, the results are not reliable, and this is very good rule-in tests. That means if it turns out the positive, you can tell your surgeon, yeah, okay, just send this patient to the surgery. And you can use it in the AUS lesions if they have an architectural atypia. It's very good. So, conclusion. Are we ready for entering the new molecular diagnostic array? Yes, we should, because we are the drivers, not the technicians. So yes, if you have an interest in what's going on the engine of the car, it's up to you. But at least we know our limits and we know our where we can reach out. And diagnostic categories are changing. Endpoints of the diagnosis are shifting from benign malignant to the surgeries needed or not, rule in or rule out groups, or some percentages about the malignancy. And we have found something very interesting. After extensive use of molecular analysis, we learned that the genetic features of the same tumor vary among different countries. So it's like in Turkey, we have a saying, there is no disease, there is a patient. That means every disease in every patient differs. So probably the tumors like this and the genetic features of the papillary thyroid carcinomas in Korea is completely different from those in United States. And each country or each geographical location should have its own genetic information, molecular information, I think. And since molecular techniques are always being marketed as we are better than the pathological evaluations, it's too old. No, take my word for it. They will not perform better, not now, not in the future. At least, as a morphologist, we are ready to take the blame for our diagnosis. And what about the molecular techniques? Will they blame the DNA for their malpractice? Huh? What do you think? Okay, this is the conclusion of my speech, but just one. You remember the picture I showed you? I took it from literature, and something told me this picture is not complete. So this is the Artemisia, the painter with the goiter. And this is the real picture. I found it on the internet. This is the guy who raped her, Agostino Tassi. Okay, that's the end of my speech, and I'm expecting your contributions and questions. Thank you for listening to me.
Thank you, Haldun. Let's look to questions. And now there is no question yet. I can have a question.
Yes,
do you use molecular studies in thyroid cytopathology?
No, because first of all, first issue
or
is who's going to pay.
immunochemistry? Sorry?
We started to immunohistochemistry, but for the molecular diagnosis, main limitation is who's going to pay it. And it's expensive, and it's not covered with the insurances. And it's not easy to convince, since I'm working in a private institution, and it's not easy to convince the social security institution to cover all the prices. And it's expensive right now. Besides, it takes a lot of time. I do have some friends in molecular diagnostics, and it usually takes 45 days to get the results. Yes. And many of the patients does not agree with this waiting time.
Okay, one question now. I think, can you read the question?
Yes,
I can.
Yeah, it's a long question.
Yes,
okay.
Yes. Related with my previous question is another question. Formalin is being used worldwide for all tissue processing, and same process is followed for cell blocks processing. Can you please advise the alternative process flow steps of alternate chemical to overcome this problem that may damage the fish and molecular test results?
Yeah, this is the reason. Yeah, okay.
Yes.
Excuse
okay.
me. So this is the reason why all the genetics friends hates us. Okay, they don't like this idea. When you send the specimen to their genetic analysis or molecular diagnostics, they always just say, okay, if it's a formalin fixed, then we may not be saying something. So far, I think there are several chemical solutions which may be replaced the formalin fixation. And their limitation is, since the formalin also inactivates every kind of infectious disease, this novel fixative agents, we don't know if they can inactivate the viruses, microorganism, etc. So best thing is use formalin fixation as less as can be. That means if you need to do a cell block, just precipitate them, and then little bit, just half an hour fixation should be enough. So far, no commercially available solution exists in the market.
I agree with this attendee because formalin is universal fixative, and all pathologists are using formalin and a little bit alcohol for cytology slides, and we have no better choice.
Yeah,
yes.
But that's where the cytology takes place. Don't think about the cell blocks. Think about the already stained slides, or if you have an extra slides, you can do these testings on this slide because they are not fixed with the formalin.
But we can't use cytology slides every time. It's very limited. So we need cell blocks.
Yeah, we need cell blocks, but in our Congress, you may remember, we are trying to develop a method for destained cytological smears, and with a diamond pen, we just etch them, separate into two pieces, and then we can do immunohistochemistry on this slides.
We do every time this method. This is not a new method.
New, yes.
Yes.
Okay. And I think there is another questions.
Yes. Dr. Sıtkı Tuzlalı writes something. Other fixatives other than formalin cannot be used for metastatic breast lesions. Yes, I agree. This is also universal. Yes, I agree, Dr. Sıtkı. And AFA, Holland, etc. are not used. Yes, in lung cytology, it is all the same. And again, Javed Zaman, that can only be achieved by liquids-based fixation. Yes, we do cell blocks from liquid-based fixation, liquid-based cytology. And it is also very nice, and we can use them for molecular pathology also. This is useful. And Dr. Serpil Dizbaysak, formalin is perfectly usable for molecular studies. Overfixation is bad. Yes, I agree. It's also. And Tijana, do you ever use immunohistochemistry for BRAF V600 in cell blocks in suspicious for papillary carcinoma to confirm it?
Yeah, we are not using the cell blocks because we are not happy with the cell blocks, but sometimes we need to use the liquid-based preparations from thyroid for immunohistochemistry, not the cell blocks. And it's very good.
We use cell blocks. We use liquid-based cytology, and we do cell block from this liquid-based cytology, and then we can do everything, immunohistochemistry or molecular studies for BRAF. But BRAF immunohistochemistry is not very good. This is my opinion.
Yeah, okay.
Okay. Is there any question? Okay. Then we can go to second speaker. Our second speaker is Dr. Amera. But today, Dr. Amera cannot be with us because her uncle passed away yesterday. And so we will listen her lecture from records. Yes, please.
Good afternoon. My name is Amera Shadia, and I'm working as a nuclear medicine specialist in Clinical Center of University in Sarajevo. I'm going to talk about clinical approach to the thyroid nodules today. A thyroid nodule is an abnormal growth of thyroid cells that forms a lump within the thyroid gland. Definition of thyroid nodule by American Thyroid Association is discrete lesions within the thyroid gland, radiologically distinct from surrounding thyroid parenchyma. By age of 60, about 1/2 of all people have a thyroid nodule that can be found either through examination or with imaging. Incidence of thyroid nodule increases with age in women, in people with iodine deficiency, and after radiation exposure. Thyroid nodule prevalence is 2 to 6% with palpation, 19 to 35% with ultrasound, and 8 to 65% in autopsy data. Causes of nodule development are overgrowth of normal thyroid tissue, sometimes referred to as a thyroid adenoma. Thyroid cysts most commonly result from the generation of thyroid adenomas. Chronic inflammation of the thyroid Multinodular goiter often contains multiple distinct nodules, thyroid carcinoma, and iodine deficiency. Ultrasound is method of choice for evaluation of thyroid nodules, and it is the most accurate and cost-effective method for evaluating and observing thyroid nodules. Ultrasound features associated with malignancy are hypoechogenicity, microcalcifications, irregular margins, absent halo sign, solid aspect, intranodular vascularization, and shape, taller than wide. Ultrasound elastography, USE, is a powerful new diagnostic tool which assesses hardness as an indicator of malignancy in thyroid nodules. American guidelines of American Thyroid Associations for biopsy, according to US pattern, are benign pattern, which contain 0% of risk. Recommendation is no biopsy. Very low suspicion pattern, low than 3% of risk. Biopsy if nodule is equal or larger than 2 centimeters. Or you can observe by ultrasound. Low suspicion pattern, 5 to 10% of risk. Biopsy if nodule is larger or equal to 1.5 centimeter. Intermediate suspicion pattern, 10 to 20% of risk. Biopsy if nodule is larger or equal to 1 centimeter. High suspicion pattern, more than 70 to 90% of risk. Biopsy if nodule is equal or larger than 1 centimeter. Benign pattern, 0% of risk, are completely cystic nodules with well-defined walls. Very low suspicion pattern, lower than 3% of risk, are spongiform nodules and nodules with interspersed cystic spaces without any of the features in more suspicious patterns. Low suspicion pattern, 5 to 10% of risk are isoechoic or hyperechoic nodules, partially cystic nodules with the peripheral solid component and with none of the following features, which are microcalcifications, irregular margins, extrathyroidal extension, and taller than wide. Intermediate suspicion pattern carry a 10 to 20% of risk. These nodules are hypoechoic solid nodule with smooth margins. They have none of the following features: microcalcifications, irregular margins, extrathyroidal extension, and taller than wide. High suspicion pattern, more than 70 to 90% of risk. Nodules are solid hypoechoic or solid hypoechoic component over partially cystic nodes with at least one of these features, which are microcalcifications, irregular margins, which are infiltrative, microlobulated, then extrathyroidal extension, taller than wide, with ring calcifications with an exclusive soft tissue component, and of course, lymphadenopathy. Another ultrasound classification system for risk of thyroid carcinoma is EU-TRADS, which is reporting system designed by the European Thyroid Association for ultrasound assessment of thyroid nodules and stratification for fine needle aspiration and malignancy. EU-TRADS 1 is category, which refers to ultrasound examination where no thyroid nodule is found. Benign category, TRADS2, where risk of malignancy is close to 0%. This category includes two patterns. These are pure anechoic cysts or entirely spongiform nodules. This is ultrasound pattern of TRADS2. Low risk category, TRADS3, carry a risk of malignancy 2 to 4%. These nodules are oval shaped, smooth margins, isoechoic or hyperechoic without any feature of high risk. Nodules with these characteristics have a low risk of malignancy, and fine needle aspiration should usually be considered only for nodules larger than 20 millimeters. This is TRADS3 ultrasound pattern. Then intermediate risk category have an ultrasound pattern of nodules TRADS4, where risk of malignancy is 6 to 17%. These nodules are oval-shaped, mildly hypoechoic nodules with smooth margins and no high-risk features, and should be considered at intermediate risk of malignancy. Fine needle aspiration should usually be performed only for nodules which are larger than 15 millimeters. This is an example of TRADS4 ultrasound pattern. High-risk category, TRADS5, carry a risk of malignancy 26 to 87%. These nodules have at least one of the following high-risk features: non-oval shape, irregular margins, microcalcifications, and marked hypoechogenicity. All such nodules larger than 10 millimeters should undergo fine needle aspiration unless a patient is inoperable or has a low life expectancy from other comorbidities. In case of a first benign cytological result, fine needle aspiration should be repeated within 3 months to reduce the rate of false negative samples. This is an example of EU TRADS5 ultrasound pattern. Fine needle aspiration biopsy procedure is very safe procedure. It is typically performed under ultrasound guidance. Patient lying on back with head tipped backwards and neck extended. A pillow is placed under patient shoulders to get in the best position for the biopsy. It is obligatory to ask the patient to remain still and avoid coughing, talking, and swallowing during the biopsy. Risks which are very rare are bleeding at the biopsy site, infection, and damage to the structures near the thyroid. Procedure of fine needle aspiration biopsy is done with a thin, fine gauge needle attached to a syringe in a plastic or metal holder. Ultrasound is used to guide accurate placement of the needle within the thyroid nodule. After the sampling, the needle will be removed. New needles will be reinserted if eventually additional samples are required. This is the picture of fine needle aspiration procedure in our institution. Thyroid nodule cytology is usually reported using 6 diagnostic category system. outlined in the Bethesda system, and it is at present the most used system. Bethesda system for reporting thyroid cytopathology is divided in 6 categories, which are first non-diagnostic or unsatisfactory, benign, atypia of undetermined significance or follicular lesion of undetermined significance, follicular neoplasm or suspicious for a follicular neoplasm, suspicious for malignancy, and malignant. Fine needle aspiration biopsy cytology in 5 to 20% of cases is not possible to discriminate between benign and malignant nodules because of an indeterminate cytology, including follicular proliferation and atypia of undetermined significance. In 2 to 16% of cases, cytology is not diagnostic, or the material is insufficient for diagnosis, and it is very often that fine needle aspiration repetition is requested. As a minority, about 20% of indeterminate thyroid nodules has been proved to be malignant at fine histology, so a high proportion of these patients actually undergo diagnostic rather than curative thyroid surgery. So the need to improve the diagnostic performance of fine needle aspiration cytology in the setting of indeterminate results has led to the search for diagnostic biomarkers. So at the moment, several are recently introduced molecular tests such as gene expression classifier, gene mutational panel, targeted next generation sequencing, and hopefully to hear something new in the following, in this school actually. The combination of a mutation detection and mitochondrial RNA expression have been reported as promising in ruling in or out a substantial risk of cancer. So the future is molecular cytology diagnostic, molecular tests which resolve non-diagnostic cytologies, and this is regarded as an important goal for future research.
Thank you, Dr. Amera. We listened to her lecture, and I forgot to introduce her CV to you. She's specialist in nuclear medicine since 2009 at the Department of Nuclear Medicine and Endocrinology, Clinical Center, University of Sarajevo. She has particular interest in thyroid gland imaging and diagnostics, and she is a member of European Association of Nuclear Medicine and European Society for Hybrid Molecular and Translational Imaging. Thank you, Dr. Amera. And I am looking for questions. There's no question. And also she's not here. We can go on, and our third and last speaker is Dr. Koray Ceyhan from Ankara University. He's completed pathology residency in Ankara University School of Medicine in 1995, and also completed his cytopathology training in the same department in 2003. He has been working as cytopathologist for 18 years and at the same department. His major interest fields are nearly all fields of non-gynecological cytology and also molecular cytology. We will listen him and he will show nice cases to us. Yes, Dr. Koray Ceyhan, we are listening to you.
Hi, dear colleagues. I am Koray Ceyhan from Ankara University School of Medicine. I am also a professor in cytopathology section of Department of Pathology. Firstly, I would like to thank organization committee for their kind invitation. In this presentation, I am going to try to share some nice and challenging thyroid cases from our departmental archives. First case is a middle-aged woman underwent thyroidectomy due to PTC, admitted to the hospital for routine checkout. An FNA was performed from the thyroid bath due to suspicion of PTC recurrences. In these pictures, we can see some geometric elongated particles in a proteinous background, and also some multinucleated histiocytic cells around the material. Please note that there is no inflammatory reaction in these pictures. When we go to the cell block, same cytological features are seen in these pictures. We can see some elongated quadrangular laminated fragments, and also there are always proteinous background or exist in this slides. There is a little bit different cytology in this case. Okay. These elongated laminated fragments in the proteinous background, these features are consistent with oxidized cellulose reaction. Oxidized cellulose is a water-soluble cellulose derivative. It's a local hemostatic agent, such as namely surgical is well-known commercial blend, frequently used during the surgery in surgery bath for the hemostasis. Second case from a female patient with a thyroid nodule. In these pictures, a cellular smear showing syncytial cell growths mixed with crowded small follicles, and some rare single cells are seen, and cellular smear we can see. When we go to higher magnification, follicular cells are arranged in microfollicles with a little bit irregular borders, and also thyrocytes have subtle nuclear atypias such as mild nuclear enlargement, some nuclear growth, nuclear elongation, fine granular chromatin pattern, and a little bit nuclear membrane irregularity, and also chromatin clearing. Please note that there is no colloid, and also intranuclear pseudo inclusion are seen in this picture. And also there is no visible nucleolus. Another example of microfollicles showing irregular external borders, in particular in the slides, is very prominent, and also subtle nuclear atypia. Please note that there are some light and dark cells mixed together. Light cells reflecting a kind of chromatin, clearing chromatin pallor, and the prominent feature in this picture is microfollicles with irregular borders, not entirely circular. When we come to the sublog section, a sublog material shows a microfollicular pattern neoplasia. Immunohistochemical study with malignancy-related markers such as HPME1 strongly positive in the tumors, and also cytokeratin 19 shows focal positivity. Galactin 3 BRAF antibody is not positive. A molecular study with NGS was performed from the cytological smear for the further information the diagnosis. In this case, NRAS mutation, PQ81R mutation was found. This is a RAS-like mutation. RAS-like mutations are common in follicular pattern neoplasias. In particular, most common mutation is NRAS mutations, and most cases are NIFP or follicular variant papillary thyroid carcinoma case. So this case is highly suspicious for NIFP or follicular variant papillary thyroid carcinoma. Molecular and cytologic and immunohistochemical features are not consistent with a benign entity. When we go to the histological section, histologic diagnosis was non-invasive encapsulated follicular variant papillary thyroid carcinoma, namely NIFP. In this picture, we can see two different entity and also two different morphology. First is a malignant or borderline PTC-like neoplasia, like this, and irregular follicles with subtle nuclear atypia, and second one belong to follicular adenoma, totally different from two pictures. In this picture, follicles are nearly circular, small, and there is no cytological atypia, and PTC-like lesions shows heterogeneous chromatin pattern, dark and light and large cells are together. In contrast, in follicular adenoma, homogeneously dark stained cells, totally different, and also nearly circular lesion but irregular border, like this. Yes. Yes, this is NIFP, microfollicular, nearly microfollicular pattern lesion, no papillary architecture, no colloid or minimal colloid, focal septum nuclear atypia are characteristic features for the NIFP. Most cases are signed out as Ausfluss follicular neoplasia or suspicious for malignancy category in Bethesda system. Distinction from invasive follicular variant papillary thyroid carcinoma is very difficult. Malignant-related immunohistochemistry markers such as HPM1, CK19 are usually positive in NIFP, in contrast to follicular adenoma, and NG does not show this positivity. Invasive infiltrative follicular variant papillary carcinoma usually show significant nuclear atypia and also a significant intranuclear pseudo inclusions and microfollicular patterned lesions. Prominent nuclear atypia, in particular, SCOR3, and presence of intranuclear episode inclusion, and also immunohistochemically BRAF positivity or molecularly BRAF mutation, BRAF V600A mutation is strongly suggestive invasive follicular variant papillary carcinoma. These features are not consistent with NIFP or a benign lesion or follicular adenoma. Yes. Third case, this is from a 14-year-old child, patient with congenital hypothyroidism. Ultrasonography revealed multiple hypoechoic nodules with well-defined borders. FNA was performed from hypervascular dominant nodule with suspicion of follicular neoplasia. In these pictures, follicular cells are generally arranged in microfollicles, and some microfollicle complex imply trabecular arrangement, and there is an endothelial cells, capillary vessels among the follicles. Okay. In this picture, the presence of uniform circular microfollicles with smooth borders and microfollicle complex suggests this is a follicular neoplasia. Please note that colloid is absent and rare isolated atypical cells are also discerned with nuclear enlargement, and there is no significant cytological atypia in this cluster, only isolated atypical rare cells. Microfollicular and trabecular pattern were also observed in cell block material. And in immunohistochemistry, malignancy-related markers are negative in this case. HPM1, CK19, galactin-3, all of them were negative. But CD56 is positive. Presence of strong CD56 positivity excludes the PTC, whereas a negative staining is highly suggestive for non-PTC follicular nodules. Other malignancy-related markers have not high diagnostic value in distinguishing a follicular adenoma from follicular carcinoma or adenomatous nodules. Pathologic diagnosis of this case was dyshormonogenetic goiter. Dyshormonogenetic goiter is a pediatric disease associated with congenital hypothyroidism. It consists multiple adenomatous nodules mimicking a follicular neoplasia. Nodules may be in solid trabecular or microfollicular pattern. In this case, you can appreciate a follicular and trabecular pattern simulating follicular neoplasia, and internodular areas shows cytological atypia. Those are characteristic for dyshormonogenetic goiter. Internodular areas of dyshormonogenetic goiter atypical may show atypically isolated cells. However, in most cases, we cannot appreciate these cells in cytological smears. Another case, an elderly woman with Graves' disease admitted to the hospital for routine checkup. She was treated with an anti-thyroid drug metimazole. Through ultrasonography showing multiple nodules and an FNA was performed from suspicious nodule. In this picture, there is a significant cytological atypia in cell groups. Atypical cells are sparse and randomly dispersed, mixed with benign follicular cells. Pleomorphism is also evident in this picture, but I would like to pay your attention to the answer ratio. Answer ratio is not high, and also clean background, no colloid. And atypical cells is adjacent to benign follicular cell growth. This is a characteristic or consistent features for this entity. Oh, this picture a little bit different from others. Highly ugly looking cell groups suggestive and aggressive malignancy such as anaplastic carcinoma. We can see pleomorphic cell groups with high nuclear hyperchromacy, high significant nuclear enlargement, and mitotic figures, pleomorphic cells, suggestive and aggressive malignant tumor. It's questionable for a malignant tumor such as anaplastic carcinoma. Oh, another areas we can see scatter atypical cells mixed with coexist to benign follicular cells. This is reactive atypical cells in Graves' disease treated with methimazole. It's characteristic feature for this case, cytological atypia, significant cytological atypia. When we go to the subblock section, this is the atypical reparative approaches and also mitotic figures you can also appreciate. This kind of changes should not be confused with a malignant tumor. A benign cell cluster associated with or very close to atypical cells, a warning sign for a benign lesion, and clinical story is also important. This is the reparative atypia and Graves' disease treated with antithyroid drug methimazole. Same features may occur in Graves' disease or toxic nodular hyperplasia cases treated with radioactive iod treatment may be common. Reactive atypia may occur also in benign follicular nodules, adenomatous goiters. In these pictures, we can see another example of reactive atypia and benign follicular nodules, spindle shape, reactive atypical cells with prominent nuclear enlargement and anisokaryosis. Yet normal NC ratio, no hyperchromasia, and fine chromatin are characteristic features for reactive pathology. There are clearly benign follicular cells in this region, and atypical cells. These benign follicular cells are also very close to reparative cells, are highly typical for this pathology. This is an example of benign nuclear reactive atypia and Hürtel cells of Hashimoto thyroidosis, a well-known cytological appearance in Hashimoto thyroiditis. When we go to cell block, we can see the benign reaction Hürtel cell atypia in benign pathology. Oh, a little bit different. pathology in Hashimoto thyroiditis. In some chronic lymphocytic thyroiditis or Hashimoto thyroiditis case, some epithelial groups showing subtle nuclear atypia in the lymphocytic background. A little bit atypical appearance in cytology. Is it benign or malignant? It's questionable. When we look at the other cell clusters, follicular epithelial cell significant nuclear atypia reminding a papillary thyroid carcinoma, but there is no papillary architecture, there is no intranuclear pseudo-inclusion, and there's a background lymphoid population, somewhat questionable for papillary thyroid carcinoma. Most cases are classified as AUS in Bethesda classification. This atypia always problematic in cytopathology routine. Sometimes the cells may mistakenly rendered as suspicious for malignancy and may lead to unnecessary surgery. Irregular follicles with focal cytological atypia embedded in lymphocytic infiltrate is highly characteristic for this lesion. But sublocks look like a benign reactive atypia. In problematic case, sublock immunohistochemistry with malignancy-related markers may contribute to avoid a misdiagnosis. Some authors describe this cytologic change as follicular epithelial dysplasia, which is precancerous lesions for PTC. They claim that malignancy-related markers and also cyclin D1 positivity in most cases suggesting proneoplastic condition. Another case, an elderly woman presented with multiple mediastinal lymphadenopathies and a right lung mass. In her clinical history, she underwent thyroidectomy for thyroid cancer, and an EBAS FNA was performed from subcarinal and paratracheal lymph nodes, whether it is primary lung cancer or metastatic thyroid carcinoma. In cytology, a monotonous tumoral population forming cell cluster or syncytial aggregates are observed. Relatively uniform, round shape, hyperchromatic nucleated tumor cells are seen in these pictures. A monotonous, small to medium size round cells arranged in microfollicle-like structures. Single discohesive cells are scattered in background, and nuclear crowding, high NC ratio are very characteristic for this tumor. And please also note that PTC-like nucleus does not exist. In some slides, there are a rosette or acinar-like formation are discerned. There are small rosette-like arrangement, and single cells with bare nuclei are common features. Fragile cytoplasm, no colloid, a coarse chromatin, smooth round nuclear membranes. Remind us at first, is it an neuroendocrine tumor metastasis? Okay. In other areas of tumors, consists of cohesive cell clusters with traversing capillary vessels and also enveloping vessels. It reflects trabecular or insular pattern, insular arrangement. When we look at these pictures, we can see a small cluster is enveloped by an endothelial cells representing an insular pattern. Subblock material revealed an epithelial tumor with trabecular organization, and also in cytology you can see traversing vessels suggesting trabecular organization. And when we make the immunohistochemistry in subblock material, these cells are positive TTF1 and PAX8, showing thyroidal origin, and there is no neuroendocrine markers. So this is a metastatic polydifferentiated thyroid carcinoma. Polydifferentiated carcinoma diagnosis it's always very difficult. It's not easy because there is no well-established cytological criteria. A considerable degree of overlap with other follicular tumors are common problems. High cellularity, microfollicle-like pattern, small to medium size, monotonous round cells with hyperchromatic nuclei, high NC ratio, single atypical cells with bare nuclei are consistent features of poorly differentiated thyroid carcinoma. Necrosis and presence of mitosis, which is characteristic features of poorly differentiated carcinoma on histology, unfortunately uncommon features in cytology. In thyroid, in the differential diagnosis, solid variant of papillary thyroid carcinoma is important because in this tumors, trabecular and insular pattern may occur, but a retained PTC-like change in this pathology is helpful to reach correct diagnosis. We can see trabecular cell clusters with many traversing vessel suggesting a trabecular insular pattern, may confuse with poorly differentiated carcinoma, but cytological features are consistent with papillary thyroid carcinoma. So assessment of nuclear features is critical for the correct diagnosis. Another case is an elderly male with a non-small cell carcinoma admitted to the hospital for routine checkout. A PET scan revealed a multiple thyroid nodule with high Sumax values. Final aspiration performed from one of the pathologic nodules with high Sumax value for suspicion of lung cancer metastasis. Oh, it's a similar case to previous tumor. A follicle-like arrangement, monotonous tumor cell population, hyperchromatic tumor cell with round nuclei, medium-sized tumor cells, in particular coarse chromatin resembling salt and pepper-like chromatin pattern suggesting a neuroendocrine tumor, and also corresponding subblock solid tumoral infiltration monotonous. Yes, when we go to immunocytochemistry from cell block, Yes, this is the metastatic atypical carcinoid tumor to the thyroid gland. TTFM positive, both of neuroendocrine tumors or thyroid. Sorry. TTFM focally positive in this tumor. It does not prove thyroidal origin, and also Paxate negative, and neuroendocrine markers strongly positive, and calcitonin and carcinoembryonic antigen is also negative, which is characteristic for a medullary carcinoma. So this is the metastatic atypical carcinoid tumor from lung to the thyroid. Another case, 56-year-old male with a thyroid nodule with irregular emergence involving thyroid lymph node. This is relatively easy case because cytological features are very characteristic, I think. Isolated plasmacytoid tumor cells with abundant granular cytoplasm. Some tumor cells have binucleated, multinucleated, and granular metachromatic material are easily discerned. Tumor cells have always excentric placement, leading to plasmacytoid appearance, and also pale abundant cytoplasm with significant metachromatic granules, salt and pepper pattern, chromatin pattern, coarse chromatin pattern, also characteristic features of this tumor, and binucleation is common feature. So this is the medullary thyroid carcinoma, but morphology a little bit different. Look like an oncocytic tumor corresponding cell block showing an oncocytic lesion, but cytology is highly characteristic for medullary thyroid carcinoma, which has consisted of metachromatic cytoplasmic metachromatic granules, plasmacytoid, eccentric nuclei. Binucleation is very typical for medullary thyroid carcinoma, and subblock material verified the diagnosis: calcitonin, always positive, chromogranin, synaptophysin, and CD56 positive, and also Paxate positive, reflecting thyroidal origin. This is the classical form of medullary thyroid carcinoma, typical monomorphic plasmacytoid cell with abundant granular cytoplasm, and also salt and pepper chromatin pattern. And in some case, dense colloid-like basophilic material reflecting amyloid accumulation is also characteristic for this tumor. In some case, medullary carcinoma may contain some ugly-looking giant cells, suggesting an anaplastic tumor in this picture, like this. But a classical form of plasmacytoid cells and significant, well-illustrated cytoplasmic metachromatic granules in giant cell are helpful features for the correct diagnosis. Another pattern is medullary carcinoma is spindle cell morphology. Spindle cell morphology may be confused with sarcomatous tumor involving thyroid gland or rare primary thyroid sarcoma, spindle cell sarcomas. Uniform spindle cell population, absence of significant nuclear ATP and characteristic chromatin pattern are distinctive for the features of medullary carcinoma. And also blood calcitonin level or measuring calcitonin level in needle washout may contribute the diagnosis. This case from an elderly woman with newly developed mediastinal lymphadenopathies and multiple lung masses. In clinical history, she underwent a total thyroidectomy for Hertel cell thyroid carcinoma 3 years ago, and EBUS FNA was performed from subcarinal and hilar lymphadenopathies to verify metastatic disease. In this picture, as you can see, there are some tumor clusters showing oncocytic morphology with significant macronucleoli is evident in this tumor. Follicular-like architecture, medium-sized hyperchromatic round nuclei, basophilic, significant nucleoli, macronucleoli, and oncocytic granular cytoplasm, follicular architecture are typical for Hertel cell neoplasia. This is obviously metastatic Hertel cell carcinoma. And cell blocks verify the metastatic diagnosis, PAX8 and also TTF1 positive for this case. So the cytological features are consistent with metastatic Hertel cell carcinoma. So this is a relatively easy case. If you remember the cytologic features of benign oncocytic lesion, we can appreciate a polygonal, loosely cohesive cells with abundant granular cytoplasm and medium size central or paracentral, maybe eccentric placed nuclei, small nucleoli, not macronucleoli, are characteristic features for typical benign or well-differentiated Hertel cell neoplasia. And also, we can appreciate richly vascular network, capillary vessels among the oncocytic cells. Those are highly characteristic for neoplasia, not benign follicular with Hertel cell metaplasia. Presence of vascular organization should strongly suggest neoplasia, Hertel cell neoplasia, and corresponding cell blocks show the Hertel cell lesion. Another Hertel cell lesion. Some popular thyroid carcinoma may be confused with Hertel cell neoplasia. It's classical form oncocytic variant of papillary thyroid carcinoma. However, characteristic nuclear features of these lesions are retained and also helpful features for PTC diagnosis. You can see intranuclear pseudo inclusion is diagnostic of papillary thyroid carcinoma, and oncocytic cytoplasm and oncocytic cell clusters are seen here. Another example of oncocytic variant of papillary carcinoma, easily seen intranuclear pseudo inclusion, are helpful features, and also nuclear irregularity, some nuclear grooves, nuclear membrane irregularity, overlapping are other characteristic features of papillary thyroid carcinoma, and corresponding subblock is also helpful to reach correct diagnosis, and oncocytic appearance is evident in this tumor. Total variant of PTC is another oncocytoid tumor. In this picture, as you can see, tumor cells are at least 2 to 3 times as tall as their weight. You can see the tall cells, and also tall cells with abundant elongated tail-like oncocytoid cytoplasm. They contain is characteristic for this tumor. And tall columnar cells with tail-like cytoplasmic elongations like this are very helpful features for tall cell variant. And in cell block, histology neoplastic cells are arranged in linear fashion like a railroad track is another characteristic feature of this entity. One more oncocytoid tumor is hobnail pattern or hobnail variant. PTC is another oncocytoid tumor. In this tumor, there are loosely cohesive cells with loss of their polarity. There is an oncocytic cell group with teardrop cytoplasm and eccentric nucleus is characteristic for hobnail appearance. It's a very rare entity in thyroid cytology. Okay, one more oncocytic case. A female with underwent thyroidectomy for PTC and a hypoechoic well-defined small nodules in the left thyroid bed. It's important whether it is PTC recurrence or not, or suturagranuloma or granulation tissue. Major clinical diagnosis in this case. We are going on oncocytic lesions. In these pictures, large syncytial cell clusters showing oncocytoid morphology are seen. Please note that no colloid in the background. The tumor has loosely cohesive follicular cells, some isolated naked nuclei cells, and clearly evident that tumor has complex vascular pattern like a follicular neoplasia. Okay, this is a parathyroid lesion, parathyroid adenoma. When we go to the cell block, we can see parathyroid lesion and also characteristic immunohistochemistry from cell block or CM parathormone antibody strongly positive, also neuroendocrine markers, chromogranina, and also synaptophysin and CD56 was also positive. Another case, a young lady with multiple colonic polyps. A hypoic non-vascular thyroid nodule she has at the left thyroid lobe. In these pictures, as you can see, large cell clusters form a slit-like empty space, and some large papillary-like structures are seen. In another pictures, tumor cell clusters showing cribriform like holes, anastomosing bars, and also another cribriform structure easily seen. And arrows point out some swirling areas. In these pictures, you can see some eddy formation, a swirling pattern in cell cluster mimicking squamous cell accumulation. Squamous cell metaplasia may be reflecting morus are observed. In the slice of the tumor, there are tall columnar tumor cells, and these cells have tail-like cytoplasmic elongations like Tosser variant papillary thyroid carcinoma at periphery, but with low NC ratio, and there is no characteristic features of papillary carcinoma. There is no much more intranuclear inclusion or papillary thyroid carcinoma typical features. One more distinctive features of this entity is cytoplasmic lipid accumulation in TOSAs with cytoplasmic elongations. Another features of this tumor, a very polymorphic morphology seen in this tumor, pseudostratified columnar cells make palisating effect, and also pseudostratification mimicking colonic adenocarcinoma metastasis, but dirty necrosis does not exist, characteristic for colonic carcinoma. So this is the pathology. This is cribriform Muller variant of PTC, and also its characteristic immunohistochemistry. This tumor always positive for beta-catenin nuclear plus cytoplasmic, and also estrogen receptor, and CD6 positivity in morus, not in tumor cells. This case from a 14-year-old male patient with multiple lytic bone lesions, and also some PET-positive lesions in both thyroid lobes and lungs. Thyroid ultrasonography revealed multiple ill-defined patchy lesions in the thyroid gland. In these pictures, a polymorphic cell population are seen. Medium-sized mononucleated cells with multinucleated histiocytic cells and some eosinophils. In the background, multinucleated cells, eosinophils, as you can see. And mononucleated cells with abundant pale cytoplasm, some nuclear folding, and very significant nuclear irregularity reminiscent of Langerhans cells. And also there are some eosinophil leukocytes in the background, and some rare lymphocytes, multinucleated joint cells are seen. So this is the corresponding cell block, including many histiocytic cells and also associated with many eosinophils, and immunohistochemistry from cell block verified the Langerhans histiocytosis with S100 CD1A and Langerin positivity. In this case, a molecular study with NGS was performed from thyroid FNA smears for the targeted therapies. Unexpected common BRAF V600E mutation was not detected, but a rarely seen mutation, BRAF indel mutation, was found.
Okay. Thank you, Dr. Koray, Ceyhan, for your comprehensive presentation. I'm amazed. They are
Deniz
very
Hocam,
impressive.
bölüyorum. Birkaç slide kaldı. Hemen onları da açacağım. Bir kapandı.
Okay.
Değil.
Okay. Okay.
It's important that cases with BRAF indel mutation are good candidates for some other alternative targeted therapies for MAC inhibitors such as trametinib. This case was also treated with trametinib as an alternative to classical vinblastine plus prednisone standard chemotherapy. Yes, this is my last case. Middle-aged female patient and newly diagnosed with breast carcinoma admitted to the hospital for routine checkout. PET scan revealed thyroid nodule with high Somax value, and thyroid ultrasonography shows a hypoechoic central vascular nodule with smooth borders, suspicion of follicular neoplasia or breast carcinoma metastasis. In this picture, as you can see, there are oncocytic cell groups and clean background, relatively uniform oncocytic cells arranged in small clusters or follicle-like sheets. So they are highly suggestive for HER2 cell neoplasia. Dispersed HER2 cells and small cell groups are seen in this picture, but I would like to pay your attention to these ugly looking cells at the upper part of the picture. When we get higher magnification, we can see the better these atypical cells. Yes. So in other areas of smears, clearly malignant cell groups are seen without any HER2 cell morphology. Subblock is very illustrative because there are two type tumor population in this case. A HER2 cell lesion, a HER2 cell tumor are seen here, and a different tumor population does exist here, a small cell population and other different small cell clusters, which is not consistent with HER2 cell neoplasia or HER2 cell morphology. Subblock immunohistochemistry show us a thyroglobulin was positive in HER2 cell, but these tumor cell clusters were negative for thyroglobulin. So these small tumor cells were also positive for GATA3 estrogen receptor and also progesterone receptor, reflecting breast carcinoma metastasis. So this is a breast carcinoma metastasized to thyroid, metastasized to HER2 cell neoplasia in thyroid gland. So this is a sort of tumor-to-tumor metastasis. Tumor-to-tumor metastasis exceedingly rare entity, known as a kind of collision tumor, a primary malignant tumor donor metastasized to another recipient tumor. Most common malignant tumor is renal cell carcinoma. Most common recipient is meningioma. But in thyroid gland, most common recipient is follicular adenoma or papillary thyroid carcinoma, while most common donor tumors come from renal cell carcinoma, lung carcinoma, breast carcinoma, and also colonic adenocarcinoma. This was my last slide. I am so sorry running out of time. I would like to thank you for your attention and patience. See you later.
Sorry, this is really thanks. Don't forget to vote. Dr. Koray, thank you very much for your comprehensive presentation. Your cases are very impressive and interesting. And we had questions, but you answered during your presentation, and there were comments and thanks, and you see them also. Do you want to say anything else?
Oh, thank you so much for everything. I hope it would be joyful for the audience. I had so many cases, but I have a limited time. So I skipped another interesting case, such as lymphomas and also anaplastic carcinoma metastasis. I had to skip. I hope I will present in the future. Thank you for everything.
They all thank you also for your presentation. And I want to thank to all speakers for their nice presentations. To attendees, I want to thank to attendees for their participants. And special thanks to Dr. Sıtkı, Dr. Semir, and Dr. Faruk. They spend a lot of effort for this meeting to make it traditional, and I think I'm sure they succeed this. And I want to invite Dr. Semir to close this meeting also. Yes, Dr. Semir.
Thank you.
And
thank
also
you.
Dr.
Thank you, Deniz, and thank you all Turkish colleagues and friends for making this event not only possible, but to make it great as it was, I believe. And the evidence is that we still have nearly 150 people around, which is very good sign,
Yes.
you know. So
Yes.
really, I appreciate very much all the efforts from the organizers from both sides, and certainly to our great speakers, 8 total. And I think they all made this event to be great. And let's keep this tradition, and let's hope to have the next one face to face in 22.
I hope so.
Yeah, but still, I think this worked pretty well. Apart from social dimension, the rest was really good. I enjoyed it. So once again, thank you, everybody. And just a brief information to participants: they will get all certificates. All those that attended the meeting, they will receive the certificates. Thank you very much again.
Will it be, Semir, will it be possible for them to reach the records of this meetings?
Yeah, I think we should make it somehow possible. You know, let's see with the organizer, with these optimist tourism, if they can provide it, and so we can post the link somewhere on the website. I
For
think
some
that
time,
should be possible.
maybe. Okay.
Yeah, I think that should be possible, and people will like it. So yeah, why not? Yeah, I think it was all recorded. The recording is still ongoing. So even this one is recording, Sitki, so be careful.
Yeah. No, I am not nude.
I know. Thank you, guys, and it was really great pleasure to be all together today.
Thank you.
Thank you, and keep in touch. Wish you a good evening and a good
Thanks
rest
a
of the
lot.
year as well.
For you too.
Okay. Thank you again. All the best.
Thank
Thank
you.
you.
Bye. Thank
Bye
you.
bye.
The attendees.
Bye.
Bye.